صباح الخير.
بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد صلى الله عليه وسلم وعلى صحبه أجمعين. Hello everyone and welcome to today's symposium, which is part of the ongoing academic activities of our Sudanese Society for Breast Imaging. Since our establishment in 2018, we have been dedicated to early breast cancer detection in our beloved country, Sudan. Over the years, we have worked closely with the healthcare institutions, voluntary organizations, universities, and other specialties to ensure that patients receive timely diagnosis and appropriate treatment. Despite the challenges brought by the war in our country, Sudan, our commitment to this mission has never wavered. Last year, we resumed our efforts by organizing free clinics in safe areas and continuing our scientific activities remotely. Today's symposium is particularly special as it is held in collaboration with the Egyptian Society of Breast Imaging, a distinguished organization that has made significant contributions to breast imaging and cancer detection across the region. Their expertise and unwavering support are invaluable to us, and we are truly honored to have them as partners on this journey. With that, I extend my warm welcome to our esteemed colleagues. Now, please allow me to take a moment to recognize and warmly welcome a truly inspirational figure in Sudanese radiology, someone who has been guiding force for generations of radiologists in our country. It is my great honor to introduce Professor Abdullah Jabir, FRCR consultant radiologist, president of the Sudan Medical Specialization Board, Radiology Board, and president of the Sudanese Association of Radiologists. Professor Jabir is more than a leader. His dedication and mentorship have left an indelible mark in our profession. Please join me in welcoming Professor Abdullah Jabir.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين. معكم السلام عليكم ورحمة الله وبركاته.
وعليكم السلام
وعليكم السلام ورحمة الله وبركاته يا بوس.
أهلا بالحلوين، كيف أخباركم؟
الله يعطيك العافية.
Today I'm honored. بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين. Today I'm honored to open this symposium, and I'm very proud of our society. It is very active and unwavering. As I said, they are fighting this disease by contributing by lectures, tutorials, and on hand-on sessions. I hope for this symposium, which is being held together with the Egyptian Society, to push and improve the service which is presented to our ladies, and to help in fighting this disease. I wish you very good time, enjoyable time, and I have to congratulate Dr. Rabab for the effort she is doing and helping. Before I finish, I will really appreciate the Hania Center, which has helped us during this war to educate, to train some of our radiologists, and that was a very helpful gesture from Hania Hospital. Thank you all for coming, and I would like you to enjoy this session. Thank you very much.
بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Thank you very much, Prof. Abdullah, for your presence today and your presence every time during all our activities. Thank you very much for your continuous and unlimited support throughout our journey in Sudanese Society for Breast Imaging. On behalf of the Sudanese Society for Breast Imaging, it is my great pleasure and honor to welcome this esteemed gathering in our in all your distinguished positions. We are truly proud and delighted to have among us the esteemed colleagues from the Egyptian Society for Breast Imaging who are joining us in today's symposium. And it is not the first participation, and we have previously honored by the participation of Prof. Rasha Kamal and Dr. Merit in many previous activities. And we are looking forward for further cooperation and coordination between the two societies in all upcoming scientific activities and academic events, inshallah. Now I'm delighted to introduce Prof. Rasha Kamal for the first session. Professor Rasha Kamal is a professor of radiology. She is the head of the Women's Imaging Unit in Cairo University Hospital. She is the honored president of the Egyptian Society of Breast Imaging. She is a senior breast imaging consultant at Bahia Foundation for Early Detection of Breast Cancer and Treatment. She is going to speak about DCIS, what does radiologist add to the breast cancer board. You are welcome, Prof. Rasha, and you can start your session.
Yes, Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank you all for this kind invitation. And thank you, Dr. Abdullah, Dr. Rabab, I'm afraid to say names so that I don't forget anybody. But we are really looking forwards for more collaboration between the Sudanese Breast Imaging Society and the Egyptian. We have so many things in common to share. So I think our collaboration will really add to the field of breast imaging. My lecture today is about the role of the radiologist in the breast cancer tumor board. I will discuss this from the perspective of DCIS, which is ductal carcinoma in situ. What do we add by our presence in the breast cancer tumor board? Many radiologists look at breast cancer from a very narrow point of view. When we get a patient, whether asymptomatic for screening or symptomatic patient, we do the required examination, and then we write in the report whether this patient has a benign or a malignant breast lesions. And maybe some of us will follow up the patient, and we will think that the end of the story is to find out if the pathology report, if we have taken a biopsy, or if the patient is followed up, if whether she has a benign or a malignant, just to see what we have written is right or wrong. But actually, where we think as radiologists that the story ends is exactly where the story starts. Definitely, we begin to learn wisely when we're willing to see the world from other people's perspectives. And this happens to us as breast imaging radiologists when we start sitting in breast cancer tumor boards, when we start dealing with our colleagues in the oncology and in the surgery department. We have a different perspective of breast cancer, not like before sitting in these breast cancer tumor boards. And I always find it an opportunity to thank my colleagues both in the breast cancer tumor board in Qasr Al Aini Hospital, Cairo University Hospital, and Bahia Breast Cancer Hospital, because definitely I have learned so much from sitting with them in these boards. In this lecture, we are going to discuss, to understand DCIS from the perspective of a breast imaging radiologist attending the multidisciplinary team. We're first going to discuss the pathological background of DCIS and how it is different from invasive cancer. Then we are going to understand how we characterize calcifications, because we all know that most DCIS present with calcifications. Then we will discuss what should breast imaging radiologists know more about DCIS. Then when we're sitting in the breast cancer tumor boards, we and the pathologists, we usually introduce our results, and then we start discussing our results are concordant or discordant, and we're going to see the different situations of pathology and radiology concordance and discordance. And lastly, we will try to give a hint of how do referring clinicians want us as radiologists to report DCIS. And while answering each of these questions, we are going to give some common clinical scenarios that we commonly meet in the multidisciplinary team. And we'll start by having a look on the background of DCIS and how it is different from invasive cancer. And to understand DCIS, we must have a look on the cross-section in the mammary ductal system, where it is lined from inside to outside by the luminal epithelium, which is this layer of cells. This is followed by the myoepithelial cells, which are this red line, and then the basement membrane. This is the normal duct. If the cells lining the duct proliferate, but they maintain the shape and the distribution of the cells, then we have what is called as typical duct hyperplasia. It's just a variant from the normal. But if this proliferation doesn't keep the arrangement of the cells, and the cells show a little change, but with no malignancy seen, especially in the nuclei, then we have what is called the atypical ductal hyperplasia. And as you notice here, the atypical ductal hyperplasia does not involve the whole circumference of the duct. Because if it involves the whole circumference of the duct and we see some changes in the nuclei and the number is more than what we see in the atypical ductal hyperplasia, then we will have here the ductal carcinoma in situ. And if the ductal carcinoma in situ decides to penetrate the myoepithelial cells or the basement membrane, then we have the true invasive cancer. So if we look at carcinoma in situ and we want to define it, we will say that it is characterized by proliferation of malignant epithelial cells lining the terminal duct lobular unit without histologic evidence of invasion through the myoepithelial layer or the basement membrane. And only approximately 30 to 50% of carcinoma in situ will progress to invasive cancer, but we can never know which of these carcinomas will progress. And that's why it is we should remove all carcinomas in situ discovered in the breast. And you will find that while sitting in the breast tumor board, the pathologist will say that this is a carcinoma in situ, and we did myoepithelial markers, as you see here, and these myoepithelial markers are essential to ensure that the myoepithelial cells are intact all through the ducts, so that they ensure that there is no infiltration outside the duct. From the surgeon's perspective, carcinoma in situ is different because he is not justified to do axillary dissection unless he is going to remove the whole breast. He is allowed to make a sentinel lymph node biopsy in this case only. Also, extensive surgery is reserved for locally advanced lesions, which are more than 5 centimeters, but this has to be correlated with the size of the breast for multicentric disease and for the diffuse ductal carcinoma in situ. There is also, from the perspective of the surgeon, controversy regarding the optimal margin width for ductal carcinoma in situ, and this controversy has existed through decades. But the current consensus guidelines published recommend a margin threshold of 2 millimeters for DCIS, and that means when we remove the DCIS, we should see a margin of 2 millimeters around the DCIS to say that we have negative margins. From the perspective of the oncologist, there are also some things different for carcinoma in situ. You will see that also in the tumor board. When we have a diagnosis of ductal carcinoma in situ, immediately the oncologist will ask us if she is ER positive or negative. If she is positive, then she will follow up in the oncology department because she will receive tamoxifen or aromatase inhibitors. We will also see some different scenarios for the carcinoma in situ. We might have a pure carcinoma in situ, and we might have a DCIS which states that there is microinvasion. A microinvasion is defined as no invasive focus larger than 1 millimeter. The pathologist should ensure that there is no invasion more than 1 millimeter. In this case, this DCIS will remain to be treated as in the normal DCIS, so long as the invasion is not more than 1 millimeter. So this patient will be managed as a pure DCIS. But there is a third scenario that we find that there is a combination of DCIS with invasive component, or they would write invasive carcinoma with DCIS. And in this case, we just ignore the word DCIS and the patient is managed according to the invasive component of the tumor. So we have three scenarios: pure DCIS, DCIS with microinvasion, which remains to be treated as DCIS. But if they say that there is a DCIS with invasive component, then it's no more a DCIS, or it's no more managed as a DCIS, and it will be managed as an invasive cancer. From the perspective of the pathologist, the classification of ductal carcinoma in situ has we can classify it according to two different aspects. One of them is the nuclear grade, and according to this, they classify carcinoma in situ into low grade, intermediate grade, and high grade. And it also can be classified according to the architecture, or how these proliferating cells fill the duct. We have the comedo, the cribriform, the micropapillary, the papillary, and the solid. And the worst of all is the comedo type, which is very poorly differentiated. So now we have taken an idea about the pathological background of DCIS and how it is different from invasive cancer, and we will proceed one step forward and try to characterize calcifications. To characterize breast calcifications, we should describe both the morphology and the distribution. For the morphology, we have either benign or suspicious calcifications. Under the benign, we have a long list of benign calcifications, and there is one common feature which combines all these types of benign calcifications, and that is that they are all macro calcifications. Under the suspicious also, we have a long list, and with the exception of the coarse heterogeneous, there is also one feature which combines them, and that these are micro calcifications. For the distribution, we might have a diffuse calcification involving most of the breast, a regional calcification which occupies a large area, which is more than a quadrant and not necessarily directed towards the nipple. The segmental is a part of the breast, or taking spreading along the ramification of a duct, so it is pointed towards the nipple, the linear branching, and lastly we have the grouped calcification, which we used to call the cluster calcification. And going from the benign, from the diffuse to the grouped calcification, we are moving from benign to malignant calcification. We're going to see now some common clinical scenarios. This was a female patient, a screening mammogram of a 55-year-old female, and she had bilateral rod-shaped calcification, and these calcifications are typical for plasma cell mastitis. But there was something more in the right breast. There was this group of grouped microcalcifications, and to see this group, if I go back, you won't see it. To see this group of microcalcifications, we have to magnify, which means that we are now dealing with micro and not macro calcifications. Adjacent to these microcalcifications, this is the rod-shaped calcifications. They are characteristic for plasma cell mastitis, and this is vascular calcification. These calcifications were on a background of a focal asymmetry. And again, if we go one step, this is the focal asymmetry with the microcalcification. So here, suspicion has been raised, and it was biopsied, and it came back, the biopsy report came back with a low-grade DCIS. If we think it might be, yes, fitting with the low-grade DCIS, but for me, it was not acceptable at all. And this not acceptable because if we look at the mediolateral oblique view, we will find that we have pathological lymph nodes, which were further proved by a complementary ultrasound. And in this case, when we have a pathology stating DCIS and pathological axillary lymph nodes in the tumor board, you should, as a radiologist, recommend for a lymph node biopsy. And actually, the lymph node biopsy was performed, and it came back with a metastatic axillary lymph node. And DCIS can never send metastasis to the axillary lymph nodes. It's a locally malignant tumor. So in this case, we recommended for excision of the mass and axillary dissection. And actually, the true pathology after removing the whole lesion was a mixed invasive duct carcinoma and DCIS, which makes sense that we see a picture which suggests DCIS, but it is associated with pathological axillary lymph node. This is another case. Again, we cannot see anything inside the breast unless we magnify. In this area, there was a grouped microcalcification, and again, you would never see it except if we magnify. Now we see how subtle these calcifications, but they are calcifications taking a distribution. And in a while, we will say that any calcification in the breast taking a specific distribution should be taken seriously. Both in the CC and in the mediolateral oblique view, it was taking a linear branching calcification. They were biopsied, and when the calcifications are subtle, it is better to do this using vacuum-assisted biopsy. And whenever you take a biopsy, you should document that the calcifications were removed in the biopsy by imaging your specimen. And the pathology came with an intermediate grade DCIS. Now we'll move another step, and we will try to see what should breast imaging radiologists know more about DCIS. If you ask any radiologist, even not, those not working with breast imaging, oncologist or surgeon, if you ask him about the DCIS, he will tell you that DCIS equals microcalcifications. And usually cases presenting to the radiology department with DCIS, they usually are asymptomatic patients discovered in screening units, or they are symptomatic patients discovered in the outpatient clinics. And usually these patients come complaining of nipple discharge, which is unilateral, uniorificial, spontaneous, bloody nipple discharge. And a few cases will come also complaining of a palpable mass lesion. And as I was just saying, the vast majority of mammography detected DCIS manifests as coarse, heterogeneous, fine pleomorphic microcalcifications, either taking a group pattern or taking a segmental distribution, which means that they are following the ramification of the retroareolar ducts. And I told you this is what is most radiologists know about DCIS, is that it is equal to microcalcifications. But what we should know more about the DCIS is that this calcification is not always as evident as it was in these two cases. Sometimes we have very subtle calcifications. It might be very subtle calcifications, like in this case, we might even ignore this calcification, saying it's just mild calcification. But again, any calcification taking a distribution should be taken seriously. And this case, when we see the magnified view, a biopsy was performed, and imagine that this was a high-grade DCIS. So please keep in mind, any calcification taking a distribution should be biopsied. What also we should know more is that less commonly, about 10 to 25% of DCIS appears as a non-calcified asymmetry. This decreases the sensitivity and specificity of mammography. Maybe in this case, because the breast is fatty, we can see this focal asymmetry or an area of subtle parenchymal distortion. But if we imagine that this breast is a dense breast, it would have been very difficult to identify this DCIS. And this is the contrast mammogram. See how much the subtle, it takes very faint enhancement. So it is always difficult to diagnose non-calcified DCIS. This is a faintly enhancing non-calcified DCIS. Much less commonly, DCIS might appear as a non-calcified mass, like in this case, it was a tiny mass. We biopsied it, and it turned out to be an intermediate grade DCIS. What we also should know that multiple lesions can occur in the same breast and in the contralateral breast as well. You will find the pathologist saying that it is common that we see skip lesions in DCIS, and that means we can remove a lesion with a good safety margin, but there would be another lesion in the breast away from the original mass, and this is common with DCIS to find skip lesions within the breast. Like in this case, we have an evident asymmetry in the upper outer quadrant, and this asymmetry showed microcalcifications which further raised the suspicion. It was biopsied and it was a DCIS, but please avoid the happy eye syndrome and always magnify to see the rest of the breast. And on doing so, we saw another group of microcalcification in the inner quadrant away from the mass. If we would have removed this mass, it would have been removed with a good safety margin, but we would have missed this tiny group of microcalcifications seen in the inner breast quadrant. So this was a case of multicentric DCIS, and I think the management would be totally different if we have a single group from a multicentric DCIS. This is another case which shows that DCIS might accompany also invasive cancer. Again, in the same lesion, in the same breast, in another site, or in the other breast. This case, we have an evident mass in the upper outer quadrant, and when we magnify, we see that this mass shows microcalcifications. We can never stop at this stage, because as we go back here, the breast is a dense breast, and we can never exclude the presence of other lesions in the breast. So we decided to perform contrast mammogram, and again, the contrast mammogram, this was the original lesion, but there were two additional lesions which were not evident on the mammogram of this patient. And as we see here, the pathology comes with both a DCIS together with invasive cancer. As we have been saying, that microcalcifications are mainly seen on mammography, and that is why most DCIS cases are detected on mammograms. But the question is, how do we see microcalcifications on ultrasound? And the answer is yes. Even we have some applications on some machines in specific genders which show the microcalcifications as shining points within the breast. We can see them whether inside the duct or outside the duct, but when they are inside the duct, they raise suspicion or even higher than outside the duct. As we see here, we have an intraductal mass which shows microcalcifications, and whenever we see this appearance, we should apply the Doppler, and now we see that this mass is also highly vascular, and this was a case also of a DCIS. But what if DCIS are non-calcified? Could we still identify them on ultrasound? And again, the answer is yes. A non-calcified DCIS may appear as a non-mass hypoechoic area in the ultrasound examination, and sometimes they appear as duct, which appears to be filled with an echogenic material, and when we apply the Doppler, we see that this echogenic material shows vascularity, and this is very specific for DCIS. In spite of what we have been saying about mammography and on ultrasound, still MRI is the modality of choice to assess a lesion extension. Whenever we have a case diagnosed with DCIS, we should do an MRI, or we should do, especially if the patient has a dense breast, or we should do, to a lesser extent, the contrast mammography. Pure DCIS usually presents with any form of non-mass enhancement on MRI, but the commonest presentation is a segmental and clumped enhancement. This was a case of DCIS with a focal asymmetry showing microcalcifications. We can never assess whether the lesion is extending to the nipple or the actual size of the lesion, except if we do MRI, and now we can see this segmental distribution of the non-mass enhancement which is reaching to the nipple. On the diffusion weighted images, DCIS also shows restricted diffusion. For example, we have here, this is the subtraction, this is the dynamic showing segmental clumped non-mass enhancement. If you look at the diffusion, we will find that it is bright here and it becomes suppressed in the ADC. Then this is what we call diffusion restriction. And this is another sign of DCIS, which might help us to see the actual distribution of the DCIS. So to set up rules in the diagnosis of DCIS, because DCIS follows duct ramification, any calcification or enhancement pattern taking a specific distribution in the breast should be taken seriously, and it should be biopsied. Now we're going to see some common clinical scenarios. This was a case. She was a 48-year-old with a long-standing palpable left breast mass lesion, but she came presenting with right bleeding per nipple. As you see from her mammogram, she had on the left side an encapsulated fat-containing mass lesion, while on the right side she had segmental microcalcifications taking a specific distribution in the upper outer quadrant. We decided to do contrast mammogram, and as you see on the left side, we have on the right side we have asymmetrical segmental non-mass enhancement, while the lesion on the right side did not show any enhancement at all. A biopsy was taken, and this was a case of a DCIS, and as you see here, the cells are proliferating with an intact basement membrane, which ensures that there is no invasion outside the duct. So we have in this case a right intermediate grade DCIS and the left hamartoma. This was another case. She's a 65-year-old with palpable, painful right breast mass. This was her mammogram in 2021. She came complaining of a mass which correlated to this mass lesion, which appears oval, hyperdense, with obscured margins. An ultrasound examination was performed, and this was simply a complicated thick-walled cyst, which was aspirated, and she was asked to come for her regular annual checkup. In 2022, she came, but she has developed something new in her breast, and if we do not magnify again, we will not see this new thing. She had left newly developed multiple groups of microcalcifications. This was the AI in 2021. It did not see anything. And this in 2022, it showed that it marked the microcalcification with a high abnormality score of 96%. And as we see, the AI can also delineate the distribution of these microcalcifications. So just looking or comparing between the 2021 and 22 in the CC and in the mediolateral oblique view, if we just have a quick look on the breast, we will never discover these newly developed microcalcification. So making it a rule, if either you have AI or you have to also magnify so as not to miss subtle changes within the breast. These calcifications were biopsied using vacuum-assisted biopsy, and the cores were imaged. And as we see, we have now here microcalcifications within the core. And it is essential, as I said before, that the radiologist should document the procedure and the specimen. He should take images of the procedure showing the needle within the microcalcifications, and he should image the specimen to see, confirm the presence of microcalcifications within the specimen. This was the pathology, and the pathologist also should document the presence of calcification within the specimen. And the pathology report came back with an intermediate grade DCIS. This was another case. This was her mammogram in 2017, and this in 2018. Although the changes were subtle, but if we look closely at the different mammograms in 2017, 2018, and 2019, we will notice that gradually the patient is developing here, developing asymmetry here. It is not present here. It was very subtle, but here it became evident. And if we magnify and have a close look, we will see that this asymmetry is taking a specific distribution within the breast. An MRI of the patient was requested, and it showed asymmetrical multiple enhancing foci taking the same distribution as the asymmetry. And this is the MIP images showing the segmental distribution of these enhancing foci. And this was a case of an intermediate grade DCIS. Now we move another step, and this is one of the most important points in my lecture today. The radiologist and the pathologist in the MDT are discussing whether our results are concordant or discordant. The radiology pathology correlation is the ultimate phase in the diagnostic workup of any patient after which management decision is taken. It includes the critical review of the imaging findings in view of the pathology reports. It is defined in the BI-RADS Atlas as a tissue diagnosis is considered to be concordant if cytological or histological diagnosis rendered by the pathologist is consistent with the imaging features of the biopsied lesion. And to understand the different pathology and radiology concordance and discordance, the screen is shared or no?
Yes, Professor, it's shared.
But I don't know why the presentation stopped. Okay. So to understand the different situations, we will make a comparison between the different situations. We say and remember that this is from the point of view of the radiologist, not the pathologist, because if we are pathologists, things will completely be turned 180 degrees. So from our point of view as radiologists, we say we have concordant benign results if we and the pathologist state in our reports that there is a benign lesion. And in these cases, the patient is asked to come for a follow-up study just to confirm that this lesion is benign. If we say we have concordant malignant lesions, then again, we and the pathologist, we both say that we have malignant lesions. And in this case, the patient has to proceed to radical management. And now we come to the situations where we have discordance. We say we have discordant benign results. And from our point of view as radiologists, we have stated in the report that we have a benign lesion, but this lesion was biopsied and the pathology report came back with a malignant pathology. And in this case, we just have to discard what we said as benign because the pathology said it is malignant, and we have to proceed to radical management. There's another situation where we have discordant malignant results, and in this case, we have two situations. In the first situation, we say we have a malignant lesion, but when it was biopsied, we find that the pathology report comes with a benign findings. And another situation is that we both said it is malignant, but what the pathologist stated, it does not explain what we see in the imaging. Like, for example, the case that I showed you at the beginning with microcalcifications and pathological lymph nodes, we said malignant, and the pathology report came with the DCIS, but the pathology report does not explain what we see in imaging, does not explain the presence of pathological axillary lymph nodes. So this is another case where we both said malignant, but but what is written in the report does not explain what we see in the imaging. And in the last two cases, we have to have a stop here and try to revise ourselves. So should we revise? The first thing is that we should have another look on the imaging findings and see whether we have overestimated the mass to give it, for example, a BI-RADS 4 or 5. Is it really benign looking? Maybe it's benign looking, and we overestimated the BI-RADS category of this case. Was the lesion correctly biopsied or no? And should we do a re-biopsy or do an excision for this lesion to make it more accessible for the pathologist to diagnose? or do we just need to make larger course from the biopsy specimens? So we have to take a stop here, because we could not, if we say malignant and the pathology report states benign, this is not an indication that we just ignore the malignancy that we see and say it's a benign lesion and put the patient under a follow-up. So we're going to see some common clinical scenarios now. First, we're going to see the discordant benign results. The discordant benign, which means we said benign, but the pathology report stated that this is not a benign lesion. This was a 42-year-old complaining of right bloody nipple discharge, and we all know that the orificial unilateral bloody nipple discharge should be taken with a great caution. And the patient came for her mammogram, and on the mammogram, she had a heterogeneously dense breast. The complaint was on the right side. On the right side, we did not see any calcification or no speculated mass lesions. Even we had this asymmetry on the left side, but here it's not present. So it's just overlapping breast parenchyma. This was her ultrasound examination. And when I was sitting in the tumor board, I found that they have reported this as a retroareolar avascular mass lesion with related dilated duct, and they stated in the opinion that this is likely an intraductal papilloma. We usually ask for patients with the bloody nipple discharge for cytology from this nipple discharge, and the report of the cytology came that this is a hemorrhagic disease with mild to moderate atypia. And when we see the word atypia, we should have a stop here and revise ourselves. And the first thing to revise was going back to the imaging. Was this really an intraductal lesion? If it is an intraductal lesion, where is the dilated duct that this lesion was situated in? Yes, there was a duct passing just adjacent to the lesion, but it's not an intraductal lesion. So I told them, no, this doesn't fit with the diagnosis of an intraductal lesion. And I think we have to repeat something in order to diagnose the case. So I said, let's biopsy this case, this lesion, because it's not actually a papilloma looking. There was no central vascular pedicle, no dilated duct to say that this is a papilloma. And we biopsied the lesion, and the biopsy showed low-grade DCIS of cribriform pattern. And as I told you, the oncologist would always request for an ER test, and it was an ER positive. This brown staining stands for the E positivity of the lesion. And this was the P63 to ensure that the basement membrane was not infiltrated. So the biopsy now report, it's stated that this is a low-grade DCIS. And when we were again sitting in the tumor board and the pathology report came stating that this is low-grade DCIS, then we have to proceed for radical surgical management. And immediately the oncologist the surgeon will ask me, should I remove only this mass, or I have to remove something more than this mass? And immediately we should also say that we have to do another examination to decide whether the patient has to do a mastectomy or the conservative surgery. And in this case, we performed MRI examination. And as you see here, this is the mass that we saw on ultrasound examination, but it was not only this mass. It was associated with segmental numb mass enhancement, taking a distribution from the nipple posteriorly. And to see this extension, this whole extension, we should recommend for a simple mastectomy and not just a conservative surgery. If the surgeon would have removed only the mass that we see on ultrasound, it would have come, the biopsy specimen, the surgical specimen would have come with a positive margin, and we would, the patient has to go again for surgery to do a simple mastectomy. This is another case, and in this case, we're going to see discordant malignant results. This is a screening mammogram of a 65-year-old female. She had a heterogeneous dense breast, and what we can see in this mammogram is this oval, isodense, obscured mass lesion. But remember, this was on ultrasound, it was simply a cyst. And remember, we always have to magnify. Please do not forget to magnify if you're doing, especially in screening. And when we magnified, we saw multiple groups of microcalcifications reaching to the nipple. And in this case, we have to state the distance from the skin and the distance from the nipple to allow for the surgeon to decide whether he has to do, for example, a skin sparing mastectomy, a conservative, or a normal mastectomy. This mass was biopsied, and the lesion came with an intraductal clonal epithelial cell proliferation with cytologic and morphological features similar to low-grade DCIS, but it only involves a portion of the affected duct. You see here, it's a partial and no affection of the whole circumference. Even here, we have a partial affection and not the whole circumference of the duct. And remember from the images that I showed you early in this lecture, we said that if this proliferation does not involve the whole circumference of the duct, then this means, or if the count is below what the threshold for DCIS, then this is ADH. And this was the report. It stated that there is fibrocystic disease with foci of ADH. Actually, in the breast cancer tumor board, when we have the diagnosis of ADH based on a true cut biopsy, those should not be accepted, especially that these microcalcifications looked very suspicious. So we have to revise what we did, revise the imaging features. The imaging features were very suspicious. What was the lesion correctly biopsied? Should we rebiopsy, or we need larger cores? Then this has to be revised. And actually, on revision of the course, there was only a single fleck of microcalcification in the core biopsy. So we said, no, this is an inadequate pathology, and so long it's an ADH, the pathologist would request for a larger core biopsy to be able to differentiate whether this is ADH or is it DCIS. And when we did larger cores, microcalcifications are now evident. And now the pathology report came back with an intermediate grade DCIS of solid or cribriform patterns with microcalcifications. And he should document the presence of microcalcifications within the taken biopsy. So this was a case of an intermediate grade DCIS. And again, in this case, we have to proceed for radical surgical management. And to do so, we have to go forwards for a contrast study. And in this case, contrast mammography was performed. And as you see here, we see enhancing foci and small mass lesions taking a segmental distribution. And the left breast was negative for any contrast uptake, but there was a sign which is very characteristic to contrast mammography. And this is the negative contrast uptake, or the eclipse sign, which characterizes cystic lesions. This is another screening mammogram of a 40-year-old female. She had this focal asymmetry in the left lower inner quadrant, and she had left pathological lymph nodes. Artificial intelligence showed a lesion of low abnormality score of 22%. A biopsy was taken, and this revealed a low-grade DCIS. Again, we should not accept this in the presence of malignant nodes. And if you see here, we said malignant, the pathology said malignant, but these are discordant results. What we see in imaging is not explained by the pathology report. So, and the surgeon, we will be asked many questions. What about the axillary nodes? Is it a pure DCIS or an invasive cancer? And the oncologist will tell me, should the patient receive neoadjuvant chemotherapy? And the surgeon will ask, do we need axillary dissection? And this could not be answered unless we take a biopsy from the axillary lymph nodes. These were the dilated ducts, thick fluid-filled ducts, and these were the pathological-looking lymph nodes. But fortunately, in this case, when we took the biopsy, the lymph node biopsy came back with follicular hyperplasia with no malignancy. So this was a case of pure DCIS. And the contrast mammogram was requested to see the actual extension of the lesion. And as you see here, we have segmental non-mass enhancement. And this was a case of low-grade DCIS. This was the surgical pathology report and negative sentinel lymph node biopsy. The surgeon is, if he's going to perform a mastectomy, he's asked to perform a sentinel lymph node biopsy. Because if this patient turned out to have invasive cancers, invasive cancer, we will not be able to perform a sentinel lymph node biopsy after making a mastectomy. This is another 33-year-old with a palpable left breast mass lesion. In the left breast, we had an asymmetry, which is seen in both the CC and the mediolateral oblique view. But there was associated mild skin thickening in the breast. This was the ultrasound examination, which showed a non-mass hypoechoic lesion, which extended from 11 to 3 o'clock, so it's a wide area. But when we looked at the axillary lymph nodes, they were not specific. They were oblong, preserved fatty hilum, and thin cortex not exceeding 3 millimeters. A biopsy was performed, and this was an intermediate grade DCIS. Again, this could not be, is not convincing to me because DCIS does not cause diffuse skin thickening like what we saw in this case. We requested a contrast mammogram, and as you see, there's a very wide extension of the lesion. Nearly all the left breast was enhancing. And the surgical pathology came with an intermediate grade DCIS with an invasive component, which explains the associated skin thickening in this case. And lastly, we come to the last question: how do referring clinicians and radiologists report DCIS? The radiology report is considered the end product of radiologists. They are the chief way how radiologists communicate with clinicians. On the other side, clinicians are considered the customers of the radiology department. Before attending the breast cancer tumor boards, the radiologists are mostly product-centric, which means that during writing a report, they mainly focus on a well-organized report, which is their product, irrespective of what the clinicians or the customer demands and challenges are. Sometimes we write a report which does not answer what they need to know from our report. But after attending the breast cancer tumor boards, now we become more customer-centric because we deal directly with the surgeons, with the oncologists, and when we write the report, we focus mainly on answering the questions or answering the demands and challenges of our customers, who are the surgeons and the oncologists. I'll show you some examples to see how different we are when we are product-centric or focusing on the report, and when we are customer-centric, focusing on the oncologist. This is a 38-year-old with left breast palpable mass, which was diagnosed as inflammatory outside Bahia Breast Cancer Hospital. When she came, we were not satisfied with this diagnosis, actually. This was her mammogram, and as you see, we see here a global asymmetry of the left breast. And when we performed an ultrasound examination, we had left microcysts, dilated ducts with retained secretions or echogenic material, and the axillary lymph nodes were not good looking. They had focal cortical thickening, which was more than 3 millimeters. But everything was, as you say, you cannot be decisive whether this is benign or malignant. But we decided we should take a biopsy, and the biopsy came back with a high-grade DCIS. If we are product-centric, we would just say that there is a left breast global asymmetry seen in both the CC and the mediolateral oblique, and we would say that the left axillary lymph nodes have a thickened cortex, and we would give the case either a BI-RADS 3 or a 4. She was given a BI-RADS 3 outside Bahia, but for us, it was raised to a BI-RADS 4. Okay, but if we are customer-centric and we now know this is a high-grade DCIS, we should answer the demands and the recommendations of the oncologist and the surgeons. We would say, yes, this is a highly suspicious. We say it's a left breast global asymmetry, but it is associated with parenchymal distortion in both the CC and MLO view. Up till here, we are okay with the product-centric radiologist. But what we will add is that we would measure the area occupied, and we will say that it measures 0 by 0 centimeters to answer the surgeon if he's going to perform a conservative surgery or no. Approximately X centimeters from the nipple and X centimeters from the skin. We should mention that there is no skin thickening, and we should say that there is associated indeterminate level 1 axillary lymph nodes, and we will not stop here. And you see this here, he said axillary lymph nodes open. Here we have to specify the level of suspected or indeterminate lymph nodes. We said that they are level 1. I don't know who, somebody wrote on the screen. If the admin can just remove this. Anyway, and we should recommend for a biopsy. When in the MDT, we know that the lesion pathology is DCIS, we would recommend for a further contrast study to see the actual extension, and we should ask for a second look ultrasound on the left axillary nodes, plus or minus a true cut biopsy from the axillary lymph nodes. Thank you. And we would recommend for further MRI to see the actual extension of the lesion. And again, if we are product-centric, we will just write in that there is left breast segmental non-mass enhancement, which shows a dark T1, intermediate to T2, and bright signal with restricted diffusion. If we are customer-centric, we would say, yes, define all this, but we will add the actual size of the lesion, the distance from the nipple, the distance from the skin. This should all be included in the report. And lastly, the implementation of multidisciplinary tumor boards definitely enhances the communication between different specialties, and thus they definitely impact breast cancer care outcomes from diagnosis to management. Furthermore, multidisciplinary tumor boards are a good chance for young radiologists to learn and for professionals to upgrade their knowledge. And thank you.
Professor Rasha, allow me to thank you on behalf of all of the audience for this amazing presentation. As usual, it was informative, well-structured, and high-level presentation. Thank you very much. Professor Rasha has to leave the discussion now for a prior scheduled commitment. So the discussion is now open for her part of the presentation. Please raise your hand if you have any question for her, and one of us will unmute you. Alternatively, you can drop your question in the chat menu, and I will read it for her to contribute towards it. So discussion is now open. To start with, Professor Rasha, there's a question from Dr. Amal Al-Hidairi. She's asking, do we need to rebiopsy vacuum-assisted biopsy or excision to prove invasion of in the DCIS?
I know that vacuum-assisted biopsy is not available everywhere, even in Egypt, and I think the same situation in Sudan. But we have conditions. Definitely, it's better to do a vacuum-assisted biopsy for microcalcifications. But we have specific situations that it has become a must, or else we would do an excisional biopsy, like the cases that I showed that do not match, that these are DCIS, and the patient has axillary lymph nodes. Maybe if we biopsy the axillary lymph node, this would be a solution. But in the case, for example, where we had associated edema with no pathological axillary lymph nodes, we can never differentiate unless we take a larger core for the pathologist. And you will find that in many reports of the pathology, they would write at the end, a larger core biopsy is recommended. We have to consider case by case in the tumor board. If we have vacuum-assisted biopsy, then if you have microcalcifications, then go directly for vacuum-assisted biopsy. But to say that we removed it or excised it based on a vacuum, I think this is still questionable.
Yes, thank you so much. Dr. Nadia Dawi has a question. She raised her hand. تفضل يا دكتورة نادية.
Yes, good morning. Thank you. I'm a pathologist. Thank you so much for this lovely lecture.
Thank you.
I really enjoyed it. I wish I could do the same, because now I don't have my practice, but it was such a lovely, and it came directly from to me.
Thank you, Dr.
I think everybody will appreciate this. Although I do have some questions, because actually it's a comment. Without a multidisciplinary team, we cannot do that. It is really difficult on the phone, as we usually do in Sudan, or we did in Sudan, to go on the phone and discuss cases on a one-to-one basis. But to do this in a multidisciplinary meeting, it would be, of course, lovely. Thank you so much for this.
Thank you, Dr. Nadia.
Thank you so much.
Thank you, Dr. Nadia. Dr. Rabab has a question.
Can I tell something to Dr. Nadia?
Of course.
Used for multidisciplinary teams regularly before the corona, after the corona, and we now know the Zoom. Even if you're far away, you can just discuss the lesions online, especially if you have a PACS. We can just share from the PACS the lesions or the imaging. Yeah. And yes, so the online.
It is one way of doing it. Yes.
Yes, yes, and it helps a lot. Maybe now it has become more informative than sitting together.
Yes,
Yes.
definitely. But even that is not that easy. But now I think we are getting the
As much as you can. I know it's
sessions.
difficult in some situations, but as much as you can just try to, because this really helps in taking a good decision for the patient.
Yes, we are getting quite used to it now, doing even exams where everybody is in a different time zone. So I
Yes.
think it will be possible. Thank you so much.
Thank you.
Thank you, Dr. Nadia. Dr. Rabab, you have a question?
أولا دكتورة رشا السلام عليكم ورحمة الله
وعليكم السلام
وبركاته.
ورحمة الله. ازي حضرتك
Long
يا دكتورة؟
time from you. First, thank you so much for accepting our invitation and share with us this insightful and informative talk about very important topic, the DCIS. We really enjoy it so much as usual.
الله يخليك. شكرا دكتورة رباب. شكرا.
It is not surprising to have this amazing presentation from Prof. Rasha. But I have only one question regarding one case you presented. The one they suspect that intraductal lesion, and it was not. On MRI, you presented there was a focal non-mass like enhancement in the contralateral breast. How do you usually deal with such type of abnormal enhancement we usually faced?
It was in the same breast. It was in the same breast.
No, I'm asking. I have noticed a small.
I got it here.
Yes.
Here it is. Yes.
In the contralateral, I'm asking about the contralateral. Yes,
this area, you mean?
Yes. Sometimes we notice
these are dilated ducts, but if you look at the subtraction, there is no enhancement, and if you look even on the map, there is no enhancement.
So you ignore it. As a mild enhancement, you ignore it.
It's not a mild. It's not no enhancement at all. It's just a dilated duct with retained secretions. That's it. Here it's not. There is no enhancement. The enhancement is similar to that of the parenchyma.
Okay.
Yes.
Okay. Sometimes even we can see some types of focal enhancement. How do you usually deal with such type of in case if it is a real one?
You have to target the area with an ultrasound examination. Sometimes when you do a second look ultrasound examination, you see a lesion. When you're looking for something, you sometimes you see a lesion that was missed. But what if we don't see any lesions? You have either one of two solutions. If it's an MRI guided biopsy, and we don't have in Egypt, and I think the same in Sudan, I think. So
yes, you
we cannot do a biopsy. Sometimes we do a contrast guided biopsy. In Egypt, we have contrast guided biopsy. So we do a contrast mammography. If this lesion is apparent, then we do a biopsy. And if it's not apparent, then we have to put the patient under follow-up because there is nothing to do. We cannot biopsy something that we don't see. So you have to put the patient under strict close follow-up examination so that you can, if something develops calcifications or something which points to the lesion, then we can just take the biopsy.
Okay, so just I would like to know how you are dealing with such type. I am dealing in the same way.
Yes.
I used to target it with second look ultrasound. And I have some of the cases even the index cancer in the beginning it was DCIS, and the second focus just picked up on MRI was invasive cancer even.
Yes, that's true. Yes.
Yeah. And otherwise, I might follow the patient if I could not find the lesion on ultrasound because we have no facility for MRI guided biopsy.
Yes.
Yeah. Thank you very much. Thank you again.
Yes, thank you, Dr. Rabab.
Thank you, Dr. Rabab. There is a question from Dr. Mirat المضوي. تفضلي دكتورة ميرات.
صباح الخير. Good morning everyone. صباح الخير دكتورة. يعني first on behalf of for the Egyptian Society of Breast Imaging, we are so honored and so happy we are part of this Sudanese Breast Imaging Society Symposium. يعني we are looking forward for collaboration all over the year. حقيقي because as you know يعني you are our extended family من Egypt
so
يعني you are directly our extended family, and we as Dr. Rasha said يعني a lot of common scenarios are common between the our patients and of everything. So thank you so much for having us.
خلونا نشوف صوركم يا جماعة دوكيومنت. أسهروا لنا كاميرا، أسهروا لنا كاميرا وأنتوا بتتكلموا. معلش دكتورة مريت، يعني أنا قطعتك بس عشان تسهري.
لا يعني I'm just يعني إن هو بيد هيد دلوقتي، فشكلي بيد هيد.
لا ما في مشكلة.
يعني هعمل بس شوية adjustment وافتح الكاميرا. حاضر على محاضرتي.
حاضر. هي المشكلة يا دكتورة رباب
خلينا نشوفك يا بروفيسور.
ساعات لما ممكن افتح، بس هي الفكرة ان ساعات لما بفتح الكاميرا بيقلل
الكواليتي والكونكشن
بتاعت
بس في الدسكشن خلي الكاميرا مفتوحة.
انا كنت هفتحها في ماي توك يعني، بس انا بس كان
دكتورة رباب ولا ايه؟ انا مش متأكدة، مش شايفة نفسي.
هي دي.
لا احنا شايفينك دلوقتي يا دكتورة رشا ودكتورة رباب اهي ان بينك.
ايوه هنا دكتورة رباب.
دكتورة رباب مبهجة. يعني ثانك يو دكتورة رباب، ماي دير فريند حقيقي، مبهجة دايما زي ما انت شايفينها.
الله يكرمك الله يكرمك يا مريم.
وثانك يو سو ماتش دكتورة مدي.
والله احنا سعيدين بكم. احنا سعيدين جدا. ما تتخيلوا ان الان احنا يعني دي فعلا جلسة علمية مميزة، تماما مميزة.
كنت
فيها يعني.
ربنا يخليك. كنت يعني I want to يعني اللي هي ال question about الليمف نود، لان هو somehow related للتوك بتاعتي الليمف نود، وفي نفس الوقت يعني I want to have دكتورة رشا's opinion على الكويشن ده. جالي كذا مرة هنا كمان في السعودي أرابيا about يعني احنا يعني appropriate method of sampling لل DCIS. طبعا we are all agree that it is a vacuum as long as you can يعني proceed ل vacuum assisted, do it from first place vacuum. Okay.
Take large amount of tissue. Yes,
of course. Right. And as Dr. Rasha يعني explain how this is crucial for appropriate management if the surgeon will do a sentinel or not gonna do a sentinel based على في invasive component or there is no invasive component. فطبعا vacuum is appropriate. However, sometimes as you said some places don't do vacuum. So when يعني it's a question I received often when I have a DCIS based on a core, then يعني there's doubt, should I upgrade or not? So I think we should do an MRI or contrast enhanced study, زي contrast enhanced mammography أو MRI, and based on the finding, if there is a suspicious of invasive component, usually it seems like a clumped area. طبعا of course لو في mass خلاص this is easy يعني we will target this mass. However, sometimes it's like a clumped area of non-mass enhancement, areas that's very obvious washout. This is when we are يعني make it more encourage us more in احنا no wait, we will do upgrade ل something, refer her to a vacuum center or encourage the doctor to do, the surgeon to do sentinel lymph node. يعني ده اللي هو situation اللي هو يعني I think السيناريو اللي can be followed if there is no vacuum on site. But at least I think we should
he's not justified to do a sentinel lymph node if he's performing a conservative surgery. He only does the conservative. The sentinel lymph node if he's performing a mastectomy, then he has to perform.
He has to do
conservative surgery, and we have a pure DCIS. The surgeon is not justified to open the axilla at all.
Exactly. So the question is the question from the surgeon, are you sure this is only DCIS? So this is why I'm asking.
If we see imaging features which fit, but usually we depend on the pathology report. And what we see in the imaging is, for like the cases I've showed you with the breast edema or pathological axillary lymph nodes. And in the pathological axillary lymph nodes, it's recommended not to take a fine needle. It's recommended must perform a core biopsy, because based on the core biopsy of the lymph node, you will know the ER and the PR.
لا I'm talking about a scenario في DCIS no suspicious lymph node, في benign appearing lymph node, في extended DCIS و I don't see يعني invasive component بالماموجرام أو كده، المكان ما فيهوش فيه no vacuum biopsy. فالسيناريو اللي يعني أو الquestion اللي بقى أنا received دايما، أنا عملت core biopsy it revealed DCIS، لكن السيرجن يعني asking me are you sure إن هو there is no invasive component.
I think yes.
Pathology. On the pathology.
Pathologist لو هو based على vacuum I was gonna be very confident لو based على vacuum، لكن الأماكن اللي بتسألني بتبقى خدت core only، فعشان كده
دكتورة مريت I think MRI is a good suggestion. I have a recent 2 case, okay, pathology result were ADH, okay, and then we proceed because يعني they might take the sample even if it is core biopsy, they might take the sample from area not involved by DCIS or even by invasive component. So we usually, in such case, I usually proceed for, if I did not do ultrasound myself, I'll proceed for MRI, okay? And
the
for
word
me,
in a pathology
these 2 cases, then 10 out on MRI demonstrated a high suspicion and proven to be even invasive component, DCIS with invasive component rather than just a DCIS. And the early pathology and the first pathology or initial pathology was just an ADH.
And ADH, even without the MRI, is an indication of a larger biopsy. Because as I told you, it's just a count difference between DCIS and ADH. If it's more than 1 millimeter,
no, I agree with you, but it is more or less the same scenario. يعني the mammography demonstrate just micro calcifications.
Yes.
And the biopsy turned out to be ADH.
Yes.
Okay. Then we proceed for MRI, demonstrate more suspicious features than MRI,
and
it tend to be high-grade DCIS with invasive component, and there was a pathological or metastatic lymph node was not clinically suspicious.
Yes.
يعني دكتورة رشا ممكن recommend contrast study for all DCIS to plan appropriately the type of biopsy.
Most of the cases you will find that in DCIS you have to proceed either to contrast or to MRI, and there was
ده هي البوينت اللي عايزة
يعني there was a question from the audience when to perform contrast and when to perform MRI. MRI is a modality of choice, but contrast mammography solves maybe 70 or 80% of the problems. If you have the pathology stating low-grade DCIS, then it's better to go for MRI. If the lesion, you see it in the imaging in a deeply seated, or you cannot see the posterior extension, or you think it might be extending in a mammography hidden area, or the lesion is present in a mammography hidden area, then again you proceed to MRI. So it depends on what you see on the imaging, the position of the lesion, and if you think that if you do contrast mammography you will not see the full extension, and on the pathology report if it states a low grade tumor, then it's better to proceed, because MRI is definitely of higher sensitivity than contrast mammography. So this was one of the questions from the audience, I think.
Dr. Rasha, I think here the problem for us, for you and us, is lack the facility of MRI guided biopsy. And in this case, in such case, contrast mammography, it will be superior.
A lot of problems actually.
Yes.
But we don't usually need the MRI guided biopsy. احنا بس doing MRI before
go for second look.
and then go to for second look. MRI finding will assure you. Do you need really to refer the patient to a place where there is vacuum? لما تشوفي clumped area.
If you have any suspicious, then
suspicious إن في invasive.
whether based on imaging or based on the pathology.
هي دي البوينت I think اللي احنا عايزين نوصل، اللي هو ال DCIS do MRI، والام ار اي لو في suspiciously invasive من الستارت خليها vacuum assisted biopsy not core biopsy عشان reach the diagnosis without any hesitation.
It was the modality of choice from the start. So if you didn't perform it and you still have suspicion, then proceed.
وبعدين برضو MRI, if we have seen it on MRI, that means the grade is a little bit higher. Yani we will be confident that it is an MRI of a higher grade than what we have seen on mammography.
Yes.
Yes. Thank you so much for your contribution, doctors. There's a question from the chat menu. We'll have to just take one question. Most of them were answered. Dr. Wiam Mohammed is asking, please, in case of discordance between, especially in cases of palpable focal asymmetry, is the decision to take further steps a radiologist decision or a surgeon decision?
The radiologist or the surgeon, actually,
Yeah.
it's the decision of both. If you have a palpable asymmetry per se, to me, this is very, should be taken seriously, because we have a lot of cases of lobular carcinomas, for example, and DCIS as well, non-calcified, and they can be missed based on imaging findings alone. Whenever I refer to the surgeon and he tells me, no, I feel it's suspicious, it's palpable and suspicious on palpation, we have to proceed for a biopsy. And it's easy now because we have a palpable lesion that we are going to biopsy. It's not based only on imaging. Sometimes we see an asymmetry on mammography, and then when we do the mammogram, we see, or the ultrasound, we see nothing corresponding to this asymmetry. But if it is palpable, this makes it more suspicious and makes it easier to biopsy. So whenever you have a palpable focal asymmetry, you have to biopsy.
صباح الخير يا دكتور رشا.
صباح النور.
انا اقصد ديسكوردنس، يعني الباثولوجي قال انها نو مالجنت سيلز نو اتيبيا. الستيب اللي بعد كده المفروض الراديولوجيست ياخدها
فولو اب. Yes, 6 months follow up.
مامو ولا MRI؟
لا, start with the mammo. It's not, if it's not increasing in density and no correlate on ultrasound, then it's focal adenosis, for example.
Okay, thank you.
ازيك يا وئام الأول؟
يا دكتورة رشا، سوري معلش for the interruption، لكن الحتة بتاعت الديسكوردنس دي في الفايبروسيستيك I think it is a dilemma. يعني كتير الريبورت بيكون حاجة vague, just a fibrocystic. Your experience in this area.
From the point of view of radiologists, because we think that fibrocystic mammary changes are are only those when we see cysts inside the breast, and that's it. Fibrocystic mammary changes include a very wide range of it includes apocrine metaplasia, sclerosing adenosis, radial scar, and so in many cases even we have reports with fibrocystic mammary changes, and actually we do not see actual cysts in the breast. And all these lesions might clinically be palpated like malignancy, and on imaging also, they might give us features like malignant breast lesions.
Yeah, I do agree with you, but my concern is not just yes, I agree with you. There is a wide spectrum of fibrocystic, but if they specify in the pathology report, they specify is it a proliferative or non-proliferative type of, and specifically they reported as adenosis or sclerosing adenosis or radial scar complex lesions or something like that, or just an area of fibrosis, at least we will be more, this is more specific diagnosis, what I mean. But just to put for us fibrocystic changes, I think this is the vague,
what's more important in the report is that the pathologist should write if there's atypia or no, because if there is atypia, then there is still an incidence that this lesion either holds a malignant lesion inside, or it has a tendency to change to a malignant lesion. So it's an indication for excision. If there is no atypia, then we put the patient under strict close follow-up. If anything,
close follow-up, yes. This is what I mean. If it is just the report, the pathology report is just fibrocystic, non-specific like that, I have to follow the patient. I should not leave the patient
be strict about this follow-up. Yes.
Yes.
You have to explain to the patient and make it a must that she must come for a close follow-up. Yes.
Okay. Thank you very much. Thank you.
Professor Rasha, شرفتينا, and we are honored by your presence and contribution towards today's symposium. And we're looking forward for welcoming you in the upcoming events of the Sudanese Society of Breast Imaging, inshallah. Thank you very much. Thank you.
Before that, دكتورة رشا أتمنى إنك يعني تحضري معانا البرزنتيشن بتاع اللاست برزنتيشن.
لو انا والله عندي بس التيومر بورد، انا يعني كنت هقول لكم ان انا ممكن احاول ادخل بالموبايل بحيث ان انا لو عندي وقت وفاضي في النص اقدر
والله مأكدة عليها يا دكتورة رباب من غير ما تقولي، مأكدة عليها عشان
اللي هي الساعة 5 وانا
لأنه عندنا سترين كيسز حقيقة، وانا I need your opinion in such cases.
ان شاء الله والله لو اول ما خلص بس التيومر بورد، بس ساعات بنخلص متأخر عن كده، فان شاء الله ربنا يسهل وتكون التيومر بورد سهلة.
very interesting. I informed everyone في السوسايتي ان هو very interesting scenario. يعني I was shocked لما عرفت ان الموضوع ده very unique عندهم في السودان، فاحنا فعلا we are really interesting ان احنا maybe
ان شاء الله. فانا والله جاهزة يا دكتورة رباب، ولو ما حضرتش يبقى غصب عني ان هم ما خلصوش، لكن اول ما يخلصوا ان شاء الله
اكيد طبعا ما هقول لكي انا ما شايفه نفس الكيسز هنا، لانك you are talking about early breast cancer، لكن نشوف دكتور الكيسز بتاع الدكتورة أمل وبعد ذاك نحدد يعني اذا كان عندنا حاجه شبيهه ولا لا. لانه في الليتريتشر يعني since 2022 I was searching for such cases and I didn't find any similar one.
ان شاء الله ربنا يسهل واقدر احضر باذن الله.
ان شاء الله حنكون سعيدين جدا اذا كنت موجوده معانا يعني.
لا ان شاء الله باذن الله احاول ان شاء الله باذن الله ان شاء الله.
ان شاء الله ان شاء الله.
الله يكرمك. Thank you Professor Rasha. Thank you very much.
السلام عليكم مؤقتا وهرجع.
وعليكم السلام.
ان شاء الله.
اهلا تشرفينا.
شكرا لك يا دكتور رشا. شكرا.
مع السلامه.
الله يسلمك.
Please join me in welcoming Professor Amal Hijazi, a consultant radiologist and a chairperson of the Public Radiation and Community Awareness Committee at the Egyptian Society of Breast Imaging. She is also the founder of Lady Scan Radiology Center and the former head of radiology department at Ayad al-Mustaqbal Hospital. Professor Amal is going to discuss with us the multimodality imaging review of the HER2-positive breast cancer and the response of the new adjuvant chemotherapy. Thank you, Professor Amal, for joining us today. It's an honor to have you on board. You may share your screen now if you would like. Professor Amal, if you would unshare the screen, please. Professor Rasha, if you would unshare your screen for Professor Amal to share hers.
I think you do stop sharing. Okay.
Yes. Yes, Professor Amal, you may go. You may go now.
السلام عليكم. يمكن يا دكتور.
وعليكم السلام ورحمة الله.
وعليكم السلام ورحمة الله دكتور أمل.
كده انتوا شايفين السكرين؟
بس في ايكو يا دكتورة أمل، ممكن تقفلي one من أنا شايفة two devices.
هقفل.
اقفلي الساوند في one of them.
مش شغال إلا من على الموبايل، فثواني كده بنحاول نظبطه من على الكمبيوتر. طب السكرين باينة عندكم؟
لا أنا عندي مشكلة.
لسه مش باينة. لا لازم نلوث الساوند، فيه مشكلة. الساوند شغال؟ ثواني. انتوا شايفين يا جماعة السكرين ولا لسه؟
لا لسه.
لا لسه.
انتوا شايفين السكرين يا جماعة ولا لسه مش شايفين؟
ايوه ظاهرة دلوقتي.
طب بالنسبة للصوت ايه الأخبار؟
الصوت لسه فيه صدى شوية.
طيب خلينا مع بعض كده نحاول نظبطه.
لا كده كده كويس
كده
كده مفضلة.
ايوه كده احسن الصوت.
بس قربي من المايك.
طيب عشان المايك عامل ايكو. طيب خلاص كده تمام.
لا كده تمام.
طيب كده تمام يا جماعه.
تمام ايوه اتفضلي يا برو.
السكرين باينه والدنيا باينه.
باينه السكرين باينه والصوت واضح.
طب الحمد لله.
الحمد لله.
السلام عليكم.
وعليكم السلام
انا
ورحمه
حابه
الله.
جدا. لا خلاص يا صباح مش لازم. بتحاولي تعملي المايك. لا خلاص طالما الصوت كده واضح اوكي. طب حاولي كده. طب حاولي. ثاني اديني دقيقه كده يا جماعه بنحاول نظبط كده المايك عندنا.
اتفضلي
الصوت
اتفضلي يا
واضح
برو.
الصوت واضح يا دكتورة.
تمام كده. لا المايك مش راضي يرقص.
لا الصوت واضح دكتورة أمل، الصوت واضح. proceed يعني go.
طيب تمام. لا خلاص خلاص يا صباح عشان الوقت بتاعهم مش عايزه اعطل. مش عايز خلاص اتس اوكي. هنستعمل الصوت بتاع الموبايل وخلاص. خلينا بقى نظبط ده كده. تمام كده. تمام. Really, it is my honor to be invited to this meeting with my dear friends and family, the Sudanese Society of Breast Imaging. I want to thank Dr. Merit. She did a big effort to make this meeting easy and happened after a long time. I don't know, it is my bad luck every time that I had to speak after my professor and the colleagues and friends, Dr. Rasha. Every time, I don't know why, in any meetings or any time, always my presentation will come after her. And very difficult to compare between Dr. Rasha. She is excellent, and then my presentation. I hope to find something add value for you. It is very nice, these our meetings. I hope it will be going all through the year. Very important to share our experience. Very, very important. Merit told me that there is very interesting talk will be by 5 o'clock. Really, I will do my best to join with you. And now I will start my presentation. Now I will start my presentation about the multimodality imaging review of HER2-positive breast cancer response to new adjuvant chemotherapy. The objective of my presentation is to know about the classification of breast cancer regarding the molecular subtype and the most typical appearance of HER2-positive breast cancer, which is the point of our talk today, and how and why to assess the response. And this is very important for the radiologist and for the oncologist and for the surgeon, of course. And the radiological and pathological correlation, and what the best imaging modality for evaluation of tumor response. And by the end, we know we want to answer a very important question: what to clip and why to clip. A rapid review about the molecular subtype. Everyone knows that the molecular subtype is a grouping of breast cancer that share same characteristics and hormones receptor status. Understanding molecular subtypes help in treatment. 4 main molecular subtypes of invasive breast cancer: luminal A, luminal B, HER2 enriched, and triple negative. And in our presentation today, we will make our talk mainly on HER2 enriched. Luminal A breast cancer is hormone receptor positive and HER2 negative. And very important to know about the Ki-67. In luminal A, it is a very low level, and this is very important because Ki-67 is how fast the cancer cell grow. And when it is low, this means that tumor will grow more slowly and it will be low grade, and of course it will respond well to hormonal treatment. And luminal A represents the most common cases of breast cancer. It is about 50 to 60%. Luminal B cancer breast is either positive for one of the hormones receptors, either estrogen or progesterone, HER2 positive or negative, but the most important thing is high level of Ki-67, which means that the cancer cells are growing very fast. That's why it will be faster growing, higher grade, large in size, and more aggressive, more likely to come back. And of course, it will be poorer prognosis. Luminal B breast cancer, about from 15 to 20% of all breast cancer. And HER2 enriched breast cancers are hormones receptor positive or hormones receptor negative. But the most important thing is that HER2 had to be positive. And I mean positive is 3 plus, score 3. And in HER2 enriched breast cancer, it is the tumor will be faster growing, more aggressive. But it is very important to know it is highly treatable, and that's why it is they have good chance to be treatable because they are taking target therapy, including Herceptin and Projecta. Also, it is higher grade and diagnosed at later stage. It is again like luminal B, 15 to 20% of breast cancer cases. And by the end, this is triple negative, which everyone knows that estrogen, progesterone receptors, and HER2 will be negative. And most commonly, they are in BRCA1 mutation, younger women, Black women, and they are very fast and higher grade and more aggressive. About 20% of all breast cancer are triple negative. This is the main four, but in between there are overlap, especially between luminal B and HER2 positive. Now we will go to how the feature of HER2 enriched carcinoma on mammogram and ultrasound and MRI. Really, there is nothing specific for HER2 to be diagnosed by a mammo or ultrasound or MRI. The same, you will see irregular shape, less likely circumference, indistinct margin, asymmetry, all the things, but there is something very, not a specific, but 60% of these cases, they associated with fine pleomorphic microcalcification. So in ultrasound, they are the same, but most of them have increased dobular flow. And what I want to tell you from this, there is no specific things you will see, oh, yes, this is triple negative, oh, this is HER2. We say it may be. If we see well circumscribed lesion and oval and in young age, maybe it will be triple negative. But triple negative, it comes with irregular sometimes and microcalcification. The same for the HER2. You will find HER2 60% with microcalcification, but it comes without microcalcification, okay? One thing is very important to start with about the role of MRI. MRI is the gold standard for assessing the response of the neoadjuvant chemotherapy due to ability to provide detailed morphology and functional information. That's why it is not mandatory, but it is better to do MRI for the people who will do who will take neoadjuvant chemotherapy to assess a response. Okay, so the decision to do MRI typically based on individual patient factor and the clinical judgment. There is no guidelines will tell you mandatory you have to go for MRI if you have a case with HER2 and you have to go for neoadjuvant chemotherapy to assess the response. But it is better to do it because everyone knows that the MRI will give us not the morphology only, but the function information. And this is very important. And we will see this in our presentation. Okay. How we will deal with HER2 positive breast cancer. Okay. Better baseline imaging established. You have to establish the tumor size and extend anti-staging. That's why it is better to do MRI and PET-CT to make a good staging for the tumor and to know the real size of the tumor. In between, we had again to repeat the MRI or the ultrasound after 2 or 3 cycles of the therapy to assess an early response. And please don't forget to put a clip insertion. Post-treatment follow-up, mammography and ultrasound or MRI to confirm a response. And here I want to give very important point. If you start by MRI to as a baseline, so post-treatment follow-up, you had to do again MRI. But if you are not doing MRI as a baseline, I think it is of no use to do MRI as a post-treatment follow-up. So if you start with mammo and your follow-up by mammo and ultrasound, and if you start by MRI as a baseline, please follow by MRI. Now, just I will give you some presentation of HER2 positive. This is one of the case, and you can see how the mammo see irregular speculated lesion with very faint microcalcification, and this was HER2 positive. Okay, again, another case, it is well circumscribed lesion with macrolobulated outline, and still also it is with taban intramammary lymph node. This one was positive, and still it is HER2 positive. This is how we see it by ultrasound with longitudinal orientation and desmoplastic reaction around, and it is HER2 positive. Again, another case of HER2 positive presented with just asymmetry. Just, I put this case for the junior colleagues to tell them this asymmetry was missed by us when we did first memo. And again, when we ask our technician to put it in a good position, we see all this focal asymmetry, and by ultrasound, it was like this, because this one was in the inframammary fold, and this is how it appeared by ultrasound, and again, it was HER2 positive. That's why from this case, I want to, this is again another one, and this is the 60% presentation of HER2 will come to you by this presentation. Focal asymmetry, upper outer with overlying pleomorphic microcalcification, and with it pathological lymph node. That's why I give you 4 presentations for HER2 positive. They are not similar, but the last one, this is the most common presentation of HER2 positive. Now we will discuss some cases, and we will see how is the cases present for this very aggressive tumor. 55 years old with negative family history, presented with left breast edema, and this was her mammogram. As you see, this mammogram showing thickened skin, edema of the left breast with focal central asymmetry. However, this incidental finding, right breast mass, she is not palpate this lesion. It is not palpable, and this is her its view in MLO. You can see now this area of focal asymmetry with breast edema, axillary lymph node, and this isodense lesion with speculated irregular outline in the lower aspect of the breast. This it's ultrasound finding. hypoechoic lesion with posterior shadowing, irregular outline. However, this is the presentation of this mass by ultrasound. You can see area of non-mass enhancement with surrounded by breast edema. At that time, you had to take a biopsy with different needle for the right and left breast. TrueCut biopsy was taken from both lesions. Right lesion was infiltrated ductal carcinoma. ER/PR was strongly positive and HER2 is positive. However, left breast lesion showing ER strongly positive, PR moderate strong 6/8, but HER2 was negative. That's why very important to know that different radiological feature equal different pathological subtypes. Again, you can see different presentation radiologically. This from that. That's why when you see two lesions in the breast, you had to take TrueCut biopsy from the two lesions, because very important to know the different subtypes of the lesion, like Dr. Rasha is telling us. This will depend on this result. The surgeon and the oncologist will depend on the treatment they will give to this patient according to the TrueCut biopsy you taken, and the subtypes come from the pathologist. Okay. Why I had to assess the response? Okay, very important. This patient of HER2 positive, they are taking two-type neoadjuvant chemotherapy and target therapy. Okay, so we as a radiologist has to help them if this treatment is okay, is giving complete response, partial response, or no response, like we will see in coming cases. So why to assess this response? First of all, to guide surgical management. Secondly, we had to assess the response in the during the course of the treatment and by the end of the neoadjuvant chemotherapy. Because if the patient is not having a complete response, the oncologist had to give her after the surgery another type of adjuvant therapy. That's why very important for the oncologist to know if there is a complete response or no. Also, for the surgeon had to decide if he will go for axillary clearance or no, according to the response of the treatment. He will put a wire or for the axillary lymph node, or he will not put a wire. So the response is a part of the treatment of this patient. How to assess the response? Response evaluation criteria in solid tumor RECEST was developed in 2000 to assess change in the solid tumor size in patient giving chemotherapy. RECEST criteria are based on the sum of the maximum diameter of target lesion seen on imaging study. We will divide the response to 4 types. Complete response, that means that the primary tumor and lymph node completely disappears. Partial response means that 30 or greater decrease in longest diameter of the primary tumor. However, progressive disease means that 20 or greater increase in the longest diameter of the primary tumor, plus or minus new developing lesions, okay? But sometimes the disease will be stable. And what is mean by stable? That the tumor that did not show either sufficient shrink or to be classified as partial response, or sufficient increase to be classified as progressive disease, we will put it as stable disease. Now we will review together example for these 4 types of response. You can see here sizable 2 lesions, different in its density. occupying the upper outer quadrant of the left breast. And after they finish 2 cycles, they send the patient to put the clip, and here you will see 2 clips were seen in the both lesion. I think you can appreciate that after 2 cycles of neoadjuvant chemotherapy, this patient is start to feel it is different. My breast lump is better, and radiologically also we see in 2 ways. First, the size of the lesion. Second, the density of the lesion. And this is the way of response. You will see by memo 2 things, and you will give comment by 2 things, because this indicates the response of the disease, of the disease, the size and the density by memo. And this after this lady finished her cycle, and you can appreciate now you couldn't find the lesion, only the 2 clips are seen nicely. By this, you had to report by the end of your report. In the opinion, you will see, you will write, this is either complete response, radiological, be a very important word to write, radiological complete response, because it is not in the pathology, maybe they have another word. Maybe they say it is not complete response. So very clearly, you had to write in your opinion at the end of the report that you radiologically, it is a complete radiological response, or radiological partial response, or aggressive course, or stable. Okay, so these cases reported as radiological complete response after she did her operation. The same, the pathology agrees that there is a pathological complete response. Again, another case. This is before pre-management, inner upper lesion. Sorry, I am not putting all the study just because my message is not to learn you how to read the memo. So I just put the simple one view. Okay, this is the pre-management, and this is when the patient came after she finished her treatment, a neoadjuvant, come to us to put the wire, because of course the surgeon couldn't feel the lesion. And this is the wire, and this is the clip, and everyone can appreciate this is the lesion almost vanished. So we report it as complete radiological response. One thing here I want to just tell you, please, when you put a wire, of course I am give my message for the junior staff. Please please be sure that you take your 2 views, CC and MLO, or lateral view, for the surgeon to be sure that your wire is in the correct position, guiding the clip. And for us, we report it as radiological complete response, and also the pathology agreed that is complete response. Now, what is about partial response? Again, partial response, 30% or greater decrease in the longest diameter of the primary tumor. Let us to see some cases of this. Again, this case show again left inner upper speculated lesion is a retraction of the skin, and here after we put our clip, and this is how it's seen by ultrasound. The lesion was about 2 centimeters 1 by 1, and always try to take the 3 dimension of your lesion by ultrasound. And this is after the about 6 months of the treatment. You can see nicely how the clip is seen by ultrasound, but very clearly you can see the lesion. Here, what was about 2 centimeters, I told you we will take the largest diameter, and here the measurement is about 1.5 centimeters. So this is, we will report it as partial response. And here we put the wire in the clip. And of course, we will report it as radiological partial response, and also concordant with the pathology, it comes as, of course, partial radiological response. Again, another case. This is before treatment. There is skin thickening, very clear lesion, seen irregular, speculated, retroareal in the center. And here, after we finish, she finished her treatment, and this is the clip, this is our wire. And something I want to show it here, highlighted. This is the lesion seen in mammogram, and this is again after she finished her treatment. Here, very difficult to assess the size of the lesion. It seems to be smaller and the density. But I think when we did ultrasound for this case, I think this is at the time of starting, and this is by the end. I think by ultrasound here, you can appreciate, you can judge the size more better and more confident by ultrasound than in mammogram. Okay. Here also we will report it as radiological partial response, and of course the pathology came the same. Another case. This case, I don't know the screen is clear or no, but this case was, there is a mass with faint microcalcification, and this is not the clip. And here, when we put the wire before the operation, and still we see the microcalcification, and here how it's seen by ultrasound as well circumscribed lesion. And like Dr. Rasha is telling you, please, when you report, you had to report in details. You had to report its distance from the nipple, its distance from the skin, its distance from the underlying muscle, and all the details had to be written in your report, please. Here, of course, we will tell the our oncologist there is radiological partial response, and also, of course, the pathology will come the same. So from the cases you see, I think ultrasound is more accurate than mammogram for evaluating the response after neoadjuvant chemotherapy. Overall accuracy about 8%, because sometimes in the mammo you can feel that there is a good response, but when you did the ultrasound, you can see the lesion more nicely. Tumor size regarding a measurement on ultrasound is a predicted of partial complete response and radiological complete response. So very important to take the size of the lesion from the beginning, the maximum diameter, and in the follow-up, you again take the same size to evaluate if there is a partial response or complete response. Vascularity is very important. Pre-treatment tissue elastography, also elasticity as measured by shear wave elastography, has significant relationship with the subsequent reduction in the cellularity of the primary tumor in response to neoadjuvant chemotherapy. The vascularity and the elastography now is very important when you do your first evaluation of the case. Then in the follow-up, you had to mention how about the vascularity and the elastography. This will help too much to assess the response. Some case there will be no response, stable disease. Again, what is the meaning of stable disease? That the tumor that did not show either sufficient shrinkage to be classified as partial response or sufficient increase to be classified as progressive disease. we can review this case together. This case 2711-2021, you can see upper lower breast lesion, and in 7/3/2022, you can see the lesion with the clip. I think everyone can see there is no significant change regarding the size, regarding the density of this lesion. Also by ultrasound, you can see this is the lesion, this is the maximum diameter, there is a ductal extension here, there is a peripheral vascularity, and again, the lesion is almost the same size, and also the clip is seen well, but the lesion has no different change in the size. So this case, we are categorized as stable disease. Now, sometimes after they finish their treatment or in between, you will see a progressive disease. Progressive disease means that 20% or greater increase in the longest diameter of the primary tumor. Sometimes you will see newly developing lesions, like this case. You see the mass here and the clip in the center. And by the end, you can see nicely how the lesion is increased in size. So you will categorize this. This is a progressive disease. Again, another case. The lesion on the right breast, it was all the lesion are HER2 positive, by the way. This is the lesion with the clip in the center. Again, the lesion in the middle, we see a nicely response, regressive course. But by the end of the disease, we see the lesion again progressed in size. So what does make the assessment difficult? Post-treatment change may happen inflammation, fibrosis, necrosis, can complicate the post-neoadjuvant therapy measurement, and calcification. That means sometimes you see that the lesion increase in size, but it is not due to the increase the tumor itself. Sometimes inflammation on top make it appear as bigger than the previous size. Sometimes necrosis inside the tumor let the tumor, the mass, become bigger in size, but it is not that means that the tumor is increasing, but the necrosis, and this all we can see only after we take it out and the pathology give us the final decision. And also calcification make it very difficult for the radiologist to assess also the response. Calcification, of course, everyone knows that the mammographic calcification is a difficult challenge to radiologists in assessing a response to neoadjuvant chemotherapy. Because through the imaging, sometimes we see complete resolution of the calcification. This is about 4% of the cases. But sometimes there is decrease only in the microcalcification. And most of the time, 50 to 82%, there is no change in the calcification. And this is when we start working, we think that the calcification, if it is there, it will not decrease or change if we give neoadjuvant chemotherapy. And that's why some people is saying, no need to put a clip because the calcification is a marker for the lesion. But after that, we know that now today that the calcification may disappear completely or may decrease or rarely may increase in about 8 to 29%. And sometimes, unfortunately, you will see new calcification. And this dilemma of calcification, which is sometimes increase, sometimes decrease, sometimes new calcification is appear, make the assessment of the response very difficult. I will show you some scenarios for the calcification. Now you see this case with the clip and this microcalcification. Everyone, no, I am not telling the details of radiology because I know everyone knows this is irregular speculated lesion with the skin retraction and this and that. This how they start, and this after we put the clip. And this is by the end of her treatment, almost you couldn't find any microcalcification. So the calcification is disappeared, or at least decreased, which make the assessment difficult, if this complete resolution or not. And the other thing, if I had to put a clip from the beginning, if I have the belief that the microcalcification will not change, so I will not put a clip. So I will use my wire inside, and this is my clip, but it is not coming like that at all. This case, almost the calcification disappeared and the lesion is disappeared, and that's why I will report it as a complete radiological response. But discordant, the pathology is coming, and there was still a tumor inside when the surgery take it out. So I will not depend on the microcalcification. If it is disappeared, that means that this is a complete response. Sometimes the calcification will decrease, like in this case. This case shows lesion with microcalcification overlying the lesion and exceeding the lesion. And after treatment, you can appreciate the lesion almost decreases size, and this one is the clip inside, and the microcalcification is also decreased. I will show how is the picture of the ultrasound. This was this case, right 10 o'clock axis lesion, and there was this clip. This patient really, I put for her what is called hydromark. And hydromark is making some absorbed water and gives this picture in ultrasound. This is the clip and this is the fluid around. So for me, I told, okay, the lesion is almost disappeared, and this is the hydromark, and still there is a group of microcalcification only. So of course, this is the radiological partial response, because still I can see microcalcification. I couldn't see this is a complete response with this microcalcification. However, the lesion is almost disappeared, and this is a clip. And the pathology is not agree with me about this radiological picture, because there was a pathological complete response, even with this microcalcification. Again, this is another case. You can appreciate how is the lesion and how is the microcalcification outside. And by the way, this is the typical picture of HER2 positive presentation in mammogram. And you can see how is this microcalcification, and this is after the treatment. I like to put the wire in the microcalcification, and this was the clip. And of course, we reported as this is one magnified view. And of course, we write it as radiological partial radiological response, and also it comes as pathological pathological non-complete pathological response. So remaining calcification after neoadjuvant chemotherapy may not be due to residual invasive malignancy, may be due to necrosis. So when you see microcalcification in your mammogram study, does not mean that there is still the tumor is active. Okay, this is very important, and that's why it is difficult assessment by mammogram depending on the microcalcification. So mammosonographic enable prediction of the pathological response of all over accuracy 74%, especially in absence of microcalcification in the initial diagnosis. Again, we have case HER2 positive, palpable, left invasive ductal carcinoma in 41 years old woman. And this was her MRI. Now I will show you two scenarios for MRI, how the MRI is sometimes very informative and can solve the problem and can tell us the result, and sometimes no. You can see this case. This is the one pre-treatment. You can see T1 weighted MRI show multifocal heterogeneously enhancing irregular mass and non-mass enhancement in the same time. And this one is post-neoadjuvant chemotherapy, and you can show remaining of non-mass enhancement measuring about 3 centimeters according to the MRI. And when the surgeon saw this report, he says still there is a mass, and he go for mastectomy. And after mastectomy, they show pathological complete response with calcification in a benign duct that is filled with post-treatment fibrosis. So this one was calcification and fibrosis, and it was not a real tumor. And there was discordant in the result of MRI and also compared to the pathology. However, in this case, you can see nicely, this is also a HER2 positive. MRI also detect very small carcinoma in a 59 years old woman. Pre-treatment axial contrast enhancement, T1 weighted MRI image show 1.6 centimeter linear non-mass enhancement. However, in post-treatment show no evidence of residual mass. Lumpectomy also have the same result. There was complete response. Again, very important topic. We had to go to it and to answer what to clip and why to clip. Surgery after neoadjuvant chemotherapy is mandatory till now. Of course, all of us agree for this. Use of clips as a marker of the breast lesion or lesions or positive nodes, which is under research at the time of diagnosis, is effective method to guide the surgical management. Clips help wire localization in case of radiological complete response, and also clips help the pathologist even in mastectomy. So clips help the pathologist, not only the radiologist. This interesting case, I want to share it with you about how the important to put the clip and how to put the wire, and you had insist as a radiologist to do it correctly. This case really, unfortunately, come to me by this picture post-operative. Yes, post-operative. The surgeon go and by the wire, the radiologist put it, and it's not giving any documentation. She is not taking mammo after she put her wire. By the way, this is our surgical clips we are putting instead of the tissue marker because they are expensive. So sometimes in some radiologists here, I am one of them, we put a clips surgically, but the patient after in the OR, the pathologist say I couldn't find the clip. Then the surgeon told him, okay, take the specimen and give me feedback. The pathologist after maybe 4 days, he say, I'm sorry, I couldn't find the clips. Then the surgeon send the patient to me, and I find this clips is still there. And also you can appreciate the microcalcification also is seen. So what is the surgeon remove? He removed wrong area. He is not removing either a microcalcification or the surgical clip. Then we put for him a wire, and this is very important. After you put the wire or put the clip, you had to take the mammogram. If you don't have a mammogram in your place, please don't put a wire, don't go for clipping from the beginning, okay? And insist every time to do specimen mammography for the specimen from the surgery. He had to give it to you again or to the place he is working and have a picture to be sure that all his microcalcification and the clip is out. And this is my message to you, please, my dear colleague. Always clip all lesions, not one lesion. Any lesion, you had to clip it, especially if it is not a satellite. And if the lesion is the main lesion and there is a satellite, don't clip the satellite for financial issue. But if you have the lesion far away from the your index lesion by more than 1 centimeter, you had to clip it, okay? Always do mammogram after clip insertion or wire localization. And again, clip is not for the surgeon only. It is for the pathologist to be sure that he remove and make it easy for the pathologist. Okay. Now we will move to the big dilemma and the big debate about the positive lymph node to clip or not to clip. There is a study going on, and some surgeon and oncologist will ask you and recommend to clip the node. And we are clipping the node. I want to show you some, especially if you will clip one node, the one you take the biopsy from it, to assess the response. And what is the benefit to clip the node? The benefit to clip the node, if you can follow, and if you see this node is radiologically regressed in size and radiologically it is not more pathological, at that time you will wire it, and at this point the surgeon will not go and hit the axilla and make axillary dissection. This is another ultrasound showing axillary lymph node with a clip inside, and this is after we wire the node for the surgeon. There is some future direction I want to share it with you. Limitation of mammography and ultrasound, and sometimes MRI in predicting a response to neoadjuvant chemotherapy, especially with mammographic calcification. All of us agree for this. Some study is going on of image-guided breast biopsy by vacuum after neoadjuvant chemotherapy to predict residual cancer. Post-neoadjuvant chemotherapy biopsies may be able to omit surgery for patients who achieve pathological partial complete response with a negative image-guided breast biopsy after neoadjuvant chemotherapy. What does this mean? This means that they are now trying to do, if radiologically you are happy, there is a complete response radiologically, you can put a clip, then go and make vacuum-assisted breast biopsy and take it out with the clip and put another clip before you move. The pathologist, if he agrees there is a complete pathological response, that at that stage, the surgeon will not go and operate, okay? Because the operation for the cases after complete radiological complete response, it's aimed to, it is a pathological complete response. That's why the oncologist either to give treatment or no. So if we can give the oncologist the result that there is pathological response by vacuum, so we need to go for surgery. And this is what is the future, because everyone try to go for a less invasive procedure for the patient. This is only study, not yet. By the end, I want you to know this take-home message, that the radiologist guide surgical decision-making by clarifying the extent of the disease before and after chemotherapy. No guidelines for post-neoadjuvant chemotherapy imaging. Multi-modules imaging is essential for personalized HER2-positive cancer treatment. Ultrasound is more accurate than mammography for evaluating the tumor size. However, still MRI is the best imaging modality to evaluate the response. The decision to do MRI typically based on individual patient factors and clinical judgment. Still, the standard is the surgical pathological assessment. Remaining calcification after neoadjuvant chemotherapy may not due to residual invasive malignancy. CLIP is not for surgeon only, it is for the pathologist also. Thank you.
Thank you so much, Professor Amal. You did honor us today with this outstanding presentation, which was informative, directed, and well executed. And I'm sure that everyone here did benefit from the experience you shared with us today. So thank you so much for contributing towards this symposium. Thank you. The discussion is now open for Professor Amal presentation. So please raise your hand if you have any question for her, and one of us will unmute you. Or you can drop your question in the chat menu and I will read it out for her to answer it, inshallah. So any questions? Please raise your hand if you have any question for Professor Amal. There are some questions. No questions in the chat box. Everybody is thanking you, Professor Amal, and there's a question from Dr. Rabab. Let me unmute her.
دكتور عمر، السلام عليكم ورحمة الله. حقيقة نحن
عليكم السلام.
سعيدين بك كتير، سعيدين بك وبكم جميعا. وقبل ما أنسى البروف جبال لما رحب وشكر قاصد بهية وليس هنية، بهية المصرية، مركز بهية. طيب فأنا نسيت، كنت عايزة أعلق وأقول إنه البروف كان قاصد بهية، فبيشكر سعيهم كده.
يا دكتورة رباب، أنا أخذت بالي إنه نطقت وكنت عايز في نهاية المحاضرة أعتذر عن الخطأ الغير.
لا ما خطأ يا
خالص.
أعتقد
هنية مصري أصيل برضه، أعتقد اسم هنية مصري أصيل برضه، هنية وبهية.
بس لأنه مركز هنية عندنا في السودان، عرفتي؟
طب شفتي
بس أنا قصدت أوضح عشان في مركز هنية وفي مركز بهية.
واو،
مفيش أي خطأ والله.
بالعكس يعني اهو انت اثبتي اهو ان هو واحد، بهية وهنية. بهية كانت ست مصرية طبعا، من الاسم واضح ان هي مصري اصيل جدا يعني، وكانت يعني كان جالها بريست كانسر، وكانت عندها من القدرة المادية انها تتبرع بالارض كلها اللي في دلوقتي اتعمل عليها بهية، وبطريقة يعني سبحان الله ربنا يعني فعلا اللي بيبارك أول ما بتبقى حاجة كده خيرية. زي ما انتم شايفين ابتدت مجرد حاجة صغيرة اللي دلوقتي ان احنا بيفتتحوا الفرع الثالث تقريبا
ما شاء الله.
لمؤسسة. لما بروح I was so impressed ان انا شفت كل البريست سنتر في العالم من الناحية دي، لكن ان هي كانت بهية القدرة على ان اي مريضة بتدخل من غير اي طلب اثباتات او اي حاجة، ان هي تقدر ان هي تطلب انها تتعالج مجاني من from A to Z من غير ما اي حد يسألها اي حاجة، وبتاخد كل العلاج بالتشخيص على قد ما يقدروا بالكيمو كله مجانا. كل المؤسسة مبنية على التبرعات من المصريين ومن خارج المصريين. يعني it's impressive الصراحة institution.
نحذو حذوكم إن شاء الله.
إن شاء الله.
عمل سنتر
واحدة، هي واحدة بهية هنية، هي واحدة
عمل المهم عمل الخير يعني.
طبعا
أكيد يا برو.
احنا يعني ربنا يضيف لها في ميزان حسناته ويشفي كل المرضى. ويعني بس يعني هي تكون ذاته في السي في بتاعكم انه يعني احنا طلعنا من الحرب والشباب طلعوا من التريننج، فكانت دي أول نافذة فتحت لهم يعني بكل أريحية. يعني أنا كنت
أيوة والله صح يا بروف، والله
يعني
أنا أول
النافذة الأولى اللي فتحت لنا،
ربنا يبارك.
والرغم من إنه أغلب النوافذ قفلت، هذه النافذة الوحيدة اللي فتحت
فعلا.
وكانت فعلا. يعني انبسطنا منها شديد والله العظيم. يعني ما تخيل لما ما تلاقي مكان تدرب فيه الشباب يعني، وفي واحد يفتح لك النافذة.
أنا كنت سعيدة إن أنا شفت كتير منهم برضو في المؤتمر الأخير في يناير في القاهرة كتير، وسلموا عليا وسلمت عليهم، وكنت مبسوطة بالحضور من ناحيتكم. ويعني من غير ما تقول كده احنا أهل حقيقة مش كلام يعني.
والله يعني انت
ربنا
سبقتيني
يخليكم.
لانه اصلا نحن جايين نشكركم يعني على يعني الفرصه اللي فتحتوها لناسنا وقدروا يعني حضروا وفعلا جو مبسوطين جدا. وانا كنت تاركه الفرصه لدكتوره إيلاف معانا هنا من الحضور انها في بعدين حتعلق لكم على
جميل.
الحضور
دكتورة
وكده.
أمل حجازي كمان اسكندرية، فيعني عندكم هو في القاهرة وعندكم اسكندرية. ودكتورة أمل من أحسن الناس اللي لما فعلا بتاخد إن حد هتعلمه أو كده، يعني بيبقى هو سو لاكي. أنا نفسي أكون عندها.
ما هو واضح من البرزنتيشن. أول حاجة دكتورة أمل thank you very much for accepting our invitation. Okay, we
بالعكس،
really
ده أنا اللي
enjoyed
مبسوطة إن أنت اديتينا الفرصة دي. والله أنا مبسوطة إن أنت
your
اديتينا الفرصة دي.
fascinating talk about this evolving radiological topic, the HER2 positive. يعني you are giving us an update about new radiology, emerging radiology topics. But I have one question. In your experience, regarding, I have seen that most of your patient mammography, the density is relatively low. But what about your experience with relatively low density? The mammographic density, most of them about يعني ACR 1, 2.
B.
Okay. A or B, sorry.
Yes.
I forget
A, yes.
A and B. A or B. Still 1 or 2 in our mind. We are starting from earliest ACR. A or B. What about the dense breast, the effect of the reading mammography, neoadjuvant effect on mammographic in a dense breast? This is one question. In your experience, how does it help you? How does it help you? This is one question. The other question, I observed in my practice, the neoadjuvant chemotherapy affect the density of the breast itself. And sometimes there is reduction in the mammographic density and in the fibroglandular tissue on ultrasound. Can you tell us about this from your experience? Any, and you can add for us any information?
Okay. First of all, about the dense breast, I am not showing dense breast, but we have. But I choose the cases with ACRB to just make it easy to understand the response. But in dense breast, I had to go for MRI, of course. I couldn't depend on mammo. From the beginning, for dense breast and HER2 positive lesion, directly we will ask for contrast study because we want to know how is the extent is going, how is the it is only one lesion, it is or multicentric or multifocal. We will not. That's why I choose only the cases, the simple cases with ACRB.
Sorry, but I'm asking for this point because sometimes surgeons, they are not accept to recommend for them MRI. So that is why I would like to emphasize on this point.
It is very difficult because MRI is
why not only mammography and ultrasound?
No, I show the cases that I can solve it by mammo, but that's not mean that we had to go like this by mammo and ultrasound only. These cases, I will not ask for MRI. This is what I want, this message I want all the radiologists to understand it. What is this? Not every case we had to do MRI. It is a how to select the case to go for MRI or contrast, or you will solve the problem by the data, but the mammo and ultrasound. So if you are a good sonographer and your mammo is digital and good, and the lesion is very clear for you, okay, no need for MRI. But if the patient have dense breast, you had to go for MRI. Definitely, you had to go for MRI or contrast study. It is not solved like this. So what I presented is the simple case. I can solve it by mammo and ultrasound. And I want again to say, an ultrasound is sometimes very important in assess the response than mammo. Maybe after you did the mammo, like you tell Dr. It's very good observation that the density will less after the treatment, and you feel that the region is not seen. But when you do ultrasound, it is clearly seen. We will depend on other criteria, helper like elastography, the vascularity, to assess the response. But MRI is the gold standard for reassess the response in the dense breast. But not every case I will go to do MRI.
Not every case need MRI. I agree with you.
No.
But in a good hand, doing ultrasound. Because ultrasound, yes, because ultrasound is an operator dependent and can easily miss and not well evaluate the residual disease.
In the last meeting, we met Dr. Jessica, and everyone know her, and I asked her very direct question. Did you in US make MRI for the patient, asking at how many MRI you will ask? And so simply she say, I have a very good radiographers who did for me a very good ultrasound. I can depend. It is a selected case who I go for MRI. So MRI had to be by selection according. Very strong positive family history, BRCA positive, very dense breast, lobular carcinoma, I need to with dense breast. Some selection for the case. We need to teach our junior staff how they select the case to send it for MRI, not to abuse the MRI.
And now you can add a Sudanese lady with breast cancer. After you will see how the breast cancer is spread through the easy spreads across the midline to the contralateral breast. I'm looking for your cases. I told Dr. Rasha or Prof. Rasha that her cases early breast cancer, there is no chance to compare with my cases. But even your cases, I haven't seen any features of cross-midline spread of breast cancer in your cases, even they are advanced or relatively advanced.
No, we have advanced case in Egypt. We have.
But let us see.
But we are not recording them. Maybe they are not that much with this. They are not coming to us, maybe. But sometimes it's coming, especially in the. I have case 18 years old with a sizable breast mass with lung metastasis and the skipped axillary lymph node. We have cases very bad.
Sorry, can you tell me again?
We have case 18 years old.
Yes.
Girl presented with a lung mass. And when we start to know from this mass from where it's come, by CT, she is doing for hemoptysis and incidentally find a left breast mass in 18 years old. It was invasive ductal carcinoma, triple negative, and skipped axillary lymph node with metastasis to the lung. We have cases.
Unusual. Unusual.
Yes.
Unusual. Yeah.
Yes, unusual. But I will, inshallah, I will join your cases by 5 o'clock.
Inshallah.
Professor Amal, I have a question from the chat box. Dr. Noor is asking, she thanks you for the great lecture to begin with. And then she asks, what about the added value of contrast-enhanced mammography in evaluating the response, especially in complete response?
Okay, the same answer like MRI. Contrast mammogram, if you can see it well by mammo, it is not in hidden place, seen only by MRI. Always start what you start, what you follow. Contrast enhanced mammography is a very good modality. Sometimes like MRI, if you have a dense breast, if you have to be sure there is not multifocal, multicentric lesion, and if you diagnose it by contrast mammography, of course, you had to follow by contrast mammography. Assess a response by contrast.
Yes, thank you so much. There are so many thank you notes in the chat box for you, Professor Amal. وشرفتينا ونورتينا. And we're so happy that you were able to join us today, and we are looking forward to welcome you soon, inshallah, in all of the upcoming events held by the Sudanese
بجد
Society of
انا
Breast
اللي مبسوطه
Imaging.
جدا على الدعوه
الله
الكريمه
يخليكي.
دي، وان شاء الله نبقى مع بعض على طول
بإذن الله.
ونشير اور اكسبيرينس مع بعض باذن الله. شكرا
بإذن
لكم.
الله. متشكرين
إن
أوي.
شاء الله.
بإذن الله.
نشكرك
إن شاء
مرة
الله.
ثانية وسعيدين بك إن شاء الله.
الله
شكرا.
يخليك يا دكتورة.
الله يكرمك. Allah يكرمك.
Dear all, on behalf of Dr. Rabab Al-Hassan, which is a consultant radiologist from UK, we apologize that she had to cancel her presentation today due to an urgent matter, and we wish to see her soon, inshallah, in the upcoming events. Now we are going to take a break before the start of the second part of the symposium. And we are going, excuse me?
Not me, not me. Someone asked Dr. Rabab, not me, Dr. Rabab Al-Hassan from UK, not Dr. Rabab
Al-Hassan from UK. Yeah.
Not Dr. Rabab Bella.
Dr. Rabab Al-Hassan from UK, she had an urgent matter and she had to cancel her presentation today, which was supposed to be now. So we are going to go for a break before the second part of the symposium. And when we come back, inshallah, we're going to welcome Dr. Mirat Al-Mudawi, who is going to share with us her knowledge and experience in dealing with fat necrosis and auxiliary imaging guided intervention. So we'll meet again, inshallah, at 1:15 p.m. Khartoum and Cairo local time, which is equivalent to 11:15 a.m. GMT. Thank you all for your attendance and contribution in this session. See you all at 1:15 Khartoum and Cairo time. Thank you.
After how long?
Which is exactly around 1 hour from now.
Okay, thank you.
Yep. Thank you.
Thank you very much. Thank you. See you after the break, inshallah.
Inshallah. Welcome everyone to the second part of today's symposium, which is discussing the different perspectives in the management of breast cancer. Before the break, we were honored to attend very nice and insightful presentations and discussions by both Professor Rasha Kamal and Professor Amal Hijazi. Now, please join me in welcoming Professor Meret Al-Mudawi, a breast imaging consultant radiologist. She's also the director of Bakhsh Breast Care Center in Jeddah. She is also chair of Egyptian Society of Breast Imaging and holding a breast imaging fellowship from Toronto and Ottawa universities in Canada. Professor Meret will be sharing with us today her knowledge and experience with regard to fat necrosis and auxiliary imaging guided interventions. Professor Meret, you can share your screen now and start your session. وأهلا وسهلا بحضرتك، نورتينا.
أهلا بيك يا دكتورة إيلاف، أهلا بيكم كلكم
الله
والله.
يخليك.
Very great honor. كده my screen I think.
The screen is
دكتورة
visible.
نورس اللي قدمتك يا دكتورة مريت. دكتورة نورس اللي قدمتك اللي حبيتي
أهلا بك.
حبيبتي نور.
الله يخليك. الصوت واضح يا بروف والسكرين برضو واضحة.
اوكي
اتفضلي حضرتك.
احنا يعني كانت لسه البرزنتيشن دي I presented في last week International Cancer Conference للبريست and gynae oncology, و I was so happy to see many of from يعني your side من السودانيز breast imaging society كانوا حاضرين، و يعني يعني برضو inviting you انكم تعملوا حسابكم next year 2026 برضو January انكم تكونوا معانا ان شاء الله
بإذن الله. متشكرين قوي يا دكتورة على الانفيتيشن دي، يعني كل الناس اللي حضروا كانوا very impressed with the
الحمد لله، وان شاء الله السنة الجاية نرتبها كمان more organized
بإذن الله
للممبرز your society.
إن شاء الله.
يعني هو الفات نيكروزس يعني I like to call it it's يعني name الجريت ميميكر. فعلا هو الجريت ميميكر لينا، اللي هو one of the most benign conditions that confuse us with malignancy، وبتخلينا radiologists و clinicians زي ما بيقولوا stand on toes، مش عارفين ان احنا ناخد فيها قرار. ف يعني today's goal للبرزنتيشن دي او our objective من البرزنتيشن is it how to diagnose fat necrosis و establish a diagnosis و distinguish it from malignancy. لا الصراحة this is not the goal و it can't be that accurate even للmost expert breast imagers. وهنشوف ليه، لأن هو في overlap features كتيرة و a lot of tricky challenging cases. Our real goal of this talk is developing our intuition to determine when to do a biopsy, when not to. يعني إن إحنا how to develop our level of suspicious بطريقة إن إحنا نقدر من خلالها decide which case deserve a biopsy, which case we should let her go. و I will tell you برضو ليه مهم إن إحنا يعني not to biopsy all the cases. Let's start with a quiz case. الكيس دي she is 34 years old, had a nipple sparing mastectomy 2 years ago زي ما انتم شايفين على left side, و had a reconstruction للبريست بإمبلانت, و she was due for her annual surveillance MRI when we found this new asymmetric non-mass enhancement the inner side of the contralateral breast. This was her mammogram. As you can see هنا في lower inner quadrant في the other side. You can notice in the other side also had a reduction mammoplasty من الليفل بتاع النيبل. إن إحنا نقدر نقول إنها كان في contralateral reduction mammoplasty for cosmetic طبعا reason مع the other breast reconstructed. This is the magnification view. You can see طبعا linear distribution indeterminate group of microcalcifications in a linear distribution. Is it DCIS? Is it fat necrosis? Again, this is not our aim إن إحنا to establish a diagnosis. Our aim, should we biopsy this case or not? Keep in mind وإحنا revisit this case later through يعني during الtalk دي. Let's start من البيزك. إيه هو الفات necrosis? What's fat necrosis? الفات necrosis dying للأديبوز tissue. الريزلت من الداينج ده إنه بيحصل degeneration, cystic degeneration which initiate type of inflammation process. هو بيقول non-suppurative inflammation طبعا ما هيش بكتيريا، بس هي inflammation في التيشو will lead to more phagocytosis, fibroblast proliferation, which في الليت ستيج بتأدي بقى للفيتشر اللي احنا عارفينها، السكارينج، الفايبروزس، الكورس دنس، typical calcification of fat necrosis. يعني I wish ان انا اقول لكم ان الفيزز are that clear distinction، لكن actually الفيزز of fat necrosis it's overlapping زي ما احنا شايفين الفيتشرز overlapping على بعض. فطبعا اذا كانت هي overlap على الباثولوجي ليفل فده معناه برضو ان هي it's overlap على الراديولوجيكال ليفل الراديولوجيكال فيتشر. overlapping او الفيتشرز بتختلف يعني through الانترموداليتي different modality between الالتراساوند المام والام ار اي، وكمان overlap during over time يعني اللي احنا بنشوفه في الايرلي غير اللي في الليت. فالفيتشرز vary a lot. في some of them are typical, some of them are not typical.
Dr. Mary, you're mute. We cannot hear you.
دكتور ميرات.
سوري
يلا
كده جت. فزي ما مثلا اكزامبل اللي احنا شايفين ممكن ان انا اشوف ماس في الالترا ساوند. however when I correlate مع الام ار اي it's a typical oil cyst with calcified thin calcified margin ان انا اقول لا خلاص I'm pretty sure. however يعني I need to wait for 8 years مثلا عشان تبقى في الماموجرام very typical coarse calcification عشان ما تلخبطنيش في الالترا ساوند ان هي مدياني hypoechoic shadowing area. هنا مثلا lumpectomy bed في calcifications at start او early phase بتبقى very confusing for us ان هي لو في اي recurrence، لكن over the year we are more sure that it is a calcified post-operative fat necrosis. في البيت سي تي فيوجن زي ما احنا شايفين في uptake في الاف دي جي، لكن لو احنا نفس البيشنت في الام ار اي it's typical fat signal intensity. عشان كده الانترموداليتي correlation it's a crucial في الفات نيكروزس. الفاريشن اوفر تايم مهمة جدا ان احنا نبقى aware بالتشينج اللي بتحصل. طيب زي ما قلنا بقى في الأول، طب how to develop this يعني عشان كده احنا دايما بنقول الفات necrosis is the too many phases of fat necrosis. طيب too many phases ازاي ان احنا بقى نديفلوب دي الانتويشن او الليفل اوف suspicious. I categorized it ان احنا نيفالويت الفيتشرز اللي قدامنا based on the etiology. الاتيولوجي اوف فات نيكروزس يعني لو ان احنا نعملها يعني الموست كومن او الفيموس جروب للاتيولوجي بتاع الفات نيكروزس عندنا التروماتيك فات نيكروزس او كل ما هو له علاقه بالانترفنشن من بايوبسي سيرجريز راديوثيرابي otherwise. and واللاست ثينج اللي هو كوزموتيك الحاجات اللي ريليتد لللايبوفيلينج واي كوزموزس في البريست. خلينا ناخد اسهل جروب اللي هو التروما سهلة جدا. patient جاية تقول ان هي she had a trauma, recent trauma يعني زي this patient came 44 years old, noticed a palpable lump a few days after heavy object fell on her chest. فطبعا she gives this history. لو هنشوف الريبورت اللي مكتوب ان هو شايف lesion زي ما احنا شايفين وعند كذا وقال المقاسات بتاعته، وفي الكونكلوجن والامبريشن suggestive of fat necrosis. طبعا based على هنا ما فيش based ما فيش اي criteria described، ما فيش اي features I see في الريبورت just من الهيستوري هو conclude ان ده fat necrosis. however انا مش شايفه حتى دوبلر انتروجيشن للفاسكولاريتي جوه. السيستيك كومبوننت ما هواش يعني سيستيك كومبوننت peripheral than central. يعني I don't see much feature يعني support this conclusion. طبعا it was too late لما after few months the patient came back with locally advanced breast cancer reaching للسكن، لأن هي it didn't develop because of the trauma. هي when she was feeling her breast after the trauma, she felt already الcancer it was already developing in her breast. فدي التريك بتاعت ان احنا ما ناخدش الهيستوري as it is without يعني supportive evidence. دي مهمة جدا في الفات نيكروزس، وكنت برضو بقولها دايما في برضو واحدة من الموست تريكي هيستوري الجلاكتوسيل، ان دايما لما بيقولوا البريست فيدنج اول حاجة اول ليجن بنشوفه نقول عليه جلاكتوسيل. فنفس الحكاية اول ما تقول البيشنت تقول لنا تروما بناخد على طول الفكرة ان اكيد اي ليجن هنشوفه هو فات نيكروزس. لا، ف this is why يعني don't jump to the conclusion من الفاكتس اللي هي تروما للconclusion without enough evidence. ايه هو البريدج بتاعنا عشان ان احنا نروح للconclusion بsafe و appropriate practice، وليس فقط ان jump to the conclusion ان انا يبقى عندي enough sufficient imaging criteria. ايه هي الكرايتيريا؟ هنقول مثلا comparison اهو ل another case. الكيس دي 32 years old, history of trauma 2 days. First thing when I inspect يعني نفتح اللايت بتاع الالتراساوند روم ونinspect السايت بتاع التروما I really noticed bruises, ecchymosis, bluish discoloration على الاريا اللي هي بتقول عليها. دي أول حاجة ادتني يعني شوية assuring في أو lower level بتاعي of suspicion. التاني feature of the lesion itself زي ما احنا شايفين هو kind of superficial. حطيت الدوبلر كان ما في كان avascular. الكونسنتريك بتاع السيستيك بتبقى دايما يعني concentric evolution من جوه لبره. الهيماتوما زي الهيماتوما مش سيستيك نيكروزس على في البريفري. وفي اللي هو الهايبر ايكويك ريم اللي حواليها في نفس السايت. يعني دي كانت more assuring ان انا عندي enough evidence ان انا خلاص doesn't deserve biopsy, we can follow it up. الليفل of suspicion بتاعي كان يعني lowered خالص ان انا اقول وماشيه مع يعني correlate مع الكلينيكال هيستوري مع الانسبكشن كده. فالتروما خلي دايما الكلينيكال كونتكست موجود، الكلينيكال ساينس، وده برضو رول از راديولوجيست مش بس الكلينيشن. وtypical imaging feature sufficient enough ان انا اقول انه ده تروما يعني sequel of a trauma. نخلي البوست انترفنشن ده في الاخر لان هو اهم جروب، وخلينا ناخد اللايبوفيلينج او الكوزموتيك purposes. I'm not sure how common هو في يعني في your people. هو اكتر كمان في الجولف اريا من مصر كمان. بنشوفه اكتر كمان في الجولف اريا. فبس يعني ممكن ان احنا انكاونتر اي بيشنت، وخصوصا الموضوع ابتدى ينتشر جدا موضوع الفات جرافت واللايبوفيلينج واللايبوفيلينج whether ان هو اوتولوجس من الفات نفسه لما when they are doing liposuction ويرجعوا يعملوا فات اوتولوجس، او ان هو اصلا يعني artificial filler، انواع فيلر بتتحقن. فالصراحة الموضوع بيزيد دلوقتي، ويعني يعني الامبلانت كان احسن في لينا كراديولوجيست في الفيجواليزيشن. طيب ايه هي الفيتشرز الفيري تيبيكال لللايبوفيلينج الفات نيكروز؟ حاجات تيبيكال فور ماموجرام ان احنا بنشوف زي ما احنا شايفين variable size dilucent lesions with surrounding اللي هو الدنس very thin calcified rim للاويل تيبيكال اويل سيست والبايلاتراليتي. يعني ان احنا بنشوف نفس المنظر بايلاترال في الناحيتين باليوسنت سنتر. ده تيبيكال فور ماموجرام. طب ايه هو التيبيكال ايفوليوشن ستايل اللي هو على مر بقى زي ما احنا قلنا over time ان ان الريم اوف دنس ريم ده بيبتدي يتحول ان هو calcifications زي ما احنا شايفين لغايه لما تبقى very typical oil cyst with thin calcified rim. طيب second الالتراساوند typical الفات نيكروزس بتبقى cystic lesion avascular طبعا فيها يعني الهايبر ايكوجينيك ريم، وكمان فيها هايبر ايكوجينيك كومبوننت ممكن لا. بس لما بنشوف الهايبر ايكوجينيك كومبوننت او الايكوجينيك باندز اللي بتتحرك shifting with the patient's position ده very characteristic. لما بنشوفها وبسأل patient to lie on her side واستنى 2 minutes أو minute كده وأشوف، هلاقي إن ال echogenic parts اللي جوه دي it's floating, it's shifting في البوزيشن بتاعها. ده بيبقى very characteristic يعني very assuring. over the time دايما بيبقى الفات ده بيجت oblong وفلاتنج. يعني في الأول early بيبقى rounded يعني after يعني few months و years بيجت oblong وflattening. هتشوفوا أمثلة دلوقتي. الMRI طبعا هو fat signal intensity follow the fat signal intensity in all sequences. ده ال characteristic thing. ما evaluate كل السيكونس. ممكن يبقى فيه sin enhancing fibrotic rim وده characteristic للكوزموتيك procedure عكس هنشوف بعد شوية later الفات necrosis post procedure ما بيبقاش الريم very thin وفيري يونيفورم وفايبروتيك. ممكن ان هو في البوست سيرجري بوست انترفنشن يبقى شويه irregular، لكن في اللايبوفيلينج هنلاقيه ان هو very thin uniform fibrotic enhanced rim. فدول كلهم كاركترستيك للفات جرافت او اللايبوفيلينج. فطبعا من الحاجات اللي تدينا assurance البايلاتراليتي، ان هي get flattening over the time و developing rim of calcification في oil cyst، وان هو follow fat signal intensity in all MRI. يعني some of you دلوقتي اكيد بيقولوا لي طب والهيستوري، يعني ده الحاجه easy جدا، يعني ان احنا تبقى البيشنت اول ما تقول لنا ان هي عامله she already had a lipofilling او cosmetic procedure، ده كده خلاص هيسهل لنا الموضوع. بس انا يعني I'm sorry, I'm afraid and tell you in this category of patient from my experience يعني it's not always open أو بيقولوا the truth. يعني بمعنى إن those category of patient many of them يعني في الأول they don't admit إن هم عندهم إن هم they did a cosmetic procedure. و sometimes we find يعني hard time إن إحنا يعني make them admit. يعني عايزة أول ما تدخل الكلينيك make them يعني I swear I'm telling the truth nothing by the truth عشان إنك تصدقيها يعني. فدي my experience. والحقيقة في الكونفرنس برضو أول ما قلت الحتة دي لقيت كل الأودينس بيقولوا أيوة we encountered such problem. هم مش معتبرين إن دي إن هم they went through حاجة cosmetic. I will show you an example. فسواء بقى البيشنت admit not admit فبس احنا لازم نبقى عارفين الكاركترستيك دي. This patient for example 6 years old, she came with her husband with growing hard palpable lump where she gave us no history of any breast intervention. As per the patient the first يعني scan طبعا I was shocked ان هو يعني this struck this complex lesion. وطبعا يعني أول ما شفته it's a complex lesion we need a biopsy و solid cystic part. Then scanning other quadrants I see a similar lesion. Scanning the other breast I see similar lesion. This is when يعني ابتديت بقى أفكر إن لا ده مش it's not a malignant process أو كده. يعني under pressure بقى يعني هي she was like يمكن maybe my surgeon my plastic surgeon بس I'm not sure كده يعني. فطبعا يعني مع إصرار البيشنت that she didn't had something بس أنا very assured إن خلاص دي lipofilling. يعني as a matter of precaution I had her to come follow up. After few months as you see it's getting more elongated. يعني زي ما قلنا بقى not rounded, make more flattening, more fat injection inside, more fat signal inside. And I show you after 18 months how it's very features over the time. هنا برضو ابتدت تبقى very flattening و elongated والcystic component versus الفات بيبتدي ان هو يعني alternate كده. فده كله كان هي by the time بقى يعني she admit أخيرا. عشان كده أنا هنا كاتبة حتى fat injection لما خدت منها الاعتراف بقى. this is an example. example تاني this is another companion patient. This patient الحقيقة هي يعني she was open إن هي she had an autologous fat graft. كانت عاملاه في مصر و as you see يعني ان احنا شفنا اوكي a large big bubble كده من الفات injection على two sides. بس we have a very important rule في الراديولوجي اللي هي satisfaction of search. يعني لما when we see something يعني interesting كده في البريست always remind yourself ان هو not to distracted by the finding we see and keep looking, keep searching على أي other finding. فaway من ال two big glob دي اللي موجودة can you notice هنا any يعني suspicious finding? Do you see here? يعني do you see the difference between the right وال left? هنا الليفت فيه really في something focal asymmetry مع architecture distortion وباين اهو في الtomosynthesis. You can see here ان في irregularity كده تحت ال fat injection globule هنا. ف this يعني take my يعني catch my eyes. ف because of this one we ask for طبعا بالالترا ساوند as you can see التو سايد في large oval ما فيهاش vascularity لكن يعني typical ل fat injection. However I can't get much information about the lower border عشان هي very deep اللي احنا شفناه في الماموجرام. عشان كده we proceed ل MRI. Let's show you ال MRI. Can you see here البارت اللي هو under under the left fat graft. عايزة أوقفه بس هنا. This is asymmetric non-mass enhancement. طبعا ده raise my suspicious وده طبعا abnormal finding. I can't say إن ده fat necrosis كده يعني في حاجة asymmetric و non-mass enhancement. يعني أيوة هي عند lower border of the fat injection بس it's not يعني typical sequel للفات injection. الحقيقة طبعا خدنا منها biopsy under stereotactic عشان نتارجت اللي هي الاريال اركتكتشر ديستورشن وطلعت اتيبيكال داكتال هايبربليزيا وفايبروزس وزي ما كنا بنقول هيستوسايت رياكشن يعني ان هي الانفلاماتوري نون سابريتيف انفلاميشن بروسيس وفاجوسايتوزس دي اللي بتسبب لنا كل الفيتشرز اللي احنا بنشوفها. نو invasion, no in situ, no invasive malignancy, pure benign findings. في نفس الكاتيجوري اوف بيشنت هنقول الكيس دي دي تالت كيس بعد الكيس دي هنقارن الفرق في المانجمنت والورك اب للثري كيسز بتوع اللايبوفيلنج والكوزماتيك. فخليكم بس معايا في دي انا عارفه لخبطت كتير. فالبيشنت دي 51 هاي ريسك جروب بيشنت هاي ريسك في positive family history. She came because of palpable hard lump في right breast وأنا يعني I remember إن هي more than الهارد lump كان البين كان في severe pain في الchest wall عند الرايت سايد. لما خدنا الهيستوري كان في implant removal كان في implant she removed it a couple of years ago. When we did the mammogram with the prior mammogram after removal للimplant we see this irregular dense area speculated زي ما احنا شايفين هنا associated ب microcalcifications. see and determined microcalcification مش عارفة واضحة فبس كان في لسه feature كده اللي هو الليوسنت سنتر بالرغم من very suspicious appearance. مع الهيستوري اوف implant removal يعني احنا we thought to slow down وان احنا نكمل الانفستيجيشن بتاعتها. وطبعا بالالترا ساوند كانت برضو ميكسد هيتروجينوس كده هايبر وفيها سيستيك كومبوننتس صحيح ما فيهوش فاسكولاريتي بس هو ديب لوكيشن فبرضو يعني not much evidence يعني. لكن لما proceed to the MRI شايفين ايه ده الاريا اهي في الرايت بريست اللي هي typically correlate ل center of fat signal intensity زي ما احنا شايفين. الريم ما هوش يونيفورم لان هو مش زي الفات جلوبيول انجكشن اللي شفناه لكن هو مكان فات نيكروزس من مكان السيرجري بتاعت الامبلانت ريموفال عشان كده هو شويه irregular زي البوست لامبكتومي برضو هنشوفه بعد شويه. لكن الفيتشر الكاركترستيك اللي مخلياني ان انا خلاص كده يعني انا السسبشنز بتاعي قل كتير، وجود ان السنتر كله فيلد بفات سيجنال انتنسيتي. ولما بقول فات سيجنال انتنسيتي في كل السيكونسز مش بس ده، فلما يعني I interpret و assess كل السيكونسز السنتر كله فيلد بفات سيجنال انتنسيتي. طيب في حاجه كمان قللت السسبشنز بتاعي، لما هنشوف الاذر سايد الكونترالاترال بريست، شايفين دي هنا ايه دي؟ It's another يعني center of يعني lesion filled center of fat signal intensity في نفس الاريا deep ورا posterior في البريست. طيب لما عملت second look ultrasound correlate ليه؟ anechoic زي ما احنا شايفينه very deep نايم على المصل هنا في الانر aspect بتاع الليفت بريست، وanechoic خالص cystic lesion في نفس المكان which assured me ان ده كله الناحيتين related ل fat necrosis للimplant removal procedures. ودي كانت يعني وصلت للاnechoic الاويل cyst اسرع من الاذر سايد، لكن it's very assuring. ما كانتش باينه في الماموجرام لانها very very deep inside. فبناء based على these features زي ما انتم شايفين الليفل اوف suspicions بتاعي قل كتير. عشان كده البيشنت دي يعني we didn't proceed ل stereotactic biopsy target disease calcification. فهنا خدنا الديسيجن كان صح لان يعني هي باي تشانس كانت نيد سيرجري يعني افتر فيو مانثs. كمان البين بتاع الفات نيكروزس اللي هي تقريبا هنا عامل تيزرنج للمصل جامد زاد جدا عليها، فكانت السيرجري عشان تريموف البين للفات نيكروزس اللي كان هنا من على المصل. فلما جت سيرجري كان الباثولوجي الفاينل باثولوجي ريزلت ان ده كله فات نيكروزس بروسيس. فكان قرارنا صح بان احنا ما خدناش هنا بايوبسي، وكنا هنمشيها على فولو اب، بس هي حتى اندت بسيرجري وتاكدنا من الباثولوجي. ايه يعني التيتشنج بوينت من التو كيسز دي؟ يعني التو كيسز دي زي ما احنا شايفين، الكيس اللي هي الاولانيه اللي هي اللي فيها لارج فات انجكشن، وهي بتقول انا عملت فات انجكشن، وشايفين ان ده ممكن يبقى سيكوال وقريب وريليتد للبروسيجر بتاعت الانترفنشن، لكن we take the decision to biopsy. صح؟ ليه؟ لأن الفيتشرز بتاعتي ما كانتش تيبيكال، الليفل اوف سسبيشس بتاعي ما كانش انف ان انا يعني ميك شور ان انا خلاص انا يعني مطمنه واشورد ان ده حاجه تبع. كان فيه اتيبيكال فيتشرز ما هياش مطمناني، الليفل اوف سسبيشس بتاعي ما كانش لورد، كان بيزيد. العكس بقى البيشنت دي بالرغم ان هو الفيتشرز البريليمينري الاولانيه كانت very suspicious وزي ما انتم شايفين، لكن مع ان انا بكملت الورك اب بتاعي ومع ان انا كملت يعني حطيت كله in context واحد وشفت البايلاتراليتي وكده my level of suspicious قل جدا. و this case we didn't take a biopsy. فدي الفكرة ان احنا how to work up او manage these types of cases. اتمنى اكون يعني وصلت لكم النقطة دي. فهي اللايبوفيلين كوزموتيك بايلاتراليتي الفلاتنينج الريم كالسيكيشن الفات سيجنال انتنسيتي وwhether the patient يعني قالت او لا او حطينا الكلينيكال كونتكست في الموضوع. اخر كاتيجوري هو الاهم. الكاتيجوري الاخير طبعا اللي هو كل البوست اوبراتيف بوست انترفنشن سيرجريز فات نيكروزس اللي ريزلت من كده. هنقول الكويز كيس اللي كانت في اول المحاضره طبعا قلناها، فلو فاكرينها ان هو كانت 36 years old كانت having a nipple sparing mastectomy على ال left side 2 years ago. She was due for her MRI surveillance, routine surveillance, when we noticed this asymmetric non-mass enhancement في الأذر في contralateral breast اللي هو كان معمول له يعني reduction mammoplasty عشان يعني correlate مع السايز بتاع الأذر treated breast. بالماموجرام كان في الكالسيفيكيشن دي وبالماجنيفيكيشن زي ما احنا شايفين كانت linear و very indeterminate more like a microcalcification in a linear distribution. طيب based على اللي فات احنا هنا ناقصنا ايه او يعني ايه ال next step؟ احنا already عملنا ال MRI. Should we go directly and biopsy this كالسيفيكيشن هي عشان 36 عشان question ده برضه اتسأل لي، هي عشان 36 احنا كنا بادئين بام ار اي، ما كناش بادئين بماموجرام، ولما عملت الام ار اي وشفنا ده عملنا الماموجرام، والماموجرام طلع الكالسيفيكيشن. ناقص 1 ستيب قبل ما اخد القرار بتاع biopsy. I want to explain why why decision of biopsy في this category of patient is very يعني critical. Don't take it يعني إن هو يلا let's go biopsy. This type of patient had a harsh journey. كل البيشنتس اللي مروا بالبريست كانسر journey هم خلي بالك يعني هم went through a very harsh journey. كون ان انت تدخل عليهم تقول لهم يلا we are suspicious ل recurrence, we are suspicious ل contralateral malignancy, let's go do a biopsy. It's not easy. It's يعني انت يعني في اللحظة دي بننزل السايكولوجي السايكاتري بتاعهم السيلف بتاعهم ان هو وده بيأثر على الاميونيتي بتاعت البيشنت يعني. فلازم ان احنا نبقى كيرفول قوي في this category of patient. انا عارفه ان هو قرار صعب من ان احنا نسيب patient زي دي من غير بروف.
الفات سيكونس فات نون فات سبريس سيكونس. وات اباوت نون فات سبريس سيكونس؟
زي ما انت شايفه هي كانت زي ما انت شايفه كانت ما كانتش ليجن قادرين نشوف السنتر بتاعه.
نون ماس لايك انهانسمنت لكن
ما كانش
ده نون فات.
ايوه الفات ما كانش فيري يعني هيلبفول لان زي ما انت شايفه هي مش ليجن وله سنتر قادره اعمل له ايفالويشن.
It's non-mass like.
كان more like non-mass. كان more like.
This is really challenging. Yeah, it is a challenging case. As the distribution is suspicious.
طبعا واللي حتى
the calcification on mammo linear and segmental is also suspicious.
And I wouldn't blame يعني I wouldn't blame anyone.
He has personal history.
طبعا.
But at the same time she has surgery on the same breast.
أيوه.
That still can be fat necrosis.
طبعا ما عشان كده I wouldn't blame who take a decision ان هو يطمن let's do stereotactic. بس لكن انا بلفت النظر وبهايلايت ان البيشنتس دول ان احنا نحتاج ان احنا نعمل اقصى more efforts عشان نجنبهم اي حاجه ونقدر ان احنا to avoid عشان their يعني well being وان هو الهارش جيرني اللي هم فيها. فالبيشنت دي لو بس هنزود one step هنزود يعني اللي هي compression بماجنيفيكيشن فيو. الكمبريشن ماجنيفيكيشن فيو هنا لو احنا شايفين اللينير اللي احنا شايفينهم كانت هنا، احنا شايفين اهو اللينير هنا لما تشوفيها هي عبارة عن ايه؟ هي عبارة عن بارت من الريم ايوه الريم اوف كالسيفيكيشنز اهي هنا باينة اكتر اهي. هي جزء من بارت من developing rim of calcification للأويل سيست. هنا باينة هي أكتر. فيعني complete the work up for the sake of these patients إن هم avoid for them any problem. فهنا المنظر ده خلاني لا خلاص دي يعني عشان كده احنا بنقول ال evolved.
This is tangential. Is it a tangential, دكتورة؟
Two view. Sorry. Sorry, where is it? To view. احنا زي ما احنا شايفين I think ده CC وده ال MLO view. ففي السي سي باينه اكتر.
Because in the CC it appears as if it is tangential like. Yeah.
فهي evolving بعد سنة هتلاقي بقى الكومبليت ريم developed. فده خلانا نافويد ان احنا unnecessary biopsy ل this young patient. عملت second look تاني ما كانتش في الاول باينه لكن لما يعني تارجتد كده قوي لقيت المنظر بتاع cluster of cyst ماشيين بنفس
reassuring الالتراساوند
ان هي دي الاويل سيست اللي developing right breast 5 o'clock. فده example لان one of the important step في ان احنا ناخد decision بتاعنا الاول complete your workup, complete the workup whether MRI whether
interesting
magnification كده. This case B خلينا نقول ان هي السيرجن بعتها بعد ما she felt this new subcutaneous nodule عند السايت of she had a skin sparing mastectomy I think after she finished her radiotherapy. يعني فهي finished her radiotherapy. البريست كان sparing mastectomy وسكين sparing mastectomy بإمبلانت reconstruction، وفي الفولو اب بتاعها السيرجن felt this nodule وبعتتها لي. she sent it refer to me ان انا evaluate this nodule. اوكي لما evaluate this nodule as you can see superficial nodules فيها ecogenic content، فيها يعني فيها hyper ecogenicity تحت اللي هي بالظبط الثري نوديولز اللي هي palpable دول. طيب وطبعا في اللي هو السكن بقى اللي هو بعد الراديوثيرابي والسيرجري وعند السكار اهو. What do you think? Should we biopsy? Should not? As you see يعني she's also a young patient يعني. She's worried about the implant بتاعها اللي لسه she just finished a series of surgeries. مش عايزة ان احنا نكمبرس بالماموجرام. What do you think?
It seemed to be as if it is fat fluid level is there.
Okay. So
yeah, on ultrasound.
ما هي دي الفكرة. هي on ultrasound.
Yeah, it seemed to be just there is a level and the fat is higher than the fluid. The fluid is lower and the fat is higher. To me, يعني it is more toward fat necrosis rather than
exactly. وده اللي انا يعني برضو عشان انا كنت emotionally يعني مرتبطة كمان بالبيشنت دي، وما حبيتش ان انا اكمل الورك اب واعمل لها ماموجرام عشان اتاكد. عشان كانت هي لسه painful بقى البريست بعد الراديوثيرابي، وقلقانه على الامبلانت من الكومبريشن بتاع الماموجرام. فانا يعني I did this mistake وما كملتش الورك اب اللي لسه كنت بقول التيتشنج بوينت من اللي فات ان احنا نكمبليت الورك اب. وفي سؤال هنا لو انتم ملاحظين ان هي she didn't have a nipple sparing mastectomy, she had a skin sparing والنيبل removed. معنى كده ايه؟ معنى كده ايه؟ ان هي كان يعني reaching النيبل او يعني very close للنيبل. this patient احنا طبعا عشان هي كانت very close follow up معانا وان احنا قلنا هنمشيها follow up. لكن الحقيقة دي انا admit ان هي كانت mistake ان انا ما كملتش الورك up within a few months. النوديولز دي growing significantly، وطبعا السيرجن خد منها بايوبسي وطلعت recurrence، وزي ما انتم شايفين في البيت كانت فعلا recurrence FDG. التيتشنج بوينت من هنا ان هو complete الورك اب، يعني ان هو الكومبليت الورك اب مهم عشان ناخد appropriate decision عشان المين جول بتاعنا biopsy or not to biopsy. One important point ان احنا دايما نبص على reviewing the initial cancer. يعني احنا لما نجو باك للinitial cancer how this patient يعني الكانسر بتاعها كان ستيج، هنشوف ان هي كان يعني ادفانسد يعني كانسر تريبل نيجاتيف، فطبعا خد كومبليت ريسبونس وكان الريسبونس كويس. هاويفر زي ما احنا شايفين كان يعني وصل للنيبل وصل للسكن. فلما نكون نشوف ان الانيشال كانسر بتاعها كده وفي دلوقتي سبكوتينيوس نوديول زي ما قلنا من الفيرست سلايد ان هي الفات نيكروزس انتر موداليتي ديسيجن مش وان ديسيجن مش وان موداليتي. احنا موداليتي ده تريكي ادانا فات نيكروزس زي ما شفنا، وفي موداليتي يديكي في الماموجرام هو اللي فلازم انتر موداليتي لازم نكمل الورك اب. فده تيتشنج بوينت على ان احنا نكمل الورك اب ونشوف ايفالويت الانيشال كانسر هاو واز ذا ستيج اوف ذا انيشال كانسر. فالفرق بين التو كيسز دول ان احنا الكيس اللي هي كانت سسبيشس في الام ار اي however في الماجنيفيكيشن فيو والكورليشن ادتني مور اشورنس مع وجود الريدكشن ماموبلاستي، عكس الكيس دي بالرغم ان هي سكين سبيرنج ماستكتومي وكان في كومبليت ريسبونس، لكن لما نشوف الانيشال كانسر كان يعني لا ده ما نديش امان، ما نديش امان له. يعني لو اي develop new lesion يعني we should be very careful مع this stage يعني of cancer و complete our workup. I'm sure ان انا لو كنت complete the workup ل this case يعني it wouldn't have been any way lucent lesion، ما كانش هيبقى lucent، كان هيبقى dense lesion on mammogram. وعندي cases other cases مش دي بس other cases lesions زي ده بيبقى dense في الماموجرام وليس lucent. فده من learn from mistakes. فcomplete الورك اب initial cancer location staging please review. more cases عشان معلش this group very very important for our cases يعني our patient، فهدي معلش زي ما زهقتوا بس هدي more
لا بالعكس نحن we are enjoying الكيسز دي.
ميرسي. ف
لا
ميرسي دكتورة. فالكيس برضو دي هنقول برضو comparison بين 2 cases post lumpectomy surveillance. الكيس this case she came for her routine surveillance mammogram 3 years post treatment، بس we noticed this developing dense speculated mass هنا overlying المسل. طبعا we proceed ل MRI زي ما قلنا complete your workup. As you can see, it's follows the center is filled with fat signal intensity. يعني في كل الفات سيجنال والفات سبريشن والريم الانهانسمنت بتاعها، بس الريم رينج انهانسنج، و يعني كان ماشي تيبيكال ان هو فات نيكروسس. طيب another يعني كيس بقى هنقارن بينهم نفس same we have a dense speculated developing mass at the site of lumpectomy. في الالترا ساوند دايما بيبقى الفيري ديب ليجن ساعات بيبقى تريكي ان هو مش قادرين ان احنا نيفالويت بالدوبلر، ساعات الدوبلر ما بيديش سيجنال بس هو عشان فيري ديب مش عشان ان هو ما فيهوش فاسكولاريتي. however كده احنا وي بروسيد للام ار اي. الام ار اي زي ما شفنا كان في رينج انهانسمنت كانت irregular which is accepted في البوست لامبكتومي عكس الجرافتس، بس كانت يعني شوية irregularity برضو لسه still accepted. و اتكتبت وقتها زي ما انتم شايفين ان هي التقرير بتاعها ظهر على ان هي post operative change وريم enhancing lesion، ومعرفش ليه حتى اللي وصف ان هو representing seroma حتى مش فات necrosis. وبايرات 2 ده كان اتكتب بره الفاسيلتي بتاعتنا الهوسبيتال بتاعتنا. لما جيت اراجع الاستادي يعني الفات نيكروزس سيكونس سوري التي 1 والتي 2 سيجنال سيكونسز
is low.
It doesn't follow the fat signal.
Yeah.
Why
Yes,
why it
low
was
in T2.
reported أيوة why it was reported whether يعني سيروما أو fat necrosis. يعني الصراحة يعني مجرد إن evaluate كل السيجنال السنتر بتاعنا هنا not follow الفات signal not in the T1 not in the T2. فدي كانت من الأول كانت غلط إن إحنا نسيبها for follow up. البيشنت جات لنا احنا بقى الهوسبيتال بعد سنة كمان في 23 زي ما انتم شايفين الايفولفنج بتاع الفات، يعني لو هي دي فات نيكروزس ما كانش هيبقى الايفولفنج بتاعها الديفلوب بتاعها كده ان هو بينكريز وبدل ما ان هو يريزولف لا ده بينكريز بيزاد الكافيتي وزاد السوليد كومبوننت اللي جوه انفيد المسل. فطبعا هي من الأول كان إن it doesn't follow the fat signal intensity. خلينا نقول الفرق بين الحالتين هو exactly الفكرة إن احنا evaluate كل السيكونسز وكل في الكافيتي بتاع الفات نيكروزس، وإن هو over time هو دايما بيريزولف وليس إن هو بي significantly increase. الكيس دي كمان لما زي ما قلنا الفكرة إن احنا لازم إن احنا نرجع نevaluate الانيشال كانسر staging. سوري فان احنا لما جينا نراجع الانيشال كانسر بتاعنا كان زي ما انتم شايفين كان مكانه فين. هو exactly نفس المكان اللي احنا شايفين فيه الريكارنس، وكان يعني انكروتشنج على المسل، فده يريز اور سسبيشس، ده should raise our suspicious. عكس التاني هو كان في المكان اللي هو دايما اللي هو الستاندرد الكومن بتاع البريست تيل لما doing an axillary lymph node dissection وكده accepted دايما ان هو في التيل اوف ذا بريست بيبقى فيه السيرجري بتاعت الكومبليت axillary dissection. فان احنا نرجع للانيشال كانسر نشوف المكان بتاعه وبرده ده بيخلينا ان احنا ناخد قرار صح.
What about the enhancement of the muscles and the small area of non-mass-like enhancement in the suspicious one?
ايوه ما هي هنا خلاص هي فعلا
لا not this one, in the early one, the early study.
كيس A ولا كيس B؟
كيس B.
ايوه كيس B من الاول. انا يعني انا disagree اللي كتب الريبورت. انا كده
I
من
think
الاول انا
it
من
seemed to
الاول
be suspicious. It seemed
انا
to
من
be
الاول
suspicious.
هي كانت يعني انا ديس اجري تماما، حتى بالفات سيجنال، حتى بان هي فعلا زي ما انت بتقولي هي يعني
there is associated abnormal enhancement in the muscles as well as in the anterior.
فالليفل اوف سسبيشس من الاول كان عالي، ما كانش المفروض تتساب فور فولو اب ابدا، يعني ما كانتش المفروض تتساب فور فولو اب. يعني اي اجري احنا بنحط كل الفاكتور اللي هي بنبيلت اب اور سسبشن.
طيب بالنسبه لكيس A do you are going to follow the case or to be it para 3 or para 2؟
بايرات 2 يعني انا شخصتها انها فات نيكروزس، ما كانش عندي اي سسبيشس، وكانت يعني كونكوردنت على كل الانتر موداليتي وعلى يعني فهي اللي هو بايرات 2 اللي هي هتيجي في الانيوال سيرفيلانس بتاعها. ما عملتلهاش الصراحه فولو اب لان انا كنت يعني خلاص جمعت كل السفيشنت فاكتور ان هي فات نيكروز.
You're right. Okay.
بصي يعني fat suppressed في الفات
I agree with you. Yes, you are confident here. That is the diagnosis.
خلي بالك ان البيشنت دي دايما
sometimes
اندر فولو اب، يعني البيشنت دول اندر فولو اب من الانكولوجيست، يعني هم لهم زياره كل 6 شهور وبيشوفهم، واي يعني مثلا اي يرجع اي سسبيشس هيرجعها لي. بس انا كتقرير كبايرادز ككده انا يعني ما هي الفكره ايه الفات نيكروزس، انت سسبيشس ولا مش سسبيشس؟ هتاخدي بايوبسي ولا مش هتاخدي بايوبسي؟
but some of the cases are in between.
لا الوحيده اللي عملت لها فولو اب البيشنت اللي هي كانت مصممه ان هي ما عملتش اي كوزموتيك انترفنشن، فانا كنت حاطاها فولو اب عشان هي مصممه اعترفت بقى في المره الثانيه، فمش عارفه بقى كانت قدام يمكن when her husband was معاها ما كانتش راضيه تعترف ولا ايه مش عارفه، بس دي الوحيده اللي انا حطيتها فولو اب. بس انا اي بريفير ان انت من الاول تاخدي الديسيجن بتاع to biopsy or not to biopsy، يعني افضل من ان هو فولو اب. بشوف الناس كلها بتكتب فولو اب، يعني بحسها ان هي مور ديفنسيف ريبورتنج للدكتور، بيفكر في نفسه اكتر ما بيفكر في المريضه، هو عشان يعني بروتكتيف ريبورتنج ستايل ديفنسيف، انما انا قلت فولو اب يعني. بس هو كصح كبايراد ليكسكون يعني هي المفروض انت وصلتي للكونكلوجن ان هي فات نيكروزس فتبقى بايراد 2 فور كلينيكال فولو اب وليس ايميجينج فولو اب.
I have one case like that. I discussed with the surgeon about this is a fat necrosis. It was so suspicious, typical mimicker of cancer. And after I did all workup, ultrasound, mammography, and MRI, but at the end, he went for surgery, remove it. And fortunately, at the end, the diagnosis was fat necrosis, but it was real mimicker of breast cancer.
أكيد، ما عشان كده يعني التوك النهارده
ما مقتنع لأنها كان في شكلها بخوف شديد.
طيب هي بقى his decision، بس احنا عملنا اللي علينا وكتبنا تقريرنا بالطريقة المظبوطة، ودي فكرة المحاضرة النهاردة، ان هو ازاي نديفلوب يعني ايه الفاكتور اللي ناخدها عشان نديفلوب our suspicious level عشان to decide biopsy ولا not biopsy.
والله thank you very much. بس انا عندي بصراحة ما عندي بعض الحالات قاعدة اخد تسريح، يعني ما عارفة دي فين
لا ممكن نناقشها بقى. فخلينا نقول ان البوست انترفنشن كومبليت اور ورك اب، نشوف الانيشال كانسر تيبيكال سيجنال انتنسيتي وايفولفينج راذر ذان بروجريس، مش غالبا مش هتلاقيها بروجريس. دي حاله سريعه جدا برضو ان هي قد ايه this condition is very tricky، وانا مع كل يعني انا بس بنتعلم من اخطائنا وبنتعلم. this case came 2023 يعني بتعمل السيرفيلانس ماموجرام، وشايفين ان حتى يعني بالمقارنه comparison مع last year it's even getting better في الدنسيتي والكده، والكالسيفيكيشن الكورس كالسيفيكيشن بتيفولف، وده تيبيكال للفات نيكروزس. luckily البيشنت دي كانت also مع الماموجرام كان مطلوب لها الترا ساوند عشان كان في كرونيك سيروما، كافيتي بقاله 2 سنين مش بيريزولف. واحنا بنعمل الالترا ساوند يعني this part من السيروما اللي هو الانتيريور بارت كده اللي هو نير النبل يعني it wasn't I wasn't happy with it at all. يعني أنا كنتش حاسة إن هو بارت من السيروما، كنت شايفاه more solid عن بقية الفلويدي بارت، شايفة المارجنز بتاعته insinuating كده، insinuating في التيشو، مش التيبيكال بتاع السيروما اللي هي السموث outline كده. فالحقيقة this area يعني catch my eye، وحسيت إن هي يعني need to be يعني زي ما قلنا بقى complete work up work it up better يعني. فطلبنا الام ار اي، وفعلا يعني ده مثلا مثال ان الماموجرام ما كانش helpful خالص، ما كانش فيه ساينز. عشان كده الفات نيكروزس need to be worked up بكل الموداليتيز وكل الورك اب اللي تقدروا تعملوه. في الام ار اي زي ما انتم شايفين ده السيروما كافيتي اهو، الهايبر سيجنال انتنسيتي، وفي الستير، وزي ما انتم شايفين البارت ده هو السوليد بارت اللي هو ما خدش فات سيجنال انتنسيتي، اللي هو واخد انهانسمنت عند نير النيبل. طبعا دي ووز بايوبسيد وطلع فعلا ريكارنس جوه سيروما كافيتي، وده شفت كام كيس كده في الليتريتشر، لكن طبعا قليله. لكن زي ما انتم شايفين ده السيروما كافيتي كل اللي هو البارت البوستيريور ده، والموست انتيريور كلوز تو ذا نيبل يعني التيك انكريز ذا اف دي جي. فده اللي هو السايد بتاع فعلا الريكارنس جوه سيروما كافيتي. دي كانت برضو interesting كيس. فتيك هوم مسج، طولت عليكم. الابروتش للفات نيكروزس انتر موداليتي كورليشن كومبايند ب طبعا concordant clinical context. الجرين لايت اللي بيخلينا نبقى شويه assured ان هو في sufficient typical radiological feature، و our suspicious لما يبقى low اهي. دي اللي احنا بنقول عليها بايرات 3 ولا بايرات 2. انا بصي مش كاتبه فولو اب، مش كاتبه فولو اب لان مش الفات نيكروزس مش فولو اب، لكن انا كاتبه مونيتورنج يعني دبلوماسية.
تحايل على القانون. تحايل على القانون.
تحايل عشان برضو ما نديش الامبريشن لليونج راديولوجيست ان هو يفولو اب كل الفات نيكروس. بس لما اكون في سيتويشن فيري فيري اشورد، بس انا برضو عايزه يعني اغلب البيشنت دول اندر كلوز فولو اب لان هم كانسر بيشنت اصلا، وبتبقى بيني وبين الاونكولوجيست والسيرجن رايحه جايه، فهي اصلا اندر كلوز مونيتورنج يعني. بس انا مش حابه اقول كلمه فولو اب عشان ما تبقاش تقاريرنا بايرات 3 للفات نيكروز. فهي ممكن ان انا احطها اندر مونيتور للكونديشن، عشان انا بمونيتور ايه؟ انا بمونيتور ان انا الايفولفنج فيتشر بتاعتها زي ما احنا شفنا كده تيبيكال للفات نيكروزس، وده بيدينا اشورنج اكتر. طب ايه هي الريد
يعني احنا ممكن نقول الفايندينجز are suggestive of fat necrosis for monitoring after or re-evaluation in 6 months or 3 months interval.
ممكن يعني as a matter of
يعني instead of saying
the lesion this patient clinically and radiological monitor close monitoring close كده يعني for as a matter of precaution. لكن انا ما اقدرش اقول يعني بره كان عشان موضوع البيرات بره ده very very critical ان هم بيطلعوا statistics كل شهر. فهم يعني موضوع ان انا هطلع التقرير بايراد ايه لازم يبقى فيري يعني ماشي مع الجايد لاينز فيعني
بس المشكله في لكن يعني في البيراد موجود انه ممكن المانجمنت ما يتماشى مع البيراد، يكون موديفايد.
في ان هو في ان احنا بندي ساعات بايراد
2
بس
بايراد 2
لا بايراد 3 بس ممكن ان احنا ناخد منها بايوبسي عشان نبقى to be in the safe side.
برضو البايرات 2 in case of abscess
يعني بايرات 2 بايرات 2
2
المفروض ما ناخدش بايوبسي يعني
لا intervention abscess it can be يعني it can be drained.
لا دي اوكي دي اوكي، بس انت التقرير بتاعك بيخرج بايرات 2.
بايرات 2 لا what I mean
عشان البايرات كله about الكانسر يعني البايرات
I agree with you. I agree with you. You didn't get my point. Okay what I mean زي ما يعني قلت لك ده تحايل على القانون، اني قلتي monitoring، قلت لك it's okay. نحن we can say it is بايرات 2 خلاص this is يعني we believe it is a fat necrosis. لكن to make sure to give the patient the benefit of doubt and to يعني ممكن نكون 80% suspecting this is a fat necrosis أو 90% not 100% sure this is a fat necrosis but يعني probability is very high to be a fat necrosis. لكن عايزين نتأكد نديها 3 months مثلا follow up or 6 months follow up to make sure the evolution of this necrosis, this lesion is going toward the fat necrosis, not the reverse.
ايوه
خلاص. فاقصد لك انه ممكن زي ما بعض الفيروس المانجمنت ممكن يكون modified من الفيروس assessment itself occasionally. دي ممكن تكون في الاريا دي، في الاريا بتاعت انه ما يكون typically following and management of the virus. Instead of saying 3 for follow up، وانا مثلا
98 هي
متوقع انها تكون فات نيكروزيس.
الديفينيشن بتاع الفيروس 3 ايه؟ الديفينيشن بتاع الفيروس 3% فانت لازم الليفل اوف سسبيشنس بتاعك يوصل ل about 98%.
It's okay. قولي 98% انك متوقعه 99 still
لا
عندك
هي الفيروس 3 اللي هو I think
yes less than more than 2 but less than
ايوه
more than 0 but less than 2
ايوه
percent. يعني 90 if you are
فانت برضه واصله لمرحله من الاطمئنان كويسه جدا، بس هتعملي لها مونيتورنج عشان برضه for a matter of confirmation. الابسس مختلف، الابسس احنا بنعمل انترفنشن لكن ما هوش انترفنشن محطوط كاونتد تبع الكانسر.
Yes, but they mentioned in the literature this is not concordant with the management of virus 2. يعني is a modification of the management.
تمام.
Yeah. In certain areas certain areas they mentioned that in virus 2 there are 2 or 2 point تقريبا, and some areas also I think in UK they are biopsy virus 3.
UK كل حاجه بايوبسي.
they are biopsy virus 3.
UK كل حاجة بايوبسد لأن هم شايفين إن الايكونومي وايز يعني أو ريسورس وايز إن هم يستبلش diagnosis من الأول، يعني ده بيسيف لهم ريسورس تقريبا وانشورنس عن إن هم يعملوا further follow ups tests أو إن هو فهم اليو كي كده. أنا
بيقولوا it is a fibroadenoma لكن to make sure put the needle and confirm it is فده modification.
انا عارفه والراديولوجيست هناك بيشتكوا من الموضوع ده ان هو they have to biopsy everything. الكندا وامريكا بقى العكس، كندا وامريكا يهمهم قوي الستاتستكس، فعندهم كده ليفل اوف ان انا طلعت كام ريبورت باي راد 4 كام ريبورت باي راد 3 كام ريبورت باي راد 2، بيبقى عندهم كده زي KPI وحاجات كده ان هو لازم يعني عشان كده دقيقين قوي في البايراتس لما بيشود الريبورت ان هو ما تحسبش عليا فولو اب وهي مش محتاجه فولو اب، فهي يمكن دي الفرق شويه. وان شاء الله احنا المفروض نطلع اور جايد لاينز، يعني ده اور يعني ultimate جول من السوسايتيز ان احنا نفسنا نطلع اور جايد لاينز اللي ماتشنج اكتر مع اور كلتشر اور تايب اوف براكتس اور بيشنتس يعني
our type of cancers.
ايوه حلو ان احنا نقص الديفرنت اسبيكت يعني. خليني اقول بسرعه الريد فلاج ان احنا نقول finding across الموداليتي conflict ما هيش متماشيه مع بعضها. الام ار اي signal intensity not matching with fat signal intensity in all sequence, interval progression للدنسيتي والirregular margin pattern of enhancement بدل ما evolve. Our ultimate goal is to develop level of suspicion او intuition to balance avoiding unnecessary procedure في this sensitive patient. in the meanwhile not to miss a cancer. ولو انا يعني كنت بقول لهم لو عندي اللي هو المصباح السحري وقال لي what is your 3 wishes, one of these wishes بجد واحدة منهم هستغلها في I wish you all the cosmetic lipofilling procedure vanish disappear banned من الورد لان هما يعني make our day و our work even harder عن اللي احنا فيه. فيعني انا نفسي ان احنا نمنع هذه النوع من البروسيجرز. الجراحين اللي معانا معرفش في معانا بلاستيك سيرجن ولا لا، بس انا يعني I wish بجد ان احنا يعني نخفي الموضوع ده خالص. انا thank you so much في كل الناس اللي جات لنا المؤتمر، وانا I will work hard ان انا افاسيليتيت كل ان شاء الله السنه الجايه برضو نفس الميعاد 22-23 January 2026. الحقيقه المؤتمر very rich، كان عندنا 2 days fruitful program بالاضافه لحوالي 4 workshop ما بين فيلم ريدنج وانترفنشن هاند اون سكيلز واي اي وبانل ديسكشن مع الاذر سبيشاليتي. كان عندنا بانل ديسكشن لليونج اللي هم البريجننت فيميل اللي بيتشخصوا بالبريست كانسر المفروض نمانج ازاي، وبانل ديسكشن مع الانكولوجيست والسيرجن والباثولوجيست على الستيجنج وازاي بيفرق كلمه مالتي سنتريك مالتي فوكال كفاريتش. فان شاء الله السنه الجايه نرتبها ونعمل لكم يعني فاسيليتيت ان انتوا تحضروا معانا ان شاء الله. Thank you so much. شكرا جزيلا.
Thank you very much, Dr. Merit, for this very insightful.
أنا خدت وقت زيادة عن اللزوم.
We actually enjoyed it very much. Thank you very much for this very insightful, very useful presentation, very interesting cases indeed.
Thank you.
We truly find your expertise and in-depth knowledge. It really did help us to enrich our understanding of this very, very crucial topic. So thank you very much for your time and for your contribution in this symposium. Thank you.
Thank you. Thank you.
We do have some time later for discussion if you guys have questions for Dr. Merit. But now I need to present our next speaker. Our next speaker is Dr. Nadia Qawi. Dr. Nadia is a distinguished pathologist working in Soba University Hospital with extensive experience in breast cancer pathology. Today she will be discussing the pathological response and the dilemma of lymph nodes after neoadjuvant therapy. So welcome, Dr. Nadia, and thank you very much, Dr. Merit.
Thank you. I will follow بس I mute everything عشان الشغل ويعني إن شاء الله أبقى معاكم. Okay. Thank you.
Thank you. Thank you very much. Welcome, Dr. Nadia.
Can you see me? Can you hear me well?
Yes, we can hear you well. We can see your screen now as well.
Okay, thank you. السلام عليكم كلكم إن شاء الله طيبين. Today I'm going to talk about a topic I think I had decided with Dr. Rehab to do this topic, and she was quite interested in attending it, Dr. Rehab Hassan. So I'm sorry she's not attending today. Pathological response and the dilemma of lymph nodes in post-neoadjuvant chemotherapy breast cancer. I'm going to talk mainly about the histopathology. I'm not touching on any hormonal issues. So the lecture outline is pathology reporting of lymph nodes, grossing and section preparation, regional lymph node metastasis evaluation, classification of metastasis. And here I'm mainly talking about CAP. Then I'm going to talk about the NICE guidelines and the international, the ICCR guidelines, and we come to a conclusion. And please keep me in time so I don't run away too much.
Okay, good.
Goal of histopathology report, it is a pathological evaluation. I have to drop this one just a second. Yeah. Goal of the histopathology report is pathological evaluation of the post-neoadjuvant treatment surgical sample, and it remains the gold standard for assessing treatment response. It was very interesting what I have just learned. It is very similar the way that radiology classifies the response, and it's the simplest way. The purpose is to ascertain the degree of the pathological response and to evaluate the histological and biological characteristics of any residual tumor in the breast and or in the axillary lymph nodes, which is our emphasis today. It should be noted that the degree of response may vary between the primary tumor and axillary lymph node metastasis and among the metastases themselves. So this is a pointer that I need to take specimens from all of them sufficiently. Now, similar to primary cancer, lymph node metastasis can progress partially or totally with the treatment.
Dr. Nadia, we cannot hear you properly. The voice is very far. So if you can come close to the microphone.
Okay, is this better?
No. Can you try again?
regression areas.
Yes, now it's better.
Now it's better. Okay.
Yes.
Similar to primary cancer, lymph node metastasis can regress partially or totally. So the same influence as in primary tumor. Regression areas occur with fibrosis, in which
Dr. Nadia, it's far again. The voice comes and goes.
Then how about this one now?
Yes, yes, it's much better now.
Okay, I'm closer then. Regression areas occur with fibrosis in which foamy macrophages and or hemosiderin-laden macrophages are usually present. Immunohistochemical analysis of centennial lymph nodes for the expression of cytokeratins should be considered for patients with biopsy-proven node-positive disease who undergo centennial lymph node biopsy. And this is the example that we, in diagram, we have metastatic carcinoma confirmed by cytokeratin. This diagram shows you a lymph node. And you can see these areas are metastatic deposits of tumor. This is a high power view from this one of the areas. And because of what the cancer looks like, or the metastatic tumor cells look like after neoadjuvant, it is sometimes difficult to differentiate them. So immunohistochemistry for a cytokeratin is performed, and then it is quite obvious, the brownish areas showing and confirming that these are carcinoma deposits. Lymph nodes are the most important part of any major tumor resection. Of course, the tumor itself has to be resected with safe margin and has all its precautions, but the lymph node status determines whether the disease is localized and potentially cured by surgery, or disseminated and not curable by surgery, but possibly treatable systemically. When no residual invasive cancer in breast exists after neoadjuvant therapy or chemotherapy, the number of metastatic lymph nodes is negatively correlated with survival. So this is a very important part in determining what happens to the patient after chemotherapy. Patients with a lymph node negative status after chemotherapy have excellent survival, even with residual breast cancer or breast disease. So how do we usually assess residual disease after neoadjuvant chemotherapy? Common methods assessing common methods that are used include the Miller-Payne classification, residual cancer burden, and the residual disease in breast and nodes, each having a distinct focuses and advantages. The most common that is being used is the Miller-Payne classification. In Khartoum, we used to use something which was similar to what you said in radiology, but we have different limits. Now, all of these have developed in the year after, of course, after neoadjuvant chemotherapy, and it's mostly started in the early 2000s. The last one I mentioned here, residual disease in breast and nodes, was proposed in 2008 and combined with, and it was combined with tumor histological grade to form as single prognostic parameter. Now let's take each one by itself. The Miller-Payne grading system in 2003, the criteria of classification are as follows: no change or some alteration to individual malignant cells, but no reduction in overall cellularity. Grade 2, there is a minor loss, up to 30% loss, but still high overall cellularity. Grade 3, estimated 30 to 90 reduction in tumor cells. And grade 4 is a marked disappearance of tumor cells, more than 90% loss, such that only small clusters or widely dispersed individual cells remain. And no malignant cells identifiable in sections from the site of the tumor, only vascular fibroelastosis, stroma containing macrophages often remains. However, ductal carcinoma in situ may be present. So the evaluation of ductal carcinoma in situ here is another step. It is not included. And when you read this, you realize that you have to have an idea and compare the neoadjuvant biopsy to the previous, prior to treatment. So you have to have the diagnostic core biopsy or the diagnostic biopsy, whatever it was. Another one which I touched on in my previous lecture, in 2007, we got a prognostic information from degree of pathological response. We needed to compare the primary tumor dimensions, the residual cellularity of the tumor bed, axillary nodal burden, but as a continuous variable. And the publication of this work was the real initiator in all that is developing now. So on this one was based the second system, which is residual cancer burden. Most of these are being used in comparison of studies and evaluating treatment during research, where ongoing research is taking place. But more and more, it's leading to something that we will probably eventually be using in the laboratory and in routine use. The residual cancer burden is a method to qualify the extent of residual disease in the resection specimens of patients who have received neoadjuvant chemotherapy. And it is unique among the classification systems in that it uses the combination of residual tumor size and cellularity in the breast and responses in the nodes as a continuous variable. And you need, of course, to establish cutoffs. The first one, RCB 0, is equivalent to pathological complete response. Now, the determination of the RCB class must be made by the online calculator, and it's not simply a subjective assessment made by the evaluating pathologist. So whenever you do your parameters, you have to go into the online calculator, and that will give you the RCB class. And the parameters are the size of the tumor bed in 2 dimensions, the percentage tumor cellularity within tumor bed, including, now this is different here, including the invasive and the in situ carcinoma, as well as tumor in lymphatics. The percent tumor cellularity that is carcinoma in situ, and the tumor burden in the lymph nodes, including the number of lymph nodes involved and the size of the largest metastasis. So once I have my specimen, I need to determine all of these so that I can calculate by the online calculator, calculate my RCB class. This is the so-called the MD Anderson Cancer Center RCB website also includes a guide for estimating cancer cellularity. So nothing is subjective, which is useful in ensuring that one does not underestimate or overestimate percent cellularity treatment. And these are all included, and you can see it is with that same report of 2007. These are illustrative guides of how residual tumor bed should be defined. So very important, first in 2 dimensions, the tumor bed, and I have to compare. This is the whole specimen slice. This is the tumor that has to be measured. Again here, I have to take all the specimen. I have to measure the remaining tumor bed. Although I can see all of this, I have to measure the tumor bed. So it is exactly defined how I measure and how I gross in the specimen, how I gross, because I need to know the tumor bed, and in that tumor bed, I need to determine the 2 dimensions, and I will cross all that area, put it in the slides, and then I've shown exactly by this guide how to calculate the percentage of remnant tumor and carcinoma in situ as well. Oops, I need to go back. Just a second. Maybe I can show you the cellularity in the separate slides I have. Now here, going back to the specimen, this is my specimen with all the different colors of marking to show the orientation of the specimen. Then this is and it shows the remnant tumor. Then I map it out like that, and I take my 3 blocks, B1, B2, and B3. Then I do my calculations, just as we have seen, and I evaluate the percentage of remaining cells and do my calculations with the Anderson website calculator. And this is what is also included. It shows you exactly how to calculate the cellularity or estimate the cellularity. Nothing is left subjective, so that all reports would be similar and comparable. An advancement of this is the addition of tumor histological grade post-therapy, and this is the so-called residual disease breast and lymph node system. Again, you measure the largest diameter of the tumor in a gross specimen in centimeters. If the tumor bed was not obvious or difficult to determine, the position and size of the tumor bed were found using an X-ray camera. Finally, the microscopic results were combined with the gross view just to make sure that you are measuring the whole tumor bed. The index of the involved lymph nodes is 0 for 0 positive nodes, 1 for 2, 4, 2 for 5 to 7, and 3 for 8 and greater than 8 positive lymph nodes. Isolated tumor cells in the lymph nodes after therapy were also considered lymph node positive. And the addition of tumor histological grade was according to the Nottingham grade, which stratifies tumors into grades 1 to 3. And a score of 0 corresponds to 1, which is equivalent to pathological complete response. This slide shows you the comparison of different systems. There were others earlier systems, but here we have residual disease in breast and nodes. We have the Miller-Pine and residual cancer burden, and of course with comparison of the AJCC. So both classifications, do the classifications include response in breast only or in breast and nodes? And this is important because we know that here in the Miller-Pine, it also includes the breast only, but in both other systems, it is advisable, and it is now, as research shows, that it should be in both. The addition of DCIS, it is included in these both. And then, do we need access to the specimen before treatment? And in these two, we do not need, and because sometimes, and in many cases, it's not available in the same facility. This is one of our sunny days. Hopefully it stays like that. Now, pathology report should include the presence and type of residual disease. The presence and type. Is it macro, micrometastasis, isolated tumor cells, extra capsular extension, and fibrosis. We are now concentrating on the lymph nodes. In the case of axillary lymph node dissection, the pathology report should detail the number of lymph nodes involved, of those with residual disease and of those with fibrosis in the absence of residual disease, the extent of any residual disease, the presence and extent of extracapsular extension, and the pathologic staging according to the latest TNM edition. And each of these factors have been related to survival. It has been suggested that the number of nodes reported should be used as a quality assurance measure based on the assumption that patients with small numbers of nodes had positive nodes missed, either by the surgeon or by the pathologist. Now, such patients would be understaged and would not receive chemotherapy that would have improved their outcome. However, node-negative patients with greater number of nodes reported also have a better prognosis. Now, this indicates that the underlying reasons for this phenomenon are complex and are not just due to the failure to find positive nodes. Factors related to the type of cancer and characteristics of patients undoubtedly play an important role. The number of lymph nodes present and evaluated in a specimen in the lab is dependent on many factors. So let's divide them into patient factors. The next slide will show you more surgery. Let's go into detail. In patient factors, you have the age. Older patients tend to have fewer lymph nodes and may undergo less extensive surgery. Prior treatment with radiation chemotherapy reduced the size and number of nodes. And this is one of the major dilemmas, is that after treatment, is in all specimens, it's not just in the breast, it is really difficult to find lymph nodes. There are many procedures in the lab. Some of them, it is a personal thing. Some of them, like in specimens of colorectal cancer, where we have a lot of fat, what we do is we put the specimen or the fat from the specimen, we shave it off and we put it into a substance that dissolves out the fat. But the whole procedure and the chemicals used are really dangerous and are cancerous for the operators, and it never gives you the yield that you want. So I used not to do it in the lab in SOMA, and I never allowed actually. Prior surgery to remove lymph nodes will reduce the number present at that site. Host immune responses, some systemic diseases can result in either increased size of lymph nodes due to chronic inflammation or infection, or decreased size is an indicator of the immune competency of the patient. A second factor is surgical factors, the size of the specimen, removal of tissue likely to contain lymph nodes. You get the experience that these some surgeons, they send you a lot of lymph nodes, and I don't know, is it maybe one of the surgeons, is it technique, is it the knowledge of anatomy? We get into clashes with them all the time, and by the time we start working, we know that some surgeons, they give us enough, some surgeons don't give us. This is from my experience. Cancer factors. Some cancer types are associated with an increased size of lymph nodes not involved by cancer, like medullary carcinoma. Lymph node metastasis, metastatic carcinoma in lymph node often increases the size of the involved node and makes involved nodes easier to find due to their firmness. Therefore, more nodes will typically be found in patients with many lymph node metastases. And the last one is the pathology factors, experience and technique of the person looking for the lymph nodes. We can never deny that. Methods of retrieving lymph nodes. This is what I mentioned before. It's like special fixatives or clearing solutions can be used to find very small lymph nodes. However, the additional nodes found compared to a good routine examination are very small. So number one priority is to do a good routine examination from the beginning and rarely change tumor state. The significance of increased numbers of negative nodes found by the use of extensive labor, intensive procedures is unclear. And as I said, it's often toxic. Now, coming actually to how we handle them, this is for the centennial lymph node, and this is from an integrated manual of modern surgical pathology from the College of American Pathologists, from the CAP. A specimen is, of course, measured. You examine the specimen, palpate the specimen, and determine the number of lymph nodes that you receive. Then you separate the lymph nodes. If more than one is identified, document the size of each one, remove excess adipose tissue around the lymph node, and serially section the lymph node perpendicular to the long axis at 2 millimeter intervals. You submit everything entirely, and this is, in this case, it is cut in the fresh. That's why you can see it looks like in surgery. It is cut in the fresh, and what is done is you can submit a section for frozen section, touch preparation, or then put in formalin to do later the after fixation to do routine H&Es instruction. Pathologists can play an important role in patient care by striving to find all the nodes in a specimen using good standard grossing techniques. In any specimen where fewer than expected nodes are found, the specimen should be re-examined by any additional tissue that might contain nodes submitted. And this was our routine in Soba Hospital. If I did not have enough, or what I took was not lymph nodes, then I used to re-examine, or the procedure protocol was to re-examine and remove any additional tissue that might contain lymph nodes. The report should document the extent. Now, this is one of the things that you should document what you do so that you can later compare. And of course, knowing how your lab submits, how your lab operates is also important. For optimal patient care, you should document the extent of pathological examination, like the re-examination by a second person or by the same person, or the resubmission or the submission of additional plots of tissue and how many were submitted, in order to minimize the possibility of a positive lymph node being missed. Now, let me go here directly to this record. This is what the steps of what you do in the lab. Then describe the lymph nodes that were detected. Are they tan, homogeneous, firm, normal lymph nodes? Are they white, firm to hard, like metastatic? Because they are indicators already of what you'll find later. Necrosis, because you can see that in the cross. Was there some necrosis, softness? Then this again could be metastatic carcinoma, could be an infection like TB. Describe if the capsule is irregular or effaced, if there is extensive extracapsule extension and the nodes are attached to each other by firm tissue. This is what we call fixed or multi lymph nodes. Estimate the number of nodes present and take a representative section of each separately identifiable involved lymph node, because we need the number of involved lymph nodes. Each node is separately serially sectioned into maximum 3. Cool down, it's a lot of work, yes. Now, the regional lymph node metastasis evaluation. Once I have those slides and I look at them, I need to investigate, because most patients with invasive carcinoma will have lymph node sampled for pathological regional lymph node. That's the PN in categorization. All lymph nodes must be examined histologically. The nodes, all lymph nodes that I get in the lab or that I find in the specimen, the nodes commonly examined include either I have centennial lymph nodes or single or more. non-centennial nodes, nodes from axillary dissections, and intramammary nodes. When the total number of centennial and non-centennial nodes removed is less than 6, in the AGC, we call SN modifier is used. What do I find in the lymph node in my sections? I classify metastasis into 3 groups based on size. So I have isolated tumor cells, I have micrometastasis and macrometastasis. And the isolated tumor cells are defined as single cells, small cluster of cells no larger than 0.2 millimeter, or no more than 200 cells in a single cross-section. We state that the AJCC states that a cluster is a group of cells in contact with each other, confluent or contiguous. Cells that are not touching each other should be considered independent and measured independently. So again, very detailed explanation of what isolated tumor cells are. In case of multiple clusters of tumor cells within a lymph node, only the largest should be considered when determining the N category. The AJCC also states that the size of the tumor should include both the tumor cells and the surrounding desmoplastic reaction. Some carcinomas, like particularly lobular carcinoma, may metastasize as individual single cells and not as clusters, and present as a dispersed pattern of nodal metastasis. So the type of tumor is very important. In such cases, single cells are measured separately. If fewer than 200 tumor cells are present in a node cross-section, then classification of the ITCs is recommended. Nodes containing only are not included in the total number of positive nodes when determining N category. So cases with only ITCs are classified as node negative. An interesting fact. Micrometastasis measure greater than 0.2 millimeters, but not greater than 2 millimeters and or comprise more than 200 cells in a single cross-section. If only micrometastases are present on lymph node examination, the N category is PNR1MI. If at least one micrometastasis is present, nodes with micrometastases are included in single cells are measured separately. If fewer than 200 cells are present in a node cross-section, then classification of the ITCs is recommended. Now let's do it. I should go to the diagram. Nodes containing only ITCs are not included in the total number of positive nodes when determining N category. So cases with only ITCs are classified as node negative. Micrometastasis measure greater than 0.2, but not greater than 2 millimeters and or comprise more than 200 cells in a single cross-section. If only micrometastases are present on lymph node examination, the N category is, okay, let's go to the, I think in the diagram it will be easier. So in A, we have a lymph node showing multiple clusters of tumor. You can see one here, another one here, but we measure the one with the longest diameter. In B, you can see dispersed tumor. Very few cells that in very small clusters. And this is the usual case in lobular carcinomas. And these are the cases where sometimes when they are also very few, here they are quite obvious. But here, like in this case, you needed immunohistochemistry to see those dispersed cells. And this shows you, the brownish areas showed you very few dispersed cells or small clusters. Less than 200 cells is detected by cytokeratin. Now, in the last one, we have a macrometastasis, and you can see that like all of this is tumor. This is quite obvious. This is the rim of remaining lymphoid tissue. But all of this one, oops, is a tumor. And here at this black area, you can see also that there is extra nodal extension of the tumor. From the diagrams before, I'm just including these three because it shows you that a reminder of from the previous lecture that you can see the pleomorphism and the bizarre nuclei. These photos, they don't, the previous ones, they show you just how much, they don't show you how much the tumor can change after and how difficult sometimes it can be, or in many cases it can be to determine remnant tumor, because you can see that, like in this slide, you can have a completely different histology of the tumor cells after neoadjuvant. This is another one showing the fibrosis and the hyalinization of a blood vessel with very ugly cells here affected by neoadjuvant. And here you can see the fibrosis, and in the inset, all of these are not tumor cells and bizarre shapes, but are actually calcification following neoadjuvant. More slides for tumor. These are lymph nodes. We are coming back to the lymph nodes, keeping all those shapes I showed in the normal tumor. You can see this is a lymph node with extensive fibrosis, but also with remnant tumor. This is an H&E section, and the brownish areas you see here is a lymph node with fibrosis, and these are normal changes of hemosiderin following neoadjuvant. But when we go high power here, we can see that there is this area, and this area are tumor cells, and you can see they have the changes of neoadjuvant, but definitely another cluster here. A problem that we see is this last image in E is the presence of necrosis, which makes life difficult. And if I only have in the breast or in lymph nodes, if I have necrosis, it does not preclude the classification of pathological complete response. More lymph nodes, you can see the response to chemotherapy. A large area of this lymph node is fibrosed. And you can have this flocculent area like this area. And then it becomes difficult. You need immuno to determine these single cells that are still there in this lymph node. Scattered single tumor cells better visible on immunohistochemistry and immunostain for a cytokine. Extranodal extension is defined as the presence of full thickness into and through lymph node capsular invasion, as seen with metastatic tumor invasion of extranodal fat or with or without associated with desmoplastic reaction. The area of extranodal extension is included when measuring overall size of the lymph node metastasis. And extranodal extension is a marker of poor prognosis in breast cancer patients, and the status of extranodal extension should be reported in the pathology report. Reporting of extranodal extension size based on a 2 millimeter cutoff is incorporated into the CAP reporting guidelines. More evidence is needed for this practice to become widely accepted. So it's an area that's developing. Axillary fat cancerous nodules. We see this often when you take something from the axillary area.
The voice is not clear, Dr. Nadia.
Sorry?
Yeah, now it's clear. It was not clear, but now it's
just
good.
have to come closer.
Okay.
When cancer nodules that are not associated with residual lymph node tissue are present in axillary fat, the AJCC states that these nodules should be classified as positive lymph nodes. So this is something that we see often when the whole lymph node is taken over by the tumor and eventually the whole rim of remaining lymphoid tissue is not present in your section. So it should be considered as a positive lymph node. However, if there is surrounding normal breast parenchyma, in these cases, of course, you have to re-evaluate because it could be just a deposit. So normal breast parenchyma or DCIS, then cancerous nodule in the axillary fat should be classified as invasive carcinoma and not as a nodal metastasis. So it will not give an increased number for positive lymph nodes. The important thing, because you can find breast tissue in the axilla, it is important to differentiate. Now, this was the subset in this CAP. All of these slides are from the CAP. The post-treatment classification system is the same as that at pre-treatment lymph node. So you just evaluate the same. Only the largest contiguous focus of residual tumor in the node evaluation is used for determining the N category. Any treatment-associated fibrosis is not included. An essential aspect of patient care is an understanding of the uncertainty inherent in our examination of lymph nodes. So having said all the details of how we act and how we react with lymph nodes in the lab, you have to consider that, like I have through the lectures, the 3 lectures I had, and they were beautiful lectures comparing to histopathology this time, directly comparing to histopathology. The thing is that you have always to remember that in radiology, you are looking at the patient as a whole and the organ or the tissue as a whole. You have the facility to say, to look at all of the breast, for example, all of the axilla. In pathology, the slides that we look at are a sample of the specimen that came to us. It is what we call a representative. We take a representative of the specimen that came to us, and we have very clear guidelines of how to take those representative sections. That's why grossing the specimen is so important. An essential aspect is there is some inherent uncertainty. The fact that what we observe on a microscopic section may not be the largest diameter of a metastasis on which we base our report translates to prognostic overlap between the size, determined nodal classification groups. Let me show you this here, because it's not just the grossing, it's also how you handle the specimen in the lab. You get the specimen, you describe it, you look at it, you slice it, and you get guidelines and your common sense and all the input that you should get from the surgeon and from the radiology. They guide you where to take your specimen and to take your samples of that specimen. So grossing is very important. Then in the lab, and usually this is out of my hand because it's done by a protocol, of course, by the technologists. So what happens is that embedding, when I put the tissue that I have chosen from the specimen into the carrier, which we call a cassette, I have to put it in a certain way. And then my protocol in the lab is that when it goes to the main lab, it will be positioned like I positioned it. So it also depends on the size. But of course, if it's a very small specimen, it will not be put in the same way. So if you just look, this is a beautiful study by Weaver, and he shows you that this is a lymph node, and I cut it up, and you can see from the size it's small because I cut it in 2 millimeter sections, 2 to 3 millimeter sections. Now, this is the lymph node, and that is the deposit. And if I cut it up and all 4 pieces of this lymph node, I have 1, 2, 3, and 4. And then I put it down into the cassette like this. So what I see here, this lower side is where I'm going to do the section and have a slide. And the slide will be prepared from a cut section from here that is up to, the usual is we cut at, depends on the tissue, we cut between 3, can go up to 5 micron. But usually you cut 2 to 3 microns from this area. So definitely this one will show up. This one will not show up. This is also correct. Now here I will have this one on my slide. But if I do the embedding like this, I'll have a negative slide. So this slide will show me that this lymph node is negative. And the important thing is, now remember, like in an axillary clearance or in an axillary with axillary clearance, I would have so many of these lymph nodes because minimum, they will not accept anything below 12 to 15 or 10 to 15 lymph nodes. So think about it. I sometimes have up to 23, 25, 26, 30 lymph nodes. And I have to do this for each and every lymph node, and they are of variable size. Of course, those that are anyway involved macroscopically are easy, and I count them as positive. But the thing comes with these, which are just as important. Another thing in the lab is that what is my sectioning protocol in the main lab? So I have this lymph node, and it depends on the size of my metastasis. And this is a micro, this is a macro. And then it depends, what do I do in the lab? Where do I take my sections? Because I can look at one section, this 2 to 3 micron section, that's my slide then. If I take a section from this one, it's negative, although I have this here, because this one is 2 to 3 millimeters in thickness. So if I take a section from here, oops, I should not use this. If I take a section from here, it will be negative. If, for example, I have a protocol that I take 2 sections, it will still be negative. Now, if I do a section from the top and it's negative, and then I ask to get deeper section, sometimes this is the protocol. So you take a deeper section, you will see this one. This is a micro. Some labs have the protocol that they will go through the sections. You can do a section from the surface. This is for the same block. I'm talking about the same embedded tissue. I can have a protocol in the lab which takes the first section. Then I ask the technologist, his protocol would be, give me section 1, 3, and 5, for example. Then I will have, from the same block, I will have 1, 2, 3. And in this case, for example, I'll catch all of them. I'll get the micro and I'll get the macro. Some people, this is very common in head and neck surgery. The protocol is to actually complete the block and do sections from all. Especially if this is the centennial lymph node, you just go and do all of the node, have it all in slides, even if there are 10 slides, and look at all of them. Now, the protocol in SOVA was, actually, it's something that I initiated, or we just became in the habit of doing it as we started, our group started together, is all the lymph nodes that are positive, okay, they are positive. All the lymph nodes that are negative, we do deeper sections. We ask for another section. And from the beginning, we always have 2 levels for any lymph node that is sectioned or that is in a block. For example, I have a block with 2 lymph nodes or with 1 lymph node. I will section, I will always ask the technologist to make me, in the protocol of the lab, is to make me 2 levels from each and every block of lymph nodes. I never look at one. And any lymph node after that is negative, I asked for a deeper level. By the time I issue the report, maybe sometimes get more information, those slides will be ready, and I can make sure that the lymph node is negative. Now, in summary, the thing is that until now, there is no standard protocol for evaluating or for sectioning. Yes, we section at 2 millimeter intervals, but there is no like a consensus between the labs. There is no guideline of what to do. In summary, only one standard protocol must be imposed or supposed and endorsed based on evidence. And the scene sectioning at 2 millimeter intervals, embedding all sections and examining one section from the surface of the block is a strategy designed to detect all metastases larger than 2 millimeters. This is the other complicating factor, which is the 2 millimeter limit or in size. The resulting metastases can then be placed into statistically stratified groups such as those defined by the AJCC and the UICC. This strategy is recommended by the College by CAP and the American Association. It is recognized that more comprehensive sampling will identify additional micrometastases and ITCs. However, we have not yet developed the reference population with these experimental protocols to understand their prognostic significance for patients. So new standard protocols should only include evenly spaced levels through the block. There are some trials and studies, especially in occult metastasis and other studies where the centennial lymph node gross examination protocol have been standardized, and this will give us better evaluations and guidelines of what to do in different labs, and maybe eventually we will get just like it will be included on how this will be worked out. I know you need to cool down. Just imagine going to buy some bread and milk under these circumstances. It will cool you down, definitely. Now, how am I time-wise? I don't want to override this time.
Okay, we can have more 5 minutes if you need.
Okay, then I will skip the nice regulations. A guideline, it is very similar. The important point is that there is this thing that histopathology, of course, not for centennial lymph nodes, but usually histopathology reports come in 5 to 15 working days in the NHS system. So if the results are positive, the patient will have a second operation to remove the remaining lymph nodes, the axillary dissection, and this can be more technically challenging than performing axillary dissection as part of the initial surgery. So this is one of our dilemmas of long working hours, because when it translates actually into, it can be quicker, but when you have to translate it in normal routine work. Something that I want to touch on, I found very interesting, is in the NICE guidelines. So it is something that I found a lot of research about, and it's being used more and more because of the time factor. where histopathology takes. So we have analysis, and these are intraoperative lymph node evaluation. And I find I love to hear about if somebody has experience with these, and if in their centers it's being used. So there are two systems. They work on the analysis and amplification of mRNA, messenger RNA. And what they do is they take out the centennial lymph node tissue to detect the level of expression of cytokeratin 19. The rest of the lymph node is sent histopathology as usual. And this is something you have to make sure that there is still some pathology in that one. So the test takes only 30 to 45 minutes, and the result is expressed both quantitatively and qualitatively. So a very, very interesting topic. This is another test on a similar, it's again an intraoperative molecular test that detects cytokeratin 19 and mammaglobulin. And it takes 32 minutes to extract and produce results. So it is being used already in the NH system as an in-house test to analyze half of the lymph nodes, and then the results are confirmed by follow-up histopathology. I think we can skip this one and go to two pathological methods that can be used intraoperatively are frozen section and touch imprint cytology. And in frozen section, it involves a section of the lymph node being snap frozen. I mentioned it earlier, stained and sliced before being viewed by a consultant histopathologist who directly gives the response back. It can take up to usually up to 20 minutes. So it is quite quick, but you have to have the facility for it. In Sudan until now, we have the machines for frozen section, but none of them are actually working. And I don't think they have ever worked. Correct me if somebody knows better. Touch imprint cytology involves lymph node being sliced and the surface of the node imprinted onto a slide, which is then stained and viewed by a consultant histopathologist or cytopathologist. And again, you can give direct results. Of course, the tissue itself after the imprint is again sent for histopathology. Another system, I think I'm always promoting this one because it doesn't depend on the CAP. It incorporates all the systems of reporting. So you have the CAP, you have the NICE regulations, you have the Royal College, you have the Euro-Asian, but here you have an international collaboration on cancer reporting. And this is how it looks. 4 pages of reporting. This one is specific. You have it for every issue, and this one is for lymph node reporting in. And I think this is a basis for how we should start reporting also in Sudan, inshallah. New areas is a combined RCB score with residual cancer burden with Ki-67. And there is beautiful work on this to combine the Ki-67, which we anyway always do on tissue because it's one of the prognostic markers. Then recent studies have also shown you combine infiltrating tumors into the report because they have a high predictive value, prognostic value. Combining internal breast lymph node information with the RCB system is also for a more comprehensive, and they have found it's a good evaluation system in post-operative pathological evaluation systems. Investigating the expressed genes of the resected tissue is another area that's developing quite and showing a lot of promising biomarkers. And then we have circulating tumor cell DNA, another very good monitoring system that can be used postoperatively also. And because of digital pathology, we have artificial intelligence applied to whole slide images of lymph nodes. And this can be exploited for the automatic detection of metastatic tissue, especially with the evaluation of the evolution of detection algorithms. They have very high frequency, and they are a possibility for issuing quicker reports, as well as intraoperative consultation on frozen section, which again, you can use detection algorithms. Time becomes much shorter. If a pathologist, and in accuracy, they are very good. Now, in conclusion, I think after this lecture, my lecture, and what I have presented there, and from before all the 3 lectures, neoadjuvant, also in the neoadjuvant setting, the close cooperation of pathologists, oncologists, surgeons, and radiologists within the multidisciplinary team is essential to ensure best possible management of patients. Thank you so much.
Thank you very much, Dr. Nadia, for this very, very fruitful and very well-structured presentation. We actually really enjoyed your presentation, and we truly appreciate your expertise and your knowledge that you shared with us today. So thank you very much.
Thank you.
Now, allow me to introduce our next speaker. Our next speaker is Dr. Hiba Mohamed Uthman. Dr. Hiba is a highly accomplished radiologist in breast, body, and emergency radiology. She's an associate professor in the University of Calgary and the staff radiologist at EFW, Foothill, South Health Campus, and Richmond Road Hospital in Canada. Her extensive training includes fellowship in breast and cross-sectional imaging at McMaster University, as well as all body and emergency radiology fellowships at the University of Ottawa. Additionally, she contributed to the medical community as a former executive committee member of the Sudan's Doctor Union in Canada from 2020 to 2024. We're actually very privileged to have you here with us today, Dr. Hiba. Dr. Hiba will discuss a case presentation series. So welcome, Dr. Hiba.
Assalamu alaikum wa rahmatullah. Shukran jazilan for having me today, and I'm very glad to present my talk about unusual and interesting breast cases. I have no disclosures. My objective today is to present interesting cases, workup, pathology, results, and key facts. I am showing a few cases for multifocal and multicentric breast cancer. Also, I will show a patient with questionable radiology pathology concordance and breast cancer on other modalities rather than usual mammogram and ultrasound. And lastly, I will present some cases with unusual pathologies and unusual tumor behavior. So I'll start with warm-up cases. My first case is a 60-year-old female came for screening. So this is her mammogram, and there is a fair size mass in the, I would say it's isodense mass in the lower inner quadrant of the right breast. So we did the ultrasound, and the mass is non-circumscribed with some angular margin. It is hypoechoic. There is no posterior features, and on color images, it does not demonstrate any vascularity. So we went ahead and ultrasound guided biopsy, and this is the needle going through the lesion. And every time we report a pathology addendum, we look at the actual images of the biopsy and make sure that the needle went through the lesion in 2 planes, in the radial and anteradial planes. So this came back as invasive mucinous carcinoma, grade 1. And this is the post-localization ultrasound. So previously we were localizing with the iodine 125 seeds, radioactive seeds, and now we've shifted to the magnetic seeds. And this is the post-biopsy clip seen within the lesion. So what is mucinous breast cancer? It is well-differentiated type of adenocarcinoma. It accounts for only 2% of invasive breast cancer carcinomas. And it is typically contained abundant extracellular mucin secreted by tumor cells. Usually the patients are presented more than 55 years old, and it's generally of good prognosis. The lesions usually manifest as circumscribed, rounded, or oval-shaped masses that sometimes has macrolobulated margin. Mucinous carcinoma of the breast are isochoic and hypochoic, with possible cystic changes and internal echoes. The circumscribed appearance contribute to the sometimes delayed biopsy and delayed management. The posterior acoustic enhancement is the other feature that make it less suspicious on imaging. On MRI, it demonstrates high signal intensity on the T2 because of the mucin, and variable intensity on the T1 according to the proteinaceous content of the tumor. On the ABC map, the lesion demonstrates higher than most of benign tumor, and the enhancement is variable. So sometimes it doesn't show any enhancement because of the predominant mucin content of the lesion, and sometimes it is heterogeneous because of some neoplastic cells are floating within the mucinous, and some demonstrate only REM enhancement corresponding to the peripheral distribution of the tumor cells and central location of the mucin. Second patient. This patient has a prior left cancer, and she came for annual screening. This is her mammogram, and it demonstrates the architectural distortion in the left posterior nipple line. There is a speculated mass in the inner half of the left breast, and that was not very obvious on the MLR view. The right side was unremarkable. And then this is a zoomed in view of the CC view, and it demonstrates speculated hyperdense mass. The ultrasound showed a hypochoic, irregular shape, taller than wider mass with posterior acoustic shadowing. And this came as a invasive ductal carcinoma. So metrocarcinous breast cancer is very common. This is a very good meta-analysis demonstrating that the metrocarcinous breast cancer is most common with invasive ductal carcinoma, and the disease-free survival decline with the follow-up with the consecutive follow-up. Next patient is a 62 years old, came for screening. Most of my cases came for screening only. So this is a heterogeneously dense breast. It's really hard to see the area on this mammogram, but like now we shifted all our patients to tomosynthesis rather than 2D. So that makes our job easier, and there is architectural distortion in the outer half of the right breast. This is a compression tomo image, and this is the architectural distortion and the speculation. And whenever we see area of abnormality on the mammogram, we try to see it on the ultrasound because we try to target the most invasive component. And the other thing is that ultrasound guided biopsy is usually easier than the stereotactic biopsy, and it is more pleasant for the patient, but like if we couldn't see it on the ultrasound, we will just target it under stereotactic biopsy. Luckily, we found the lesion. It is hypoechoic, irregular shape, speculated mass with posterior acoustic shadowing, and it is taller than more than wider. And this came as lobular carcinoma. Lobular carcinoma is also not very common, and I will come back to that. So the differential diagnosis of architecture distortion include invasive lobular and invasive ductal carcinoma, radial scar, which is also high-risk lesion, DCIS, and sclerosis adenosis. So it's a must to biopsy every architecture distortion we find. Invasive lobular carcinoma is the most common breast cancer after the invasive ductal. It presents 5 to 10% of all breast cancer. Invasive lobular is the most common, is mostly multicentric and bilateral in 10 to 15% of the patients. That's why MRI breast is usually recommended. Next patient is 75 years old, came for screening mammogram. And this is her mammogram. And again, it's similar to the previous patient. There is architecture distortion in the upper outer quadrant. This is the compression view, and the spicules is more evident here. Ultrasound is similar, and this came as invasive ductal carcinoma with no DCIS. Now I will shift to the other part of my topic. So I will talk about multifocal multicentric breast cancer. So this is a 63 years old with palpable lesion. So this is the palpable lesion, but this is not the reason that I brought this patient here. If you look carefully, you will see another lesion in the retroareolar area. It is also speculated, irregular shape. And this is the cone compression. This is the tomo image, and the speculation is much easier to see on the tomo, and this is the second lesion. This is the ultrasound, and this is the echogenic frame sign, and that means that there is desmoplastic around the lesion. In fast-growing lesions, it's more obvious. And also, this is the echogenic rim. This is the other satellite lesion, which is vascular, hypoechoic, irregular with speculated margin. A third ill-defined lesion is seen on the ultrasound, and we biopsied the 3 lesions, and all of them came as invasive ductal carcinoma, mixed ductal and lobular features. The patient underwent mastectomy, and they found in like 2 foci of invasive neomorphic lobular carcinoma grade 3, and areas of LCIS, and the lymph node was positive as well. Next patient is 45 years old female, came for screening. And the mammogram, like there is the retroareolar areas are busy bilaterally, but on the tomosynthesis we saw a speculated lesion in the retroareolar area with possible nipple retraction, and there's possible skin thickening as well. So I don't know if you found the other satellite lesion. It is very subtle and very far back in the breast. So make sure to look at your blind areas of the breast, the retroareolar area, the posterior nipple line, the no man zone, the posterior glandular area, and here is the lesion. And when we did a with the tomosynthesis images, it's more obvious that this is a large lesion and there is another smaller lesion in very posterior. On the cone compression view, again, more lesions were seen. And this is the ultrasound. Demonstrate multiple lesions and smaller satellite lesions. And we biopsy 2 lesions, and again, those are all positive for invasive ductal carcinoma. The last patient in this category is a 45 years old, came for screening. And on screening, we saw like a lymphorrheic microcalcification in the lower inner quadrant of the right breast with the segmental distribution. This is a magnification view of the calcification, and it is suspicious lymphorrheic microcalcification. And I don't know if you notice the other focus of microcalcification in the lateral breast. So both areas was biopsied, and it was and returned back as extensive DCIS with invasive component. This patient came with left breast lump. She is young patient, 28 years old, and she has family history of breast cancer. Her breast was extremely dense, and it was really difficult to see anything through her breast, even on tomosynthesis. The only positive finding, like there is, compared to the right side, which I didn't include here, there is certain increased density in the upper outer quadrant of the right breast, and there is a grouped lymphorrheic microcalcification in the upper outer quadrant at the site of palpable abnormality. We did ultrasound, and then there is large speculated hypoechoic mass with internal calcification and vascularity. Also, we have like the microball pearls technique on our ultrasound machine that can highlight the calcification more for us. This is her left axilla, and it demonstrates large metastatic lymph node. We biopsy both the lesion and the axillary lymph node, and both are positive for invasive ductal carcinoma. This is her MRI. So this is the large axillary lymph node. And just go back slowly to the so there is multiple satellite lesions with background of non-mass enhancement. This is the largest mass that is seen on the ultrasound and biopsy, but there is multiple adjacent satellite lesions. This is a few representative images. This is the level 2 axillary lymph node. And this is the large breast mass and few surrounding satellite lesions. The second category is seeing breast masses and breast cancer on other modalities. So most of us, we cover also general radiology and CT scan. And it's very important to look at the breast in every modality you see it, because it is the first, like the most common cancer among female. So this is a 45 years old female with a new rectal cancer. And this is her staging CT scan, and there is a speculated ill-defined mass in the left outer half of the breast. So we recommended doing a mammogram and ultrasound for that. So on, like they saw liver lesions on the CT scan as well. So they did an MRI of the liver. This is not dedicated breast MRI. This is for the liver. And again, we see a multicentric speculated masses in the left breast. This is her workup. So the mammogram demonstrated lemorphic microcalcification in linear distribution, very suspicious. And if you look carefully, you will see that the underlying speculated mass, where we already saw the mass on the CT and MRI. And then when we compress the area, like usually for the calcification, we do spot magnification views. And this also highlights the underlying speculated mass. Probably there is another one here. This is the ultrasound, and it demonstrates a irregular shape hypocholic mass with internal calcification. There are another satellite lesion in the vicinity. And the axillary lymph node is abnormal as well, with thickened cortex and a little minimal cortical bulge. So we biopsy both the breast lesion and the lymph nodes, and both are positive for invasive ductal carcinoma. This is a 77 years old with small pulmonary nodules, and in her CT scan, we see a small lesion in the medial right breast. Workup demonstrates a very small speculated mass in the lower inner quadrant of the right breast. And on the ultrasound, it is irregular shape, heterogeneous. There is no definite exterior acoustic features or internal vascularity. And pathology came as invasive ductal carcinoma. So just don't forget to look at the breast in all modalities. Those are patients like the pathology, radiology pathology concordance was not very accurate. So like there's this patient presented with left breast lump at 1 o'clock. There is a general lumpness of the right breast. She had a history of excised phylloides and with LCIS and sclerosing fibroadenoma in the right side. She now presented with the left breast. This is the palpable area, and her breast is extremely dense. So when we compress the area, it persists on the cone compression view. And then this is the ultrasound. There is hypocholic mass. There is possible surrounding echogenic rim and minimal vascularity. The biopsy came as stromal fibrosis, excuse me, negative for ETB or malignancy. We thought this is discordant with the imaging finding because although the stromal fibrosis can appear suspicious on ultrasound and there can be overlap, this lesion remains concerning based on the mammography and especially the ultrasound characteristic. So we gave the surgeon either two options, either to rebiopsy the lesion or to do excisional biopsy. So they decided to do the excisional biopsy, and this is our cover wire through the lesion. Ideally, this is the lesion here. Ideally, the thick part of the copper wire should be within the lesion, but like sometimes, we try to push it more. Sometimes we are not successful, but just we will report it in the localization before that the lesion is around the tip of the copper wire. And the surgical pathology came as a residual invasive ductal carcinoma, NPR grade 2, and the lymph node was negative. 84 years old female came for screening. this is her 2016 ultrasound, and there is small, I would say, partially obscured mass in the CCD, probably circumscribed because I see more than 75% on the MLO. And then that was not that was not included in the report at that time. And then on the 2020, they said the nodule is stable compared to 2016 and likely benign. In 2023, the lesion is increased a little bit in size. So we did a workup for that lesion, including cone compression view and ultrasound. And the ultrasound demonstrated fairly circumscribed. Probably there is some irregular margin in the inferior aspect. There is posterior acoustic enhancement. And the biopsy came as and we said this is indeterminate by Rad-4. Biopsies came back as benign mammary tissue. That were like that was not, it was not very suspicious on the ultrasound, and then we thought that we didn't, there is no cells like suspicious cells or any certain pathology on it. So we will say, okay, we will follow it in 6 months, and we gave it by Rad-3. And then patient missed her 6-month follow-up. She came after a year, 2024. There is also again interval growth of the lesion, and now it is more lobulated. There is some angular margins, and we biopsy this lesion again, and it came back as atypical papillary neoplasm. And the pathologist mentioned that differential diagnosis could be ADH, DCIS, papillary, DCIS encapsulated papillary carcinoma, and invasive papillary carcinoma. So this is the localization with the new seeds we got now. This is the magnetic seeds. This is the MLO, CC, and this is under ultrasound. So the final surgical pathology came back as encapsulated papillary carcinoma and ductal carcinoma in situ, grade 2. So what is encapsulated papillary carcinoma? It is a rare histological subtype of papillary neoplasm and constitute approximately 0.5 to 1% of all breast carcinomas. Usually it is well circumscribed. Some demonstrate cystic changes with vascular papillary projections. So when it is cystic, it might appear more suspicious, but like with the solid nodule as our patient, it is sometimes hard to justify the suspicion, and also the indolent, slow growing behavior make the diagnosis sometimes challenging. Now I came to my last group of patients, my favorite cases. So this is unusual pathologies and unusual tumor behavior. First case is a 42 years old with type 1 insulin-dependent diabetes presented with palpable mass. So this is the BB marker over the area of palpable abnormality. And there is some architecture distortion. There is focal asymmetry seen in the CC and MLO. No definite mass is identified. And then on the ultrasound, we see a just vague hypoechoic patch of tissue at the area of palpable abnormality. There is no internal vascularity, no posterior acoustic features. The pathology came back as dense fibrosis, periductal and perilobular perivascular lymphatic infiltration, suggested with the epithelial stromal myofibroblast, suggestive of diabetic mastopathy. So Diabetic mastopathy is usually present with large, painless, hard breast mass, multicentric or bilateral involvement is relatively frequent. The pathology demonstrate lymphocytic mastitis and stromal fibrosis. There is dense fibrosis and predominantly B-cell lymphocytes infiltrate surrounding the ducts, lobules, and vessels. On mammogram, it is ill-defined masses or asymmetries. And on ultrasound, it could be a regular hypocholic mass with marked posterior acoustic shadowing. And on the MRI, it is ranging from decreased diffuse contrast material enhancement to rapid intense enhancement that is indistinguishable from breast carcinoma. This is another companion patient from the internet, and it just demonstrates area of focal asymmetry and heterogeneous tissue on ultrasound. This patient is 84 years old, presented with distended enlarged left breast with skin redness and their queering infection. This is her mammogram, and there are multiple areas of course calcification. There is this area, ill-defined area of focal asymmetry seen in DCC and MLO, and this is her last mammogram I found in the system. So that was from 2017. There was nothing on that area before. On the ultrasound, we saw a ill-defined echogenic area. And that was the differential diagnosis at that time. Is fat necrosis, lipoma, hamartoma, is it hematoma, infection, breast hemangioma, and invasive breast carcinoma. So we did 2 biopsies. The first biopsy came as necrotic tissue. They didn't see any cells on that biopsy. So we did another biopsy, and they said that there is no evidence of malignancy, and special stains confirmed a myeloid tumor of the breast, which can be associated with rheumatoid arthritis and multiple myeloma, and this patient has a rheumatoid arthritis. Next patient is 53 years old, came for screening. She has a sister with breast cancer at the age of 35. On her heterogeneously dense breast, I couldn't see anything. Also on the CC view. So like our protocol here, for every patient with the breast category C or D, we do a combination of mammogram and ultrasound. And mostly we do automated breast ultrasound. So this is images for the automated breast ultrasound. Usually we review the coronal image, and we look for any masses. We can see them as black holes or architecture distortion. It's easier to see on the coronal, and then we correlate with the axial images.
Oh,
sorry. So this is the axial image, and it demonstrates ill-defined hypocholic mass. That is correlate. This is the nipple, and usually the tech will mark the nipple for us just to have accurate clock description of the lesion. So this is at 12:30 we did, and this is also from the automated breast ultrasound. We can magnify, we can zoom, and we can just move the cursors to see is it a fat lobule, is it discrete lesion. And the handheld ultrasound confirmed that there is ill-defined hypocholic mass, which is indeterminate. We biopsied that lesion, and it came back as B-cell lymphoma. PET scan demonstrate hyperactivity in the same location, and other large hypermetabolic lymph nodes. This is a follow-up after 1 year, the same area. And this is the beauty about the automated breast ultrasound. So it is not operator dependent. Usually they will take 3 volumes and sometimes 4 volumes according to the size of the breast. And you can go correlate and look at the same spot again, and you have the full image coronal and axial for the breast. This is a companion patient that I found only ultrasound for her, and this is a regular shape hyperechoic heterogeneous mass. This came back as follicular lymphoma grade 1 to 3. This patient is 56 years old female, came for screening, and it was really strange story. So this is her screening mammogram, and it demonstrates a regular shaped hyperdense lesion in the inner half of the left breast. We did ultrasound, we found this irregular shape, hypoechoic mass. Like you need to play with your depth and your gain to see that there is a soft tissue. That's why I brought those images. Not very sure if there is soft tissue. Is it cystic? The irregular angular margin, it's enough one feature that will lead to biopsy, but it's better to have the images like those to show that this lesion is soft tissue lesion. And there is angular margins. This is the biopsy and the biopsy leading going through the lesion. So this came back as spindle cell neoplasm. And they said it could be leiomyosarcoma. Surgical pathology came as leiomyosarcoma of the breast. 3 months later, the patient presented with right knee pain. So we did X-ray. I don't know if anybody saw anything. So there is some degenerative changes could be, and there is a large soft tissue mass posterior to the femur. They requested the X-ray and the bone scan in the same day, and there is increased activity in the inferior aspect of the right femur, and then in multiple images, and there is some pulmonary nodules that hypermetabolic, and there is skull metastasis as well. So, and then the biopsy confirmed that this is the primary site of the tumor. This is the MRI. This is stereo images demonstrate hyper intense lesion with heterogeneous enhancement. And this is the sagittal and axial plane. So that was a case of leiomyosarcoma of the lower limb metastatic deposit to the breast. So this patient is 67 years old, came for screening. Then we saw focal asymmetry in the upper outer quadrant of the left breast. We did compression view, and that area persists. We did the ultrasound, and we saw a irregular shaped hypoechoic mass with posterior acoustic enhancement possible. There is cystic component of this lesion, and there is internal vascularity. Biopsy came back also as a spindle cell neoplasm with giant cell and heterogeneous bone formation. This is the immunohistochemistry. And this is the localization. The diagnosis was in November, and 2 months later, at the day of the localization, the mass just tripled in its size. There is some areas of hemorrhage, but mostly it is soft tissue. And look at the mammogram now. It just occupies most of the upper outer half of the breast. So that's at the presentation was 1.7 by 1.8, and at the time of localization, it was 5.3 by 8.7 by 6.4 centimeters. So that was unusual behavior for spindle cell to be this big in this short period of time. This my last patient. This is a really dilemma. We couldn't explain it, but I just it's hot from the oven. It's just 2 weeks ago, and I share it just to have your insight about this patient. So this is a 76 years old female presented with right breast lung. And this is the area of palpable abnormality. Her breast is very heterogeneous, busy, and there are multiple nodules. Most of them are cysts. So we did like bilateral screening ultrasound. And this is the mass here in the inner lower quadrant posterior third of the right breast. It is quite superficial, quite palpable. The patient came with palpable abnormality. We were able to feel it, and the surgeon was able to feel it as well. This is the ultrasound, and it is quite vascular, hypodense mass with irregular margin. And the biopsy came as invasive, poorly differentiated carcinoma. It is ER negative, PR negative, and HER2 negative. The biopsy was in October, and the surgery was in January, 3 months apart. And on the day of the surgery, it was not localized by seed or anything because it was quite palpable. At the day of surgery, the surgeon could not palpate the lesion. They couldn't find it. They called the radiologist. The radiologist came to the OR, ultrasound, no lesion. We couldn't find it on ultrasound either. We brought the patient back to the department. We did the mammogram, and the lesion just vanished. This is the ultrasound, nothing there. So if you have, the patient is booked for MRI, not done yet, but I'm looking for your insight. Thank you very much.
Thank you very much, Dr. Hiba Muhammad Osman, for this wonderful presentation and for sharing these interesting, unusual cases with us. I'm sure that everyone here is pleased with the variety of these cases. So thank you so much. Dr. Hiba is joining us from Calgary, Canada, and she took time to attend all the sessions today with us, although it was literally short after midnight by her local time when we started. Thank you so much, Dr. Hiba. يا دوب الوقت صفحت عندك. Thank you so much for the time you took to attend this symposium. We do appreciate that, and we're looking forward to welcoming you soon in the upcoming February MDT meeting, inshallah. Bismillah. So the discussion is now open. Please raise your hand if you have any question for either Dr. Hiba or Dr. Nadia. I can see that Dr. Meret is not here now. Or you can drop your question in the chat box with the name of the doctor you wish to ask, and I will read the question for them. Dr. Rabab, are you here? Dr. Rabab, any questions on the previous two presentations by Dr. Nadia and Dr. Hiba? Let me check the chat box.
لو سمحت لي يا نورس.
اتفضلي.
السلام عليكم. السلام عليكم.
وعليكم السلام. أهلا يا بصي، زيك دكتورة وشاح، أهلا كيفك؟
I have just a comment يعني. الله يبارك فيك، الله يبارك. الحقيقة يعني حابة أشكر دكتورة هبة شكري شديد يعني ما شاء الله تبارك الله يعني she select very nice and very interesting cases. ويعني I really يعني استمتعت جدا جدا بالعرض بتاع الكيسز يعني هاروي ذاته يعني the presentation is very nice. فبنشكرها شكر جزيل جدا جدا على مشاركتها معنا المشاركة الثانية، وبنتمنى إن المشاركات معنا تستمر يعني إن شاء الله.
بإذن الله.
thank you very
وعدانا
much.
دكتورة
وبرضه حابة
هبة
أشكر دكتورة نادية برضه.
اتفضل
إن شاء
أنا
الله،
قطعتك
وإن شاء الله
معلش.
لازم تواصل معنا الكيسز لأنه she has a very interesting يعني cases
فعلا
حقيقة.
فعلا.
يعني بنتعلم من الكيسز دي كتير وبنستفيد منها كتير يعني إن شاء الله. برضو حابة أشكر دكتورة نادية شكري كتير يعني برضو على البرزنتيشن الجميل بتاعها، ويعني دايما بتخدنا معاه في الصورة بتاعت المعمل وبتاعت الباثولوجي وكده وبنفهم منها كتير يعني، فبرضو بشكرك كتير.
كتر خيره ومشكورة
شوفي
شديد.
لو في questions أو لو ما في أفتكر أظن شوفي يا نورة ستي نستقي عشان نطلع
تمام.
البريك.
ما شايفة في questions لكن let me check again the chat box. Yes there. طيب في question من دكتورة مي. After thanking you, Dr. Hiba, she said, in case of diabetic mastopathy, surgical excision is recommended, or we can be satisfied with a true biopsy.
Usually we do just biopsy. We don't do excision for that.
Okay. Another question from Dr. Hana. She says, can I ask Dr. Hiba about the BI-RADS for diabetic mastopathy?
So usually we biopsy it like after, like before the biopsy. It's a ill-defined area. We need to biopsy, so that will be BI-RADS for. And after the biopsy, you can either BI-RAD it as BI-RAD 2, and you can either recommend a 6-month follow-up, or if according to the suspicious appearance of the lesions. So after the biopsy, you can BI-RAD it at 2.
Okay, and Dr. Amira is asking about the differential diagnosis of your last case. Could it be hematoma? Could you include hematoma as part of the differential diagnosis?
The last case was biopsy-proven invasive carcinoma, undifferentiated.
Mm-hmm.
So it was like in the differential could be, but it is biopsy-proven, and also it has that angular margin, so it's like we cannot go without biopsy that lesion. So it is already biopsy-proven. And so my question for Dr. Nadia, we were asking our pathologists, they said like they didn't see a vanishing tumor before, but they said that there is tumor infiltrating lymphocytes. Do you have any insights about that?
Yes, I also raised my hand. Thank you for the lecture. Very interesting cases, and I think the clincher was the last one because I would go back to my slides, but since your pathologist says it's malignant, vanishing, I think in Sudan we would say mashat li-sheikh, because we have cases like that.
أنا كنت عايزة أقول لها دكتورة نادية أقول لها يمكن عملت رقية ولا حاجة زي دي.
عملت رقية.
عملت رقية.
But you have to update us on that case. Somehow you have to tell us what happened there.
MRI is scheduled next week.
Yeah, but even what you have now is really confounding. It is something that is really difficult because, like for me, I'm a pathologist and I look at the slides of tumor cells, and I need my personal thing is to be convinced by the oncologist that they can put these cells that have gone crazy back in line. This is my dilemma, that I need to be convinced, and I have been asking for courses I think they are even more important now with all the treatments that we can get, is radiology, oncology courses for pathologists, so that they know how to issue reports relevant in that area, because to convince me as a pathologist that can put those cells back into line is very difficult, because when I look at the slide and I see it malignant, it's gone crazy. The cells go crazy from a very systematic, nice histology to just they can do anything. But disappear, I have never heard that.
Yeah, me too.
Without any intervention, I mean.
Yeah, nothing. I like even the surgeon was very surprised. No chemo, nothing.
Yeah, and it's a very short time. It's from December to January. So just keep us posted. Have I answered your question in all this?
I don't know if tumor infiltrating lymphocyte TIL has anything to do with that.
This one, of course, is a new study, is a new area, and some of my students now, the registrars, they have research on that because it's being categorized so that it can be used in routine lab reports, and is becoming one of the factors. But to that extent, I think it's too short a time, and it's too much. I think it's not an explanation, but there must be an explanation.
Mm-hmm. It is 3 months though, but it's also short, I think.
It's a very short time, yes, for something like this to add.
Yeah.
Thank you.
Well, I hope that the rest of her workup will be ready by the next MDT, so we can discuss her again and see what comes new. Yeah, inshallah, inshallah. So thank you very much, Dr. Nadia Al-Mudawi and Dr. Hiba, for this amazing presentation. We did enjoy the cases and everything you presented very much. So if there are no other questions, we will go now for the second break, and we will come back, inshallah, to start our final part of today's symposium, which will discuss an interesting phenomena seen in our Sudanese patients that I'm sure will attract your attention. We will meet, inshallah, at 5 p.m. Khartoum and Cairo local time, which is 3 p.m. GMT, inshallah. So see you all soon after the break. Good evening, everyone, and welcome back to the third and final part of today's multidisciplinary symposium regarding the different perspectives in the management of breast cancer. We were honored today to have a group of outstanding breast radiologists and an eminent pathologist with us who shared their valuable knowledge and experience in the field of breast cancer management. So thank you very much for the amazing presentations. It is now the time to meet with Dr. Rabab Balla, a consultant radiologist and the founder of the Sudanese Society of Breast Imaging, also the head of Women Imaging Unit at Soba University Hospital, and Mr. Mohammed Al-Fateh, a consultant surgeon and assistant professor of surgery at the Faculty of Medicine at Khartoum University. They will be discussing the findings in unexpected lymphangitic spread in Sudanese women. So Dr. Rabab, you may share your screen now with us and start your presentation.
Can you see my screen now?
Yes, we can see the screen and we can hear you perfectly.
Okay, thank you very much. Thank you, Dr. Nauras. بسم الله الرحمن الرحيم وبه نستعين والصلاة والسلام على أشرف المرسلين سيد الخلق أجمعين. Good evening. Welcome everyone to the last session of SSBI today's symposium. It gives me a great pleasure to share with you our local experience of unusual breast cancer spread, the unexpected cross-midline lymphangitic spread of breast cancer to contralateral breast in Sudanese women. I'm not lucky to do my talk after all these excellent presenters. I don't know why it is not moving. Okay. My screen. Why it is not moving?
Try to unshare and share again.
طيب unshare from where I have to unshare?
From the
From
Zoom.
where?
اللي هي the same icon that you press to share بتبقى
Yes.
مكتوب فيها unshare, so press on it. the green icon السهم اللي فوق, press on it.
I press لكن ما ظهرت لي unshare. الله, no. How can? لا ما ظهر إنه unshare when I have to unshare.
Could you leave the slideshow and then try
Okay,
to
stop sharing. Okay, stop sharing.
Yes.
Okay.
Now unshare.
It's okay. One. Which one? Okay, wait. This is here.
The box with an arrow pointing upwards. Yeah.
Wait.
Take your time, Bob.
This one. Type. I don't know what happened. Why it makes like this? Just type share.
Yes, it's
Okay.
sharing
Is it?
now. Yeah. Yes.
Okay.
Yes.
Okay, so the outline of the presentation includes an introduction, discussion of the etiology and radiological appearance of breast edema in mammography, sonography, and breast MRI, provide an overview of inflammatory breast cancer, exemplify multiple cases of our patients to illustrate the role of breast imaging, particularly the MRI and ultrasound in the evaluation of inflammatory and non-inflammatory local advanced breast cancer associated with median brain cancer spread. And at last, we'll go through our study that explains the radiological findings in breast cancer among Sudanese women, highlighting the unexpected cross-midline lymphatic spread to contralateral breast. You know, breast cancer is the most prevalent woman cancer globally, and there were 2.2 million في أيوة هنا مغطية. اوكي طيب let me remove الشاشة مغطية لي جزء من اوكي. Breast cancer is the most prevalent woman cancer globally. There were 2.26 million cases of breast cancer in 2020, and it is responsible for 12% of new cases as 2021, according to the WHO. And the global burden of breast cancer is rising fast and varies greatly among countries. Breast cancer is the most common cause of women cancer deaths, and it affects women after puberty with increasing incidence in older age group. And there is no rich information about breast cancer in Sudan. However, limited data shows a prevalence of 3.9 cases per 100,000 women from 2010 to 2016. And the latest statistics showed it represents 34% of Sudanese female cancer, highlighting its role as a leading cause of cancer-related death among Sudanese women. Lymphatic drainage from the breast primarily occurs through the ipsilateral axillary lymph node, though up to 30% may drain to other sites such as internal mammary and supraclav. Drainage to contralateral axilla CAM is rare, and ultrasound and MRI are more effective than X-ray mammography for detecting lymph nodes. Metastatic breast lesions are rare and accounting for 1.3 to 2.7% of cases, mostly from contralateral breast. Imaging may reveal additional cancer in the opposite breast in 3 to 24% of patients, influencing treatment decisions. Again, stuck. Okay. Breast cancer typically spread to regional lymph node and later to distant sites via hematogenous routes, and rarely can also metastasize to the lung through lymphatics, resulting in lymphangitis carcinomatosa, a serious condition associated with late-stage disease. Lymphangitic carcinomatosa or carcinomatosis sometimes also cause carcinomatous lymphangitis, refer to a pattern of metastasis characterized by the spread of tumor emboli to lymphatic vessels of distant sites. A lymphangitic spread to the contralateral breast is rare. Inflammatory breast carcinoma is rare and aggressive, and with ominous prognosis, necessitating prompt interventions. Bilateral occurrence of inflammatory carcinoma is even more rare, with contralateral involvement only in 1 to 5% of cases. The complexity of inflammatory breast carcinoma emphasizes the importance of awareness and timely action against this challenging disease. Cross-midline lymphangitic spread in breast cancer possesses a clinical concern marked by unexpected lymphatic extension across the midline to the contralateral breast. So this study rigorously examines the radiological features of this phenomenon in 212 breast cancer patients out of 515 Sudanese women evaluated at Soba University Hospital and Universal Hospital in Khartoum from December 2020 to January 2023. Identifying these features is essential in enhancing management. So what are the causes of breast edema and how does it appear on mammography? As you know, breast edema appear on mammography as increasing density, trabecular thickening, and skin thickening generally. Okay, it can be focal, as in this case, and it can be global, as in this case, seen in both sides. And generally, we expect to see a benign etiology, especially on bilateral. But this is our patient having bilateral inflammatory carcinoma. On ultrasound, it appears as increased echogenicity, okay, as well as the swollen fat locules and diminished differentiation, fat glandular differentiation, as well as these angular hypoechoic networks, okay, due to a collection of the fluid in the subcutaneous lymphatics, as well as in the interstitial spaces, okay, and sometimes also we can have increased size of the breast as well as skin thickening. On MRI, also it depends if it is focal or diffuse. Here, this is the focal edema with trabecular thickening and increased T2 dense intensity. You see, on mammography, increase the density, on ultrasound, increase echogenicity, and on MRI, increase T2 intensity. And as we mentioned, it depends if it is focal or diffuse. With diffuse, when we have global reticular pattern due to trabecular thickening, as well as asymmetric global skin thickening, and we can see enlargement of the affected breast, as we have seen in these cases here. So what is the cause of breast edema? Generally, there is a spectrum from benign to malignant, and the common cause of, or the common etiology of the breast edema are benign causes. However, we are always concerned about breast cancer, and especially inflammatory breast cancer. So what is the inflammatory breast cancer? It is an unusual but the severest and aggressive variety of locally advanced breast cancer, and it represents a T4D. It is rare, as we mentioned earlier, represent 1 to 5%, but it is an unusual and severe, okay? And understanding its key difference from other breast cancer is essential. The symptoms of inflammatory breast cancer are usually manifest very quick within few months, roughly 3 to 6 months, with diffuse edema, BD orange, and erythema, and should be cover more than a third of the breast, and it's often not associated with a palpable lump, and also might not be detected on mammography. Demographics usually affect women younger than 40, and disproportionately affect a Black woman, overweight and obese woman. And pathologically, as we mentioned, it is an aggressive type of breast cancer, can be associated with any subtype of primary breast carcinoma. But dermal lymphatic vessel must be involved, this characterizing the conditions, okay? And the prognosis, as we mentioned, it is rapid, progressive, and spread, progressively grows and spread, and it is usually diagnosed as stage 3. Since it represents TD, T4D, regardless of the lymphatic status. However, third of the cases diagnosed at stage 4 with already metastatic involvement. Generally, inflammatory breast carcinoma have a worse prognosis, so early detection is vital for effective treatment. Okay, how is inflammatory breast carcinoma diagnosed? Like other cancer, it should be undergo triple assessment: clinical, which is typical, as we mentioned, presented with triple presentation of edema or swelling, BD orange, and erythema. However, in early stages, usually it is challenging because of overlap with mastitis. Radiology plays important role. We are going to talk about it. And the final diagnosis definitely is the pathology by taking biopsy from both skin, puncture skin biopsy, as well as from the lesions, suspicious lesions within the breast. So what is the role of imaging in the evaluation of inflammatory breast carcinoma? Is to identify suspicious lesions, guide a biopsy, stage inflammatory breast carcinoma to differentiate curable from incurable stage 4 disease, and it helps in plan management as well as monitor neoadjuvant treatment, confirm and quantify the disease response. as my colleague already mentioned earlier. Okay. So how does it appear on imaging? Here on mammography, it appears like a global edema, as we described earlier. And sometimes we might see suspicious mass or suspicious calcifications on the X-ray mammogram. On ultrasound, the same features of global edema. And ultrasound might also help in demonstrating and characterizing a suspicious mass, as we have seen our case here, or a non-mass like lesions, as we have seen also in these our patients. And on MRI, again, the same findings of global edema with global asymmetric skin thickening, okay, showing the reticular appearance. See, this is the reticulations. Okay, even here, this is the reticulation due to trabecular thickening and global edema. The skin thickening usually asymmetric, as well as the typical MRI or unique MRI appearance is a dendritic type of enhancement, non-mass-like enhancement, as we have seen in this image, and enhancement of the overlying skin thickening, and we might see enhancing masses or non-mass-like enhancement or the enhancing masses might be smaller and interconnecting. This beautiful place is Khartoum University Hospital, from where I graduated. Have you seen such an extensive spread of breast cancer across the median plane into the other breast? Any of you? Have you seen this picture before? Okay. For me, I have never seen such interesting cases since I started my career in breast imaging in Saudi Arabia, 2003. And here I can show you some of my old cases. These are 3 cases, okay, related to me. I reported before. Can you see? Extensive breast cancer, diffuse, involve the whole breast, large, all are locally advanced breast cancer, and even in this example here, involve the medial breast with the skin involvement. However, none of these demonstrate any extent across the breasternal region. Again, locally advanced left breast cancer with a larger lesion, more than 5 centimeters, infiltrating the adjacent skin. And this is again my patients with this left breast cancer causing rigidity of the left breast and infiltrating the adjacent skin and demonstrating a very extensive, very lesion, lymphangitic spread, okay? However, we raised that issue since long time on the report and was confirmed on pathology, but there is nothing extend across the midline to the contralateral side. Again, another patient of mine, I reported long times outside Sudan, and here we can see, can you see again the lesion on the medial breast, and we can see a lot of vessels around the lesions, some of which definitely are lymphatics. However, extending vertically into the chest wall rather than traversing into the other side. You can compare it with our patient here. You see, this is our Sudanese patient. Can you see the vessels going, okay, across the midline, okay, to the contralateral? And can you see it here in the breasternal region? The reactions lymphedema and the vessels, reactive vessels around the lesions extending into contralateral with a contralateral involvement and lesions seen there. While working abroad, I stayed connected to Sudan, but I wasn't fully engaged in breast imaging clinic until the end of 2021. After returning home, I began working at two excellent institutes in Khartoum. This beautiful place is the Soba University Hospital, and this luxury place is Universal Hospital, a private facility dedicated to improving patients' care. And then I have started to see such type of cases. Okay, this is the first example here. The patient demonstrates ulcerating mass in the right retroareolar region. This is part of the mass, and this is here where the ulcers going toward the medial breast. We can see edema in the right medial breast with some infiltrates. Going to the midline at the valley between the two breasts, I can see here significant edema with some infiltrative process. And this is one of the lesions in the midline, even infiltrating, overlying the skin at the chest wall in the midline. This is another example, a 35-year-old female treated for breast cancer with conservative therapy. While on adjuvant chemotherapy, experienced right breast symptoms. It is obviously here we can see there is global asymmetry and global edema on the right breast with overlying skin thickening, and that is the site here of the previous surgical scarring. Can you see any suspicious findings in the contralateral breast, the left breast mammography? It is difficult to say there is something. I had this type. What?
في حضرتك retroareolar densities يعني like ductal.
Okay, excellent. Well done. There is something,
yes.
yeah.
But
the parenchyma, this such type of coarse, complex type of parenchyma, though the breast is not significantly dense, it is predominantly fatty, but the residual parenchyma is coarse and complex, make it difficult, okay, to properly evaluate it. Okay, let us go for ultrasound. Here, this is the ultrasound of the ipsilateral side, the right breast, demonstrate the remarkable edema of the parenchyma as well as overlying skin with infiltrate into the retroareolar region as well as in the upper outer quadrant at the scar sites with significant edema. And
Dr. Bob, can you come close to the microphone because your voice is very far now?
Okay.
أيوة كده واضح.
كده أفضل؟
أيوة
كده
كده.
أفضل؟
Yes, أيوة.
Okay. So as we mentioned, here we can see at the site of previous scarring, we can see multiple masses with surrounding edema, okay? And going more medially, look for the skin thickening, even more thicker than at the site of recurrence overlying the scar, okay? There is edema with lack of fat glandular differentiation, as well as more thickening of the skin. And here we can see recurrence of pathological adenopathy with typical malignancy infiltrating the adjacent pectoralis muscles over the 3 levels of the axilla up to level 3. The same patient, contralateral breast. Here we can see this is the edema at the valley between the two breasts, you see, with the skin thickening. There is edema and skin thickening. Going to the contralateral breast, there is edema of the nipple areolar complex with suspicious underlying breast lesions. Next case here, a 55-year-old female, primary radiological diagnosis presenting with left breast abnormality. And here we can see the suspicious lesion in the outer breast with overlying skin 0.5 centimeter. However, here there are significant skin thickening 1.3% with non-mass-like lesions below the nipple areolar complex. Okay, and this is her level 1 axilla, pathological, highly suspicious lymph node going. Okay, this is again in the outer breast, satellite nodules. Okay, and just 0.6 skin thickening. But when we go toward the medial aspect of the ipsilateral left breast, we can see more edema and more skin thickening without underlying index malignancy. You see, here you can see 0.8 centimeter, and even here it was more with dilated lymphatics and a collection of the fluid in the interstitium and lack of differentiation, tissue differentiation. The same patients going more toward the midline. Here you can see in the midline, look for the edema and overlying skin thickening at the valley between the two breasts. Okay, and here again, this is in the midline. We could pick these multiple suspicious lesions with some vascular echoes. And going to the contralateral medial breast, you see, we can see skin thickening edema, and also we can see this suspicious small lesion, as well as contralateral pathological adenopathy. The next example, these patients, also initial diagnosis. Okay, this is the left axilla, pathological highly suspicious lymph node, and again the primary index lesions, multiple lesions in the outer breast, mainly upper outer. Okay, but look for the skin. Okay, the thickness of the skin overlying the primary index lesion on the outer breast, compare it with the skin thickening in the medial breast where there is no real index mass there. Okay, going more toward the midline, here at the midline, you can see all these infiltrates with skin, some skin thickening. This is at the valley of the breast, and even it is thickened. And this infiltrates, you can see it here, even invade the overlying skin at the valley of the breast. Another patient, elderly woman, presented with recurrence. This presented with recurrence after 1 month, 1 month after a mastectomy. Okay, MRM. Okay. Can you see? Can you see here? This is, okay, multiple nodules, subcutaneous nodule at the site of mastectomy, as well as the skin nodules. These multiple skin nodules, even when I start to count the number of these skin nodules, multiple nodules at the in subcutaneous, as well as overlying skin. Okay, and even extend deep within the medial, more medial aspect of mastectomy site. While here, the lateral aspect of the scar, okay, toward the lateral half of the breast, it was clear. There is nothing there. More in the medial half of the right breast, and also extending to the valley of the breast. Okay, this is the midline lesions. Okay, this irregular and going to overlying, invading the overlying skin with extensive edema. And the same extent to the contralateral breast. This is the left breast, okay, medial left breast, demonstrate infiltrative process with overlying skin thickening. Do you remember this case? I sent it in our WhatsApp group on the same day of the radiological diagnosis on 15 March 2022. Do you remember this image? This the Sudan breast tumor board. Okay, next example. This interesting case. This a 40-year-old lady presented after diagnosed with right breast cancer, treated with wide local excision, chemo, and radiotherapy. Developed while she was on adjuvant therapy, start to develop swelling in contralateral left breast. At the beginning, she was diagnosed as mastitis due to, they said she has lower immunity and she might develop infections or something, and she didn't respond. Then they sent her to our department to do breast MRI. I started for her with this ultrasound, and I found there is extensive infiltrative process throughout the left breast, more toward the outer aspect, but still some infiltrates involving the retroareolar region as well as the medial aspect of the breast. Here you can see, but this is strange enough, this is the only axillary lymph node present in her left side, left axilla, but definitely it demonstrates breaking capsule and invasion of the adjacent tissue, which is highly suspicious features. And here, this is the retroareolar region, and you can see the infiltrations going into the subcutaneous lymphatics, okay? And this is the ipsilateral outer skin thickening and prominent lymphatics. Going to the medial aspect again on the medial breast, though the lesions are, the parenchymal infiltrates are less, but the skin thickening is more or was more. The same patient with treated right breast, can you see here? This is the extreme medial ipsilateral left breast. You see the edema and this overlying skin thickening going toward the midline. This is edema at the valley of the breast in the midline, going to the medial contralateral breast, the skin thickening approaching 5 millimeter, okay? Here, with lack or diminished fat glandular tissue differentiations, skin thickening, and even there is infiltrate in the lower inner contralateral breast. The same patients here, we can see in the outer breast, this is haphazard vascularity. You see, it can be lymphatics versus just new vascularity around the infiltrates in the outer breast, but going toward the medial breast, if you look for the underlying parenchyma, there is nothing seen. There is no parenchymal infiltrate, but there are network of haphazard subdermal lymphatic vessels seen throughout the ipsilateral medial, here going toward this is still ipsilateral medial, going to the midline, you see, going to the midline here, and going the same to the medial contralateral breast with skin thickening and edema and infiltrate in the contralateral side as continuous disease process without interruption. And this is her MRI. And here you can see the global edema on the left breast with enlargement of the affected breast, extensive trabeculations, increase in the edema is really extensive, and we can see it here extending, you see, in the subdermal region across the midline to the medial aspect of the right breast. However, that was the site of the scar of the wide local excision. Can you see it here? Okay, that is the scar site, the scar site. It was clear, but the disease now is in the left breast and extending across the midline to the right breast. And even this lymphedema demonstrates enhancement, and the overlying skin is restricted on diffusion. Here, this is the ADC, demonstrate lower intensity, and it intensely enhances more than the outer breast. Can you see here? This is the site of scarring, the skin over the scar, and this is away from the site of scarring. It is even more thicker. And here in the medial breast, it is about 13.5 millimeter. And not only that, we can see also multiple lesions in the contralateral medial breast on MRI. And here we can see this is the edema extending into the medial aspect of the right breast. This is the extreme medial right breast, not only subcutaneously, but also extend into the deep lymphatic plexus. The same patient. That is why I said this is an interesting one, because again, they treat these patients with neoadjuvant chemotherapy and then underwent left mastectomy. Unfortunately, they ignored the right breast findings. Okay, and they were planning to go for radiotherapy. Okay, but there was problem and the radiotherapy delayed. She came back to me, okay, after a few months, and she said she want to do further imaging, and this is her imaging. Okay, again, the site of the right scar, it was still clear. There is nothing here, but the disease, okay, in the medial breast is still extending, okay, across the midline and going back to the contralateral breast, because post MRM, the margin were clear. There was no disease on her pathology. But now, again, the disease process from the residual, not treated, right breast going back into the left breast and infiltrating the chest wall. Can you see here? Even there is some diffusion restrictions. The next patient here, at initial diagnosis, again presented with upper outer quadrant lesions, okay, about 5 centimeter, and this is the only, I think it was the only level 1 axillary lymph node, okay? And can you see the skin thickening overlying the index lesion in the outer breast? Compare it with the subareolar. This is not strange to have subareolar lymphatics, plexus and lymphatic engorgement and skin thickening expected because of Sabis plexus. But the strange one is the medial breast. Why the medial breast? Showing also the same as the subareolar region, even more thick skin and edema and engorged lymphatics. Can you see the lymphatics here? You see, and skin thickening and edema is even more extent than overlying the index cancer in the outer breast. And can you see here, this is in extreme medial ipsilateral going to the midline, okay? The edema extend into the valley. Can you see the edema, how it is much in the valley of the breast, between the two breasts? And this is a suspicious lesions in the parasternal region, in subcutaneous parasternal region. And here there is edema in the contralateral breast with infiltrative, mild but an infiltrative process. This is another patient, okay, presented with extensive malignancy in the outer half of her breast, with again with highly suspicious axillary lymph nodes breaking capsules and surrounding edema infiltrating the adjacent tissue, another lymph nodes. And here these are the index lesion in the upper outer and lower half of the outer breast. And again, the skin thickening, it was about 4 millimeter. But again, the retroareolar demonstrates remarkable skin thickening, 1.5 centimeter, and the same on the medial breast. Again, can you see the medial breast here, how extensive edema, okay, and skin thickening, and there is some softish component within the these lymphatics and interstitial fluid collections. It was not a pure. Can you see this subdermal lymphatic vessels, how it is prominent? And here even the soft tissue within this small lymphatic demonstrates some posterior shadowing. And going further, okay, toward the midline, can you see the edema, how it is extensive in the midline? This is the midline edema. This is between the two breasts. This is subcutaneous. Okay, look for the edema and look for the skin thickening, how it is thickened. Okay, this all at the midline, different levels from above going down at the midline between the two breasts demonstrate this extensive edema with collections in the interstitium and subdermal lymphatics. And the same extent of edema going into the contralateral side. Can you see the skin thickening and edema in the contralateral side? And there is a suspicious lesion in the extreme medial contralateral breast. This is the same patient, okay? One of the lesions in the outer breast, I could pick up the soft tissue mass extending into the subdermal lymphatics. Can you see the invasions of the lymphatic vessels and the soft tissue extending here? You see, across the vessels. And on the medial side, she has this big subdermal lymphatic with tumor emboli within the lymphatic vessel interrupting the flow, okay? Here, this is again some of the lymphatics in the medial ipsilateral, but all these interrupted vessels, okay, with some soft tissue were seen on the valley of the breast in the parasternal region. Another patient. This patient, again, the majority of our patients, like in the literature, having the cancer in the upper outer breast, as we have seen in this patient, it was non-mass-like lesions, hypoechoic infiltrative process within the parenchyma with extensive surrounding edema. And these are pathological adenopathy in the ipsilateral axilla. But on the medial breast, you can see this very big subdermal vessel. Another patient, I did not show her primary index lesions. It was also in the outer breast, probably upper outer, okay? But I'm showing you her medial breast. Can you see the medial aspect of her breast where there is no index cancer, but there is extensive edema, okay? And we can see the dilated lymphatics and the interstitial fluid containing soft tissue. Okay, and here this is in the midline. These are in the midline, and this is the midline 0.6 millimeter midline lesions. Okay, the same patient, can you see her lymphatics on the medial aspect of her breast? This is subdermal lymphatic vessels with soft tissue within the these dilated vessels. Going toward the midline, this is the vascularity, or this, the Doppler echoes were seen not in a normal breast tissue, not in a normal breast vessels. These are just interrupted vascularity, just in the subcutaneous and subdermal, okay, and seen extending across the midline from the ipsilateral medial left breast across, this is ipsilateral medial left breast across the medial into the contralateral breast. You see, can you see it here? And not surprisingly, to have this patient to have this extensive adenopathy disease burden extending up to the supraclavicular region. I remember this case. She was a 66-year-old lady, had right breast mastectomy in 2002, and in 2022 presented with a mass brew in her left breast, proven to be invasive ductal carcinoma, as we have seen here, very typical mammographic appearance. But if you look interestingly, the medial skin, even it was thicker compared to the skin overlying the cancer. And here we can see extensive edema and vascular lymphatic reactions around the index lesions. And can you see the vessels extending to the overlying skin, and these vessels extending here in the subdermal location and going back into the axilla. But look for these subdermal vessels on the medial aspect of the breast extending to the site of mastectomy with this focal area of subtle increased intensity on the stair. Interestingly, on both contrast image, this is the index cancer, but look for the overlying skin, compare it with the medial skin, more thickened and enhanced. Even the intensity, it was more than the other skin. Even the areolar skin was not thick as the medial skin. And these are different levels, okay? But I select where the skin here is relatively more thick. And can you see the extension of the skin thickening and enhancement over the mastectomy site? Not only that, even there is abnormal enhancement, which is nodular enhancement with this fine enhancement line extending into the overlying skin. And this area, the intensity of this area was much more than the remain of the skin seen here. This is enhancement at the site of mastectomy after 20 years, but extending from this side of the breast. This is another patient's, okay, initial diagnosis. Look how extensive the edema into the left breast and how extensive extending along the peristernal subcutaneous region or the valley of the breast and involve the medial aspect of the contralateral breast. And this is the contralateral breast. This is a superficial edema, okay, lymphedema, and this is the deep one infiltrating, okay, or involving the deep pectoralis facial plexus, okay. We know that MRI is a tool of choice for evaluating inflammatory breast carcinoma. And this is the same patient showing that extensive edema. And here you can see the extensive disease, malignant disease in the left breast. Okay, here multiple mass and non-mass like interconnecting with enhancing bands, malignant bands. And can you see these enhanced lymphatics vessels going from the parenchyma toward the medial skin, not well appreciated laterally, though the disease, the burden of the disease is more, though it is diffuse, but it is more toward the lateral aspect. Can you see it here? And here in all image, you have seen it more on the lateral aspect, but the lymphatic is more medially. Not only that, the skin thickening, enhancement, and restrictions involve more this specific area in almost all of our patients. This area very close here to the midline, this lower portion is the maximum area of involvement in almost all patients. Can you see here? This is there are nodular enhancement within the skin, and here the maximum enhancement and the maximum restrictions. Okay, and there are multiple scattered lesions across the valley and in the medial aspect of the breast, you see, and demonstrate restricted diffusions. Here you can see the lesions in the contralateral breast and the lymphedema, enhancing lymphedema across the valley of the breast. And if you have seen here, you can see one of the vessels, okay, irregular vessels going toward the nipple areolar complex, suggesting of a lymphatic vessels going toward the sabis plexus, and along its way, we could find this small lesion which demonstrate, which exhibited intense enhancement on post-contrast study. Next patient, it was 24-year-old lady. I remember this sad story. This lady, she was lactating, presented with BD orange and rapid onset of breast hardening, was suspected as a purpular mastitis. And I have lost her ultrasound image. Okay, I start for her because she was lactating. I started for her with ultrasound. I couldn't find it, but this is her MRI. Okay, again, demonstrate extensive disease proven to be lobular carcinoma, invasive lobular carcinoma. Can you see again, low on T2, okay? This is the index cancer, okay? There was a mass and non-mass like enhancement, infiltrative process, okay, invading. Can you see here? This is some extent, I couldn't, it is difficult to bring all the images. I was trying to select some of the images that represent some of the features, but this was enhancing, okay, enhancing vessels extending vertically from the lesions into the overlying skin with mild skin thickening, and look for the some reactive vascularity, okay, around the vessels, suggesting lymphangiogenesis or new lymphatic vessels reaction around the lesions. She has also involvement of the deep lymphatics. Okay, here you can see the pectoralis involved and also enhanced by lymphatic involvement. And the interesting, can you see the vessels here? Enhancing vessels extending from the lesions toward the nipple areolar complex, which is not, it is expected findings. It is not unusual to see the extent of lesions But though it is not usual to see it frankly like this macroscopically, usually we have seen a microscopic effect of inflammatory breast carcinoma, demonstrating the features, the enhancement of the skin and the edema. But if we have seen just invasions of the skin, usually we have seen the same lesions, the mass extending into the adjacent skin, but seeing and enhancing vessels, thin vessels like this, it seemed to be lymphatics, because it is in continuation within the lymphatics, within the nipple areolar complex, okay? And interestingly, it is usual to drain the breast lesion, to be drained into the nipple areolar complex if it does not go directly to the axilla. But it is what is unusual is the presence of this medial, okay, lymphatics. What about this medial lymphatics regions? Look for this network of vessels here, this network of vessels, okay? Can you see it here even? And extending across the midline, going toward the contralateral side and associated with edema. Here we have a questions. Shall we consider it T4D, inflammatory carcinoma, or T4B, locally invasive cancer involving the overlying skin? This is another patient, okay? Also initial presentation. She was 37-year-old lady lactating, complained of right breast lump for 1 year. Her mammography ultrasound was not so impressive, but this is her MRI, which demonstrate on ultrasound, just we suspect she might have cross-midline without presence of lesions in the midline, but there is subtle suspicious findings on the medial aspect of the contralateral breast. We could appreciate it on MRI as 1.6 centimeter enhancing lesions, okay? And here the lesion was 10 centimeter right breast malignancy. It was invasive papillary carcinoma, and with involvement of the axilla as well as internal mammary node. This is one of only 2 patients I found that they have internal mammary node involvement. All of other patients, they have no involvement of the internal mammary, could be appreciated on imaging, okay? And furthermore, even she had a thrombus in the tumor thrombus in the internal mammary vein. And here you can see this is the extensions of the lymphatic vessels across the midline. She received, she was, her clinical staging at that time, it was T3, N3B, and M0, okay? And grade 3 ER, BR positive, HER2 negative. She received chemotherapy, and after the 2nd cycle, she developed right nipple discharge. Her physician's request for her follow-up MRI. Unfortunately, we could see significant regression, not only of the primary cancer, but also of the cross-midline lymphatic vessels, significantly regress, and the contralateral breast small lesions is completely disappeared, and the tumor thrombus also was disappeared. This was the first patient I have seen when I start to think about cross-midline lymphangitic spread, but unfortunately, I have lost all of her images except for these few ones. She was 38-year-old lady, had right breast cancer, underwent chemotherapy and mastectomy. While on adjuvant therapy, she experienced bilateral changes, okay? She was sent to me to be evaluated radiologically, And ultrasound and MRI demonstrate right locoregional recurrence, okay, with and features of inflammatory carcinoma in the contralateral breast, proven to be the same type of the breast cancer on her right breast later, but unfortunately, while she was on treatment, she passed away. Here you can see this is the recurrence on the side of MRM on the right side, involving the 4-layer of the chest, okay, skin, subcutaneous, muscles, and the chest wall, ribs, as well as the intercostal muscles, and she had regional lymph node extending up to the supraclav. Can you see the skin thickening and the muscle thickening and enhancement, as well as the rib? Here we can see only part of the contralateral medial breast skin and demonstrate nodular enhancement. It was a typical feature of inflammatory carcinoma. So it is not surprise to see all this locally advanced breast cancer in our country. This is following the literature, and here we can see a latest Sudanese study published on 21 May 2024, demonstrate 50% of locally advanced breast cancer in their study, with 32% metastatic disease or stage 4. Okay, so is there a normal cross-midline lymphatic passage between the breast? Is there normal cross-midline lymphatic passage between the breast? Any answer for anyone who want to answer this question? Okay.
Yes, Rabab, I think. Yes.
Yes, you are right, Muna. Yes, there is. As we know, the lymphatic drainage 70-75 to the axilla and the remain to internal mammary nodes and others less common pathway. Okay, but across the mammary, the internal mammary can cross the midline to the contralateral and can be a pathway to spread the disease to the contralateral breast. And in our patient, we have only 2 patients having internal mammary lymph node. However, there is a normal superficial lymphatic network, as we can see here. This is what we have seen in our patient. This superficial lymphatic network is a continuous connection across the midline, interconnecting the lymphatics passage between the 2 breasts, okay? And it can be engorged in case of breast disease process. So if it is normal, what is abnormal? If the cross-median breast lymphatic pathway is a normal condition, what is the abnormal? The unusual is the way of cancer spread, okay? Though it has been mentioned in the literature as one of the pathways that may occur when the usual channels are blocked. However, we could not find a similar case in the literature, and we can go through some of locally advanced inflammatory and non-inflammatory cases. This is from the literature. See how extensive and large disease without any evidence of disease going from one side to the others. Another 4 examples here. One more example, advanced disease involving the chest wall and the skin without any extent to the contralateral. Again, even ulceration without going to the lateral breast, and even on PET scan here, demonstrate extensive involvement of the disease with inflammatory and locally advanced cancer without any evidence going across the midline. And here, this is illustrations of the lymphatic pathway of the breast. And we can see this is the deep lymphatic across the facial, what we call it facial plexus, running across the fascia, the pectoralis fascia, or the fascia covering the pectoralis muscles. Okay, and here we can see the superficial plexus in the dermis and subcutaneous portion of the breast, except for the subareolar region, which considered to be a deep plexus, not part of the superficial plexus. And here we can see the lymphatic drainage from the parenchyma of the breast, lobules and ducts going directly toward the subareolar plexus. The other way, it can go directly to the axilla or to the internal mammary lymph nodes. So if we take these examples of our patients, this is only 10 millimeter index lesions expected to be either directed toward the internal mammary, axilla, or toward the nipple areolar complex to the subis plexus. However, can you see directly going back along the medial aspect of the skin? You see, this is, sorry, this is a large vessels here, large subdermal vessels extending from this index lesion along the medial breast and going, this is different levels, demonstrate these are tortuous, nodular, okay, subdermal lymphatic vessels extending toward the contralateral breast and associated with skin thickening. Can you see it here? This is on both contrast and stair view, demonstrate the extension of these abnormal subdermal lymphatics going, you see how it is engorged, going to the contralateral side instead of going back into, this is the normal vessels, this is a normal vessels, okay, going from directly back. This is different from these vessels going just underneath the skin. And if we look for these three examples, we have seen some of which, but we did not see the others, okay? Look for the skin thickening overlying the index cancer in these three examples, compare it with the medial breast where there is no parenchymal cancer, could be appreciated in these cases. Look why the skin is more thickened, why the lymphatic engorge in the medial breast of our patients. Look for the engorgement in the different patients in the lymphatics and even with tumor emboli causing thrombus within these vessels. Okay, these patients, okay, it was, she was a 43-year-old lady, had history of left breast invasive ductal carcinoma treated with lumpectomy, chemotherapy, radiotherapy for 2 years. Okay, she developed pain and presented for radiological evaluations. Okay, and we found she had features of recurrence proven on pathology. Okay, that is the site of scarring. Okay, in the upper outer breast, and the enhancing lesions here. But the new lesions was at subareolar region, which is expected and signify this is a lymphatic way of metastatic lymphatic metastasis, I mean. Okay. Okay, this is not strange to have this recurrence at the subareolar region, but look for the skin thickening overlying, okay, the site of an edema, overlying the site of recurrence, and even the subareolar region, compare it with the medial side of the breast. Look for the medial aspect of the breast, how the network, okay, the skin edema, the skin enhancement, and even it was restricted on diffusion, okay, and extended throughout, and look for the subdermal vessels going to the contralateral breast. If we can say radiation and surgery damage lymphatic vessels, leading to change in a lymphatic flow. But why, okay, why the medial side specifically involved like this in all of our patients? And these here we have different examples, and others, the contralateral involvement was observed at the initial diagnosis before surgery and radiations. Blockage, there is theory that also, or there is literature proving the blockage of or damage of the lymphatics can also occur by the underlying tumors, okay? But if we consider it due to the underlying tumors, but why selectively going, select only this way? Why did not one of the patients going to subdiaphragmatic, to the peritoneal direction, to the supraclav? Why all of our patients going directly to the medial sides across the midline to the contralateral breast? And interestingly, I have shown this to you, these examples of having surgery, okay? Having surgery in the right breast. If we say there is surgery in the right breast and cause the directions of the lymphatics to the contralateral left breast, but the cancer, when involved the left breast, going to the right, to the affected sides, again is the directions. This is one issue. And after surgery of the left breast, again, the cancer going from the affected right breast back to the treated left breast. So there are a lot of challenging questions about these cases. And also, in addition to the above mentioned, another factors in our patients which make it unique is the presence of this network in the extreme medial breast, close to the midline, close to the valley of the breast, okay? In a specific location is a common specific location between all of our patients, okay? And whatever the lesion is lateral or medial. Can you look here? The index lesion, lateral. The index lesion, medial. Okay? The index lesion, lateral. Diffuse process, whatever it is, diffuse, medial, lateral, at the end, all they are going to a network in the medial breast. So, because of that, we raise a hypothesis that this might be a variant, okay? We have claimed that this is probably representations of an apparent superficial dermal lymphatic plexus in the medial breast, facilitating this lymphangitic spread across the midline as the unique structures in the Sudanese ladies. We think, or we thought about the other possibility of the process of lymphangiogenesis. But lymphangiogenesis usually, though it is not yet very clear, it is under study according to the literature, but in lymphangiogenesis, the network, like angiogenesis, the breast cancer excrete lymphatic factors when spread through the lymphatic vessels and result in the development of a new lymphatic vessels from the pre-existing vessels, the same way as the angiogenesis. But why selectively taking this place to develop this angiogenesis? If it is related to the lymphatic thrombus, as we have seen on ultrasound, on MRI, the tumor thrombus going, this is a lymphangitic because we have seen very frank the extensions of the tumors from the inside the subdermal or subcutaneous lymphatics and going to the other side within the same breast and within the contralateral breast. So these observations uncover a significant trend that deserves our attention. And we aim to describe these new discovered radiological changes for better understanding of the radiological imaging pattern, which is crucial for effectively identifying and addressing this emerging disease spread pathway, avoiding delays in the diagnosis, ultimately supporting timely interventions and improving treatment outcomes. But at first, I appreciate your understanding regarding the quality of the images, which may not fully meet expectations due to limited resources. These photos were taken with my phone while collecting patients' radiological data. Another challenge, most patients from other hospitals visited our radiology departments and breast imaging units solely for imaging, which complicated the tracking of their pathology results and treatment. Only selectively, some of the patients we could catch their pathology. However, we found that nearly all participants were confirmed to have breast cancer and began treatment through phone communications, with some returning back for follow-up imaging, as that case I explained to you or presented to you. Despite these challenges, it is crucial to address the unique presentation of breast cancer in Sudanese women based on observed radiological features. And this initiative aims to raise awareness and encourage further research into Sudanese breast anatomy and contributing factors. The spread of breast cancer through lymphatics to the contralateral breast across the midline is exceptionally rare, and there is limited literature on this phenomenon, and to our knowledge, no comparable studies have been reported. We have conducted a thorough literature search, and we found several case reports highlighting the occasional lymphatic drainage of the breast to the contralateral axilla in context of the breast cancer. However, only one case report described an unusual pattern of breast cancer with lymphatic metastases to the contralateral breast. Furthermore, it did not especially detail the typical findings observed in our patients or in our studies. And this is a study, sorry, excuse me. This study mentioned that the lymphatic spread of breast cancer has not been reported at site other than lungs, chest wall, and skin. It also stated that the diagnostic impact of lymphangitic spread to the contralateral breast is not well understood. These statements support our hypothesis that cross-midline lymphangitic spread is a newly discovered phenomenon. This is the case. It was carried out in 2019 in Southwestern Medical Center in the US, describe a 58-year-old woman with triple negative invasive lobular carcinoma spread lymphangetically to the contralateral breast and detected by MRI as a significant non-mass-like enhancement. MRI performed because they found pathological lymph node in the contralateral axilla on contrast enhanced CT. And here we can see this is the invasive cancer in the right breast. It was 7.5 centimeter with large involvement of the axilla. And here, this is the non-mass-like enhancement in the contralateral breast, pathologically proven to be a lymphangitic spread. And they stated that this should be classified as distant metastasis leading to metastatic workup. Accordingly, they found a leptomeningeal metastasis in her brain. The patient underwent a bilateral mastectomy, radical on the ipsilateral side and modified on the contralateral side. And as of the publication date, she had been mentioned for 16, she had been monitored for 16 months post-diagnosis and had returned home with her family. She was okay. Please note, no obvious extension across the median plane peristernal region as seen in our cases. This case, there are two case reports published after we completed our study, one in January, the other one in June 2003, both from Florida in the US. The first one reported a bilateral inflammatory carcinoma in 60-year-old lady, initially detected on imaging. And this is the case here. You can see the CT demonstrate bilateral inflammatory carcinoma as well as PET scan and on clinical examination here. This photo from her clinical findings. However, none of these demonstrate any extension across the median plane, demonstrate the connection between the disease in the two sites. And the second paper or second case report represent a contralateral recurrence of inflammatory breast carcinoma in less than 1 year after the initial diagnosis in a 39-year-old lady with a stage 4 inflammatory breast carcinoma. She did not complete her treatment, and the diagnosis was initially detected on imaging. Okay, and the patient received chemotherapy regimen similar to her previous statement. The case, or this case, highlights the uncommon occurrence of contralateral recurrence of inflammatory breast carcinoma and hypothesized mechanism of lymphatic spread, suggesting local metastasis rather than a new primary tumors. Okay. And this also underscores the importance of magnetic resonance imaging in evaluation of soft tissue and lymphatic changes. And here you can see, okay, there is bilateral inflammatory breast carcinoma in both breasts on MRI and PET scan. Apart from this crossover vessels, which is a variant, there is nothing can demonstrate a connection between the two breasts. The literature review regarding contralateral axillary malignant lymph nodes, they stated that lymphatic scintigraphy advancedly improve understanding of the lymphatics of the breast lymphatics, confirming that the lymphatic flow to the contralateral axilla. And a research shows the contralateral axillary lymphatic drainage occur only in 0.3% of women, however, increasing to 2.8 in those with history of breast cancer surgery. And Hutchinson demonstrated that tumor cells can reach contralateral axillary lymph nodes via deep lymphatic plexus. It is important to perceive that contralateral regional metastases occur mainly by lymphatic way and not by hematogenous spread, supported by experimental element and also by the fact that not a few cases have contralateral regional metastasis without involvement of distant metastasis. Contralateral axillary lymph node, or CAM, is rare, accounting for 1.9 to 6%, and however, a serious concern, and present management challenges due to unclear laterality. And they claim that, or they give 3 possibilities for the involvement of the contralateral axilla, either from an occult metastasis in the occult cancer in the ipsilateral breast, or from a contralateral breast, or from site of other organs. Synchronous CAM is very rare, reported in 0 to 2%. However, the metachronous in 14.7%, and they classify, and its classification as
دكتورة رباب.
Yes.
صوتك بيجي بعيد شوية.
Its classification as stage 4 metastatic disease remains debated, okay? The potential for contralateral lymphatic drainage is significant and influenced by tumor locations, by patient anatomy, and this is emphasized, we have to emphasize on this point that it is being influenced by patient anatomy. So that is why we raise a hypothesis that the Sudanese lady might have an anatomical variant. Okay, and they said that it is highlighting the need for tailored management strategies. Okay, and the development of CAM associated with aggressive histopathological features, okay, of primary tumor, including higher tumor grades, lymphovascular invasion, large size, ER negative, and HER2 over expressions. And here we can see and a case report in 2022 in Japan demonstrate contralateral lymph node involvement in a 71-year-old lady presented with 5 centimeter palpable abnormality in a skin invasion in the right upper inner breast. Okay, and they found bilateral pathological adenopathy proven to be cancer, okay, or metastasis. The preoperative diagnosis was clinical T4 bilateral N1 M1. So T4, because already they have mentioned that there is skin involvement. Bilateral N1, okay, and M1. In spite they didn't find any distant organ metastasis, they consider it M1 because they consider the contralateral axillary involvement as distant metastasis. The histopathology was grade 3 invasive, ductal carcinoma, ER positive, HER2 negative, with no distant metastasis. Okay, and they stated that not all aggressive histopathological features were present in their cases, underscoring the variety of tumors that can cause CAM. Not necessarily to have all aggressive feature we have mentioned earlier to develop CAM, okay? And their patient had only T4, okay? And and they have lymphovascular invasion, but it is not ER negative and it is not HER2 overexpression. It was ER positive and HER2 negative. And they speculated that because the lesion located in the medial breast, okay, that is why it extends to the contralateral axilla. And after 4 cycles of chemotherapy, she had clinical partial response and underwent a partial mastectomy and bilateral axillary lymph node dissection. And the patient was alive and recurrence-free 1 year after her treatment. And they concluded that CAM is often regarded as distant metastasis, but can be curable. and it is and therefore are no, if there is no distant if there is no metastasis to the other organ, it will be a curable disease. Okay, let us go for our study, which is a multicenter descriptive cross-sectional hospital-based study. Enrolled 515 patients, referred to the patients imaging breast imaging clinic in both SOBA University Hospital and Universal Hospital, and underwent breast imaging mammography ultrasound with or without MRI in the period from December 2021 to January 2023, almost 1 year, and included all adult women, okay, excluded the men, adult women having BI-RAD 4C to 4 to 6, excluding male, and excluding those who have BI-RAD 0 to BI-RAD 4B, as well as imaging from other institutions, technically inadequate imaging, and incomplete breast imaging report. Our results. Naomi et al. Our result, we found the frequency of breast cancer 41% in our study. Okay, and Naomi and et al. Found this percentage in 948 individuals, or 948 individuals screened in Australia. Okay, and the incidence rate were much higher in more developed countries compared to less developed countries. This highlights a contradictions, especially compared to our Sudanese or our study from Sudan. And we believe this high frequency in part may arise from our research primarily conducted on patients referred to a leading tertiary hospital, SOBA hospital, and specialized breast units. Okay, and it was not a true screen detected study. A cross-midline was suggested in 32.1% and highly suggested in 20.7%, but not suggested in only 47.2%. And this depends on the features. Okay, we have seen on the images when there is a full-blown pictures of cross-midline, we have suggested or we have observed in our patients, and extensive changes seen across the midline, then we consider it as a highly suggested, as we have seen in such example. These are different patients, demonstrate highly suggested. And we consider it as a suggested if a milder or fewer signs are seen, okay, such as contralateral adenopathy and medial skin extending along the, and this is the prominent vessels extending across the midline. Another suggested, we have also seen the extension of skin thickening going along the medial side to the superior, involve the superior region in the contralateral breast. We can see here even small lesions in the contralateral breast. There are findings, but it is not as extensive as we have seen in the previous example. And if we have a patient with breast cancer, but there is no any of these signs could be appreciated, then we call it as a not suggested case. Okay, regarding the demographic characteristic, the mean age of our patient was 49.4 years, and these findings were in agreement with Sudanese study of Al-Awad et al., who found a mean of 47 years, and a Nigerian study found 48.9 years. The peak age of breast cancer, as you know, in some Asian and African countries was over 10 years earlier than in European and or American countries, according to the literature. Approximately 80% of new cases of breast cancer are in women aged 50 years or above, according to the literature. However, we found the majority, 51% of our patients under the age of 50. And furthermore, despite the literature reported the breast cancer under 40 in only 5 to 7%, we found 17.5% under the age of 40. And this result highlights concerning trends of increased affections in younger age group, possibly due to racial disparities, genetics, lifestyle, environment, among other risk factors. However, our result was reported by a literature, was supported by a literature review article performed by Najjar and his colleagues, including 28 articles from Arab countries, including Sudan. They found the average age at presentation of breast cancer in Arab countries appear to be a decade earlier than in Western countries. Okay, again, there is no significant difference of suggested cross-midline lymphangitic spread between the age below and above 50. The majority of our cases, okay, had index cancer in the left breast, okay? 56.6% were in the left breast, while only 4.2% were in the right breast, and the remain about 40%, it was bilateral breast, which is very high number. However, our result regarding the left breast involvement is in concordance with Leon Z et al., who reported most of breast cancer patients, 78% had primary tumor in left breast. However, there is no literature answering this question, why it occurs. However, our patients with left breast cancer were not statistically affected more with cross-midline lymphangitic spread when compared with right one. Most cases of our patient had indexed lesions in the upper outer quadrant, followed by retroareolar, okay? And these findings were in the same line with Allison et al., showed upper outer quadrant side in 50% and Elizabeth et al. In 33% and Amir in 54%. However, the suggested cross-midline lymphangitic spread to contralateral breast was common among the patients with lower inner quadrant lesions, seen in 75% of our patients, with statistically significant difference from other locations. It's followed by retroareolar region. Interestingly, Kimasu et al. Okay, speculated that the lymphatic flow was directed contralaterally because the tumor was located in the medial part of the breast. Most of our patients were categorized as by Rad-5, which expected findings, with statistical significant difference, cross-midline lymphangitic spread to contralateral breast, including CAM, was common in BI-RAD-5 cases compared to BI-RAD-6 and 4. And Laura et al. Reported contralateral axillary lymph node metastases in 67 of lesions classified as BI-RAD-5 versus 14% only for patients with BI-RAD-4 with statistical significance different. About 30% of our patients had index lesion size greater than 5 centimeters. And the majority of our patients were having cancer more than 2 centimeters. Consistently in the study, in a German study, demonstrate 54% of breast cancer had lesion greater than 2 centimeters, and a Turkish one, they have index lesions was more than 3.6. The mean index lesion was 3.6, but we haven't, but it was not more than 5 centimeters. It is not surprising to find a cross-midline spread to the contralateral breast was significantly higher in patients with index lesion size more than 5 centimeters and least in lesions less than 2 centimeters. Index lesion extent. Okay, our study presented 37.7% multifocal disease. Okay, as you have seen here, 34.5 multicentric, and only a unifocal disease is seen in 27.8%, signify aggressive disease. The reported incidence of multifocal and multicentric breast cancer varies widely in the literature, ranging between 6 to 60%. And the higher incidence seen recently due to improving imaging techniques. And our observation were in accordance with Gamis et al. And Francisca and DCIS, okay, et al., who reported multifocal in 37.4, 32, and 60% respectively, and DCIS also found 46% multicentric cancer. There was significant strong associations, okay, of cross-midline spread to contralateral breast with multicentric disease extent compared to the other group, followed by multifocal, which is expected findings. 91.5% of our breast cancer cases had axillary group lymph node involvement, and this rate was higher than the studies of Gamis et al. 60.3%, and Aksoy et al. 37%. Results reflected our patient presented late with advanced disease. Findings signals status of relatively poor resource countries, diminished effective prevention strategies, lack or decrease in health awareness, and difficult access to medical treatment, all of which were extremely important to curb the snowballing breast cancer burden. It is not surprising to see this type of aggressive adenopathy disease burden in patients with cross-midline lymphatic spread. And it is unshocking to see statistically significant difference in cross-midline spread to contralateral breast with involvement of supraclavicular group followed by the internal mammary group versus less adenopathy disease burden. Here you can see the cross-midline present in those who have supraclavicular seen in up to 92.3%, followed by 87% in those who have internal memory. Okay. Disease extent, an extensive disease, as we have seen in this MRI image, was seen in about 30% of our patients. And it is not surprising to find that the cross-midline spread to the contralateral breast was statistically significantly associated with advanced and aggressive radiological findings, namely by Rad-5, larger index lesion more than 5 centimeters, multiple lesions or multiple index cancer, extensive primary breast cancer, and lymph node involvement than their counterpart. So with extensive disease, we found up to 90.5%. Mammography and ultrasound were the major radiological modalities performed in our patients, followed by ultrasound along with MRI in 18.4%. But we have only 7.5% had only MRI because their conventional images were from outside institute and we excluded. The suggested cross-midline lymphatic spread to the contralateral breast was commonly seen 81.3% on MRI. And this is expected findings that due to sensitivity of the MRI with a significant statistical difference from the other two groups of both MRI and ultrasound. This is, I suggest, because the number of patients having only MRI plus ultrasound are much less, but expected to be much more than on mammography and ultrasound alone without MRI. By using ROC analysis, MRI showed the highest accuracy, which is expected findings. And the MRI findings, as we mentioned, as you know, that in breast cancer patients, you might find the mass, okay? We might find the non-mass enhancement, okay? Or a restricted diffusion. This is the ADC, so lower signals, okay? And here, the presence of enhancement was seen in 78.2%, and the mass seen in 43, while non-mass seen in 27, and so forth. Okay. Here, we can see the cross-midline was suggested in a case of, was suggested on 77.3% in a patient who have restricted diffusion on MRI, and I think this is unexpected findings. Laura Etar reported contralateral axillary lymph node metastasis was present in 67% of highly aggressive type of malignancy with statistical difference, significant difference, and this can explain that why the cross-midline associated to the contralateral breast is associated with diffusion restriction. As you know, the more restricted diffusion, the more higher malignancy. Okay, and however, it was not significantly associated. There is no significant difference between mass and non-mass like enhancement on MRI abnormality. This is table. This table demonstrates the summary of ultrasound and MRI qualitative analysis, demonstrating the features of cross-midline and how frequent. And we found that the highest in the list is the overall skin thickening, extending across the midline, reaching the medial contralateral breast, followed by pathological adenopathy. We can go through in the example with image so as to be more clear, and this demonstrate their accuracy and sensitivity. They found that the highest accuracy for detection of unexpected cross midline was reported by the skin thickening, okay, as we mentioned in the earliest table, followed by pathological adenopathy, then dilated lymphatic vessels with or without soft tissue, followed by parenchymal edema extend across the midline, and at last the single prominent lymphatic vessels. This is the commonest features detected on our study. Okay, the skin thickening extending from the ipsilateral breast across the midline to involve the medial aspect of the contralateral breast, as we have seen in these three examples, with statistical significance difference from other features, and the same findings on ultrasound. This is followed by CAM, contralateral axillary metastasis, also with statistical significance. Here we can see these two examples having bilateral adenopathy. This is the ipsilateral, and this is the contralateral, even with metastasis, adenopathy in the. And here, this is the index lesions on the right breast and having pathological adenopathy in the contralateral, and the same findings seen pathological adenopathy in contralateral axilla on ultrasound. And this is the third common sign, also with statistical significant difference, representing the dilated lymphatic vessels, okay, with or without soft tissue on the medial ipsilateral breast, seen both on ultrasound and MRI, as we explained it earlier. And the fourth common sign was the parenchymal edema extending across the midline from the ipsilateral breast to involve the contralateral side, but it was seen in 25.5% without statistical significant difference. And this is the same findings on ultrasound. These all findings seen both on ultrasound as well as on MRI. And this is the fifth statistically significant radiological sign, which is the prominent lymphatic vessels crossing the midline to extend to the contralateral breast. Here, this is the ipsilateral side, and these are seen in the midline in the valley of the breast, as you have seen here in the marker. And this is in the contralateral side of the breast, in the medial breast, with edema and so forth. And this is the same findings, the lymphatic vessels in the medial ipsilateral breast extending across the midline to involve the contralateral breast in different patients. There are a lot of different variations in this appearance of lymphatic vessels. We have to differentiate it from the normal blood vessels, okay? Especially if we have seen it like this, it will be more more characteristic, because are small and perpendicular to the skin. This is one of the features I observed to characterize it, okay? And here, the problem when we have a single vessels, large single vessels, we might say this is a blood vessels, but this it is also connected with these subdermal vessels, either with a single vessel like this or with multiple smaller vessels and interrupted. It will not, we try to trace this vessel to see if it will go perpendicular to the chest wall going into the internal mammary, but no, this will not go like that, but instead it will go horizontally across the valley, okay, toward the contralateral side. These are the normal blood vessels. We can see it here. Yes, we can see it close to the skin, parallel to the skin, but at the end it will go toward the chest wall and enter into the internal mammary. Okay. Lesions in the contralateral breast is one of the features, but doesn't show a statistical significant difference, presented in 25% of the patients. We have seen all of these or most of these images before, representing the contralateral lesions, and the same findings on ultrasound demonstrate multiple cases having contralateral breast lesions. And these are lesions, okay, in the midline, okay, found in 15.6% of patients. These are different patients having a midline suspicious findings, suspicious lesions, but it was not statistically significant, significant difference from other features. This is the same midline lesions on MRI, and the direct lymphatic vessel invasion was not a statistically significant difference, seen in 10.8%, as we have seen here, the direct invasions. Okay, let us go for the conventional images, okay? And the features in the conventional suggested cross midline on the conventional images in order of frequency. Also, we found the skin thickening is the top on the top of the features or radiological features, okay, extending across the midline to the contralateral breast, seen in 21.7%, less than on ultrasound with MRI together. Okay, on ultrasound with mammography, it is less, and because mammography is not as sensitive as MRI and ultrasound, and followed by focal parenchymal edema in the adjacent medial breast, then global edema in the contralateral breast, followed by focal asymmetric asymmetry in the contralateral breast on mammography, then global asymmetry in the contralateral breast, and then masses or lesions in the medial contralateral breast. And here we can see a mammogram of the left breast. If you look for this, definitely there is global edema, typical global edema with the skin thickening, parenchymal and skin edema, without obvious masses or suspicious calcifications. We can say, we can expect this is the primary site. The skin thickening almost 1 centimeter. However, this is not the primary site. This is the contralateral affected site secondary to the ipsilateral right breast. This was recently diagnosed to have locally advanced right breast cancer and was hugely enlarged. The machine could not get the image. Okay, we could image only the contralateral breast, demonstrate this extensive edema, and this is highly suggestive of cross-midline lymphangitic spread. Another patient here demonstrate, okay, extensive shrunken, okay, edematous shrunken left breast. Okay, and this is the cancer here in the outer breast, but the contralateral breast even demonstrate moderate edema with the skin thickening, and the edema even involve the deep plexus subpectoral region. In conclusion, breast cancer is a heterogeneous disease and has pattern and trend which vary in different countries, we reported a rare phenomenon of lymphangitic spread to the contralateral breast and axilla cam, resulting in lymphangitic carcinomatosa occurring across the median plane. Cross-midline spread is an unusual clinical scenario of lymphangitic spread that challenges the patient's treatment, representing a diagnostic dilemma, and it was suggested in a considerable proportion, okay, of our cases. This is almost the majority of our patients was suggested to have cross-midline, and surely this would have implications for breast cancer management and prognosis among Sudanese women, emphasizing the need for diagnostic imaging along with the oncologic assessment for successful treatment. And it is vital for the radiologists, especially women imagers, to consider possible cross-midline lymphangitic spread, especially on basis of ultrasound examination and subsequent suggestion to further evaluation with a more accurate breast MRI. Skin thickening and pathological adenopathy in contralateral axillary group were the main detected radiological findings. Unsurprisingly, the suggested cross-midline lymphangitic spread to the contralateral breast was statistically associated with more advanced disease, and therefore poor prognosis would be expected, and a proposed apparent superficial lymphatic plexus in the medial breast, in addition to the known anatomical subareolar subs plexus, which is postulated as a unique Sudanese woman's structure, presumed to mostly play a principal role in the common occurrence of the unexpected cross-midline lymphangitic spread in this population. The results of this study were based on radiological features alone that were not described before. We presume that this unique phenomena of cross-midline lymphangitic spread to contralateral breast represent a racial disparity of unique anatomical variants and breast cancer trends related to Sudanese women. More cases are currently documented, probably as a result of the more cases. These more cases currently documented, probably related to recent increased use of high-resolution ultrasound and breast MRI. This underscores the importance of these modalities in the evaluation of soft tissue and lymphatic changes. However, further information is needed to assess lymphangitic spread of breast cancer to contralateral breast and its prognosis in our populations. Our recommendations: we must advocate the better educations and resources to address this aggressively newly discovered phenomena, raising awareness among physicians, especially all Sudanese doctors, to be aware of and to thoroughly evaluate the unexpected cross-midline lymphangitic spread to the contralateral breast during the diagnosis and follow-up of breast cancer. Further multidisciplinary, multi-center, multi-approach prospective radiopathological studies with larger sample sizes are needed to emphasize the proposed theory and to evaluate for its more accurate frequency. Additional anatomic research of Sudanese female cadaveric as well as lymphocentric mapping is essentially needed to evaluate their possible lymphatic variations. And here you can see our references. Can we do better? Yes, definitely we can do. Together we are stronger. And all we agree that multidisciplinary management is vital in such cases, and much more efforts is necessary to go further into studying and fighting these phenomena. We have a question whether this strange phenomenon without distant organ metastasis should be regarded under the umbrella of distant metastasis or locally advanced breast cancer. In my opinion, I can see it is a local spread and therefore goes more with locally advanced cancer. But I'm waiting to hear from your side and what do you think about it and why, okay? At the end, I appreciate your participation, your patience, participations and listening, and we are waiting for your great informative discussions. But before that, I found this an opportunity to send my intense gratitude to all who shared in this study, starting with Dr. Mawadda, Dr. Mustafa Noor, Dr. Wishah, Dr. Huzaifa, all the technologists and other staff in SOBA and Universal Hospitals. And definitely, we cannot forget the continuous support of our fathers, Prof. Abdullah Jabir and Prof. Salah Kerjawil. Also, I am grateful to Mr. Muhammad Al-Fatih, who agreed to take the responsibility in the discussion from the surgical perspectives of this phenomena. Mr. Muhammad, the floor is yours.
Thank you very much, Dr. Rabab.
بس داير أقول دكتور محمد مستر محمد اعتذر يعني لظروف. He will not be able to join.
Okay. Now it is open for all of you.
Thank you. Okay, thank you very much, Dr. Rabab, for this extensive and comprehensive talk about this unusual phenomena. It was really an amazing, interesting, and very informative presentation. We really miss Mr. Muhammad Al-Fatih. He apologized because of his unstable internet connection, and we hope that he can join in the upcoming activities. And we also miss Dr. Rabab Al-Hassan for some reasons. She couldn't share with us today, and we are looking forward for her participation in the upcoming events, inshallah. Now we open the floor for discussion, and feel free to
Can I say
participate.
something, please? Wisha, can I say something?
Okay. You are welcome, Dr.
Well,
Ahmad.
I'm a surgeon. I can cover Mr. Muhammad's absence. So
yes.
Okay. You are welcome. You are welcome,
We'll be happy, Doctora. We'll be happy, Doctora Muna.
Thank you.
Muhammad, I know. Yes.
First of all, Rabab, I would like just to say well done and congratulate you for your effort to put all this together. The presentation, the imaging, and everything, in spite of the challenge we all know about the situation in Sudan and most of the stuff lost during رحلة النزوح واللجوء. صح? Well done, Rabab.
Thank you.
Very informative. I learned a lot, and to be honest, this phenomena is new, and I come to know about it only. It might not be new, but I come to know about it only when you talk to me about it. So is phenomena, and it need to be searched. I completely agree with you. It need to be searched. We need to know what is going on. From what I know a little more about inflammatory cancer, or I think it can represent similar phenomena. I think. Inflammatory cancer, we all know it is rare. It is rare entity, and now this phenomena is much more rare than inflammatory cancer. But in my opinion, this entity is part of inflammatory cancer. Because we know the mode of spread of inflammatory cancer to skin and subcutaneous tissue through the lymphangitic spread. We all know that. And just my observation or what I know about inflammatory cancer, it is, according to epidemiology and prevalence, it affects more Black African and Black American ethnicity rather than Caucasian ethnicity. So we all know that very well. It's much more common on that group. And I think this phenomenon now is a similar story, isn't it? Because we know now it is common in our population, which is Black African ladies. The problem, we haven't got research or research done even in inflammatory cancer is done in Caucasian people. So again, I would like just to second you and say we need to search it. We need to do research. It's difficult, it's challenging because we haven't got system, infrastructure and healthcare system in our countries to do this research because we haven't got the data. You said in your presentation you struggled to get the details of patient because the patient just come for radiology and then you miss them. It's going to be a difficult challenge to do research in this topic specifically. But if we put our hands together as multidisciplinary group, I think we can. Hopefully after this nightmare happening in Sudan is settled, we need to put our hand together to find out why we have this phenomena and to do some research. So this is about the comment about this phenomena. And you raised very important question because the ladies, they want from us treatment, management, rather than just to have a theory about it. So you raised the question, shall we treat this phenomena as locally advanced or metastatic? I think we had some discussion, Rabab, outside of this meeting together, and we have done some search. And I talked to one of my oncologists, and I showed him this MRI. You sent it to me, Rabab.
Yes, he agreed with us. Yes,
he agreed. He said this is like a very gray area. We can't say if it is a metastatic or it is a locally advanced cancer. But according to what I hear now from the mode of spread and same phenomena like inflammatory cancer, I think this phenomena represent inflammatory cancer, but with more extension to the other side. And we treat inflammatory cancer as locally advanced. We give as much as we can of treatment, multidisciplinary treatment, surgery, radiotherapy, chemotherapy, a lot of systemic treatment. So he said is a gray area. We don't know whether it is metastatic or locally advanced, but we have to take to take the benefit of doubt and regard it as locally advanced and extensively treated with systemic treatment, and then wait and see. And you can see from inflammatory cancer and even this phenomena, the prognosis is bad. So all that encourage us to treat it aggressively with systemic treatment and with aggressive surgery, actually, because in these cases, if it is inflammatory cancer and they got neoadjuvant systemic treatment, after that we do aggressive surgery, we do mastectomy, we do lymph node clearance. So this is actually my points. Just checking, I put some points in paper here. I think that's it. Unless someone else got any
Thank you.
interaction.
Mr. Muna, thank you very much. As Dr. Muna said, before, while I'm preparing this lecture, I start discussion with my colleagues in surgery, and I told them, as Dr. Muna said, I told her my impression about this, it is more toward locally advanced rather than metastatic disease because of 1, 2, 3, 4 points.
Agree.
Okay?
Yes,
and
I agree.
Some of them, Dr. Ramona, one of the surgeons who agreed with me, and some they disagreed according to the literature that said CAM is a distant metastasis. But even the recent literature, they are trying to put CAM as a regional disease rather than a distant metastasis. Okay? And Dr. Ramona, jazaha Allah khair, she told me, yes, I agree with you, but I'm going to ask one of our senior oncologists. And she told me his opinion as he described now. But from the beginning, while I'm discussing this case, you see, while I'm reading this case and thinking about it, I was suggesting that because it is just, there is something open between the two breasts, and it seems as if the cancer is spread from medial to the lateral breast, okay, extend to the adjacent, breast, as if it is the same, in the same way as is spread from
local spread.
Local. It is a local spread. It seemed to me it is a local spread through the dermal and subdermal lymphatics. Okay, and as I study in the literature, they have mentioned that now they are studying the phenomena of angiogenesis like angiogenesis.
Yeah.
That when the tumor is spread through the lymphatic, initiate or secrete factors that initiate a new lymphatics vessels. Definitely, it will be haphazard vessels. It will not be just like the normal lymphatics, as we have seen in our case. It might be the same, but still, my point, if it is just lymphangiogenesis, why specifically located at the same area in the medial breast of each breast, medial aspect of each breast, close to the valley of the breast? Why it is selecting this? This makes me thinking about a normal variant more than just a lymphangiogenesis. Might be aggravated by lymphangiogenesis.
Yeah, it might be, as you said, it's something in our genetics as Black African. I think it's something, it might be because as I said earlier, inflammatory cancer tend to get more in Black people, in Black African, whether it's African or American.
Yeah, so, it is in Black, yeah.
Yeah,
I agree with you. لكن if it is in Black, that means ما عارفة ما عارفة ما قدرت the aggressions. أنا معاكي في aggressions, and it behave as inflammatory and attacking the lymphatics and is spread through the lymphatics. All these accepted as racial factors. Okay, this is one of the factors, but the presence of the medial lymphatic vessels in all cases, this is the area, okay, need to exclude anatomical variants. This is my point, if you agree with me.
Research, Rabab.
I recommend, I recommend research specifically for this point.
Yeah, research asks all questions in medicine. So research, and as I said, there is a challenge in our countries, in Africa in general, to do research, to know what is the prevalence of cancer in our people. To know, we have got a challenge because I don't know, I don't want to go to the politics, but because of the corruption in the government, and the healthcare is at least at the bottom of the list of their priority. So there is no research, no infrastructure, no healthcare system. So research answer all
أنا خلينا نشوفك وأنت بتتكلمي ما في طريقة تظهري بالكاميرا.
والله
الدسكشن ده ما محتاج
والله صعب، ما أقدر أحتسع خالص بالبيجامة قاعدة.
لا خلاص. لا خلاص خلينا.
Thank you very much, Dr. Muna. Dr. Nadia. Now we can hear Dr. Nadia.
Yes, I totally agree with Muna. Definitely. I put up my hand for a quick question for your work, Rehab. We always include, because Sudan is such a mixture. Did you ask about the different, who was included in the study and from where they were in Sudan? Because we always include it in our research, because we have to make sure when they try to say Sudanese patients that first of all, they are all Sudanese. And the second thing is from where they come. Sometimes the differences can be explained because we are not one uniform background. We have so many different tribes and areas in Sudan. It's so big. You didn't talk about that at all or mention it in your presentation. So you didn't ask about where the patients are.
Because it was a retrospective study, and it was a radiological
usual,
observations. It was a radiological. I was, when I start to observe, okay, these
you already had
signs,
it. Yeah,
I made that group of WhatsApp, if you remember, and I start to
collecting.
present case by case in the group and ask for help. Okay, let us
identify.
If you remember, let us do study about this phenomena. Let us do. By the end of the year, I decided just to collect what I have seen and at least to raise the radiological observation for further studies.
Okay. Then it's clear.
I will not find the from where the patient coming in the radiology report, definitely.
Definitely it is all a multifactorial. It is multifactorial, and I think the impression, you see, Muna, it's all impressions in Sudan because we have been working for some time, and then you feel something, but of course you have to base it on research and data. But the tumor being more aggressive, coming in younger females, and presenting late. These are all features. We get into trouble when we go and do the research I usually do with students who need to do it, the registrars. So what happens, we see something and we want to investigate it, but because we don't have data and we are in the facilities far behind, and we see that our need is for something that is more basic. And again, another is that the higher studies, they have put down regulations for what they accept from students. And this is something which I have fought so many times, because we even don't have the normal incidence of cancer, different types of cancer in Sudan. And I think that is something they have to do before they go to immunohistochemistry and do genetic studies, which they are now all including, and it's very expensive for the candidates. We don't even have the basics. So why do you go to the higher things? So much data is missing. Maybe the explanation, as always, is multifactorial, but one of the main reasons is this late presentation of cases, which you mentioned in your research. All the cases are, a lot of the cases, they don't come.
No, Doctora Nadia, not all are coming late. Some are coming late, some are coming late, and some are rapidly progressing, as Dr. Ramona said. And as I mentioned in the early, that is why I start by overview about inflammatory carcinoma. My lecture I started before I'm going. I presented my study. I start by just overview about inflammatory, because I agree with Muna. I believe most of these cases were an inflammatory carcinoma, and if you was following me, most of the cases when I presented that on imaging having a typical features of inflammatory carcinoma. You see? So I agree with you and with Dr. Ramona regarding this issue. Regarding from where, while I'm doing some cases, usually I ask the patient from where. خلاص؟ I did not collect. This is دي خارج الباكج. لما كنت بشتغل البيشنت اعمل لهم التراساوند وكده. بنسأل البيشنت من وين؟ اغلب البيشنت من الشمالية.
Oh, okay. You see, let me tell you something. History. It's all history. When I started pathology, I started pathology actually because they didn't want me where I was doing ops and gynae. It was hospital policy. This strange policies that happened. So they said, where do you want to go? In the hospital. I said, okay, I'll go to my first choice, which you didn't give me first. I'll go to the lab. So I went to the lab actually as a medical officer. And I did my first part exam after working with طيب العشا, Allah yarham. Dr. طيب العشا, eventually I used to do just bone marrows. I started in the lab slowly, and then I started doing the bone marrows. I could read a bone marrow before I actually
could read. I read bone marrows before I could do peripheral blood flow, peripheral cogs. And the interesting thing at that time was that we had, if you all remember the incident in the Shemaliya, we suddenly had such high numbers of leukemia coming from the north.
Yes, yes.
So
yes.
we always get back to that point.
we know that الشمالية عشان a lot of يعني الحاجات البوليتيكال اللي بتتكلم عنها منى إنه an area يعني معروف إنه الاريا بتاعت
الإشعاع اندفن فيها الإشعاع.
Yeah, that was the time when we had leukemias. Then later, of course, years later, that was my start. Years later, we started getting solid tumors.
Okay.
Somehow we always slip back into politics. Okay, let's stop on that, and I think
yeah,
give the chance to Aida.
Yeah, it's better to stop politics. Yeah.
Okay, thank you, Dr.
السلام عليكم
دكتورة عايدة تفضلي.
السلام عليكم دكتورة باب، دكتورة وشاح، دكتورة نادية، دكتورة منى، وكل الحضور. السلام عليكم.
السلام.
نهنيكم على اليوم الجميل ده، ويعني ما شاء الله يعني كل البيبرز وكل الحاجات جميلة جدا جدا. بنشكر الجميع. دكتورة باب، البيبر والله very interesting، وأنا كان عندي observation عن في حاجة كنت I observed يعني بفتكر إنها very characteristic للسودانيز patients برضو، ويعني إن شاء الله إذا السودان ده رجع والأمور رجعت طبيعية زي ما كانت، إنه الناس تفتش الأسباب شنو. يعني أنا كنت لاحظت إنه العيانة لو حصل لها recurrence even after a long time يعني بيحصل في الكونترالاترال axillary lymph node. يعني دي حاجة كانت غريبة جدا جدا. يعني كنت يعني بلقى إنه في الكونترالاترال axillary lymph node بيحصل لها recurrence. Why? No answer. In your series, Dr. Rabab, you said إنه most of the patient a tumor في the upper outer quadrant. So anatomically يعني how does it come to cross medially؟ يعني لو قلنا لو كانت التيومرز دي في الميديال part of the breast ممكن نقول through the internal mammary، ممكن نقول through any channel of lymphatic spread. So I think there is a phenomena which we should study. مما انت طرحتي الكلام بتاع الكونترالاترال بريست كانسر ده، I went and researched in the literature زي ما قلتي very rare cases، لكن لقيت paper في من الميموريال فرونت.
Could you please raise your voice؟
سامعني؟
Could you raise your...
قلت لك مما يعني دكتورة رباب طرحت الفكرة بتاعت يعني this condition. I went and I searched in the literature and I found that there is a paper written from the Memorial Sloan Kettering Hospital about bilateral breast cancer, and they think as you agree Dr. Rabab and Dr. Muna, they think it's some sort of metastasis. It is some sort of metastasis. It metastasizes from the right breast to the, or from the left to the right, or from the right to the left, some sort of metastasis. But they found a genetic correlation. They found a genetic correlation, and they found a mutation. So I think if we can retrieve the data of your patient and we search about the genetic, and if we found any genetic mutation which can communicate between the patients, that would be great. So it's a very great paper.
أغلبهم يا دكتور من غير مقاطعة للأسف يا مستر، أغلبهم مشوا المقابر، الله يرحمهم ويحسن
ايوه ما هي لانها it's some sort of a late condition، يعني some sort of late condition زي ما قلت لك it's some sort يعني that paper I found
هي combination يا دكتورة عايدة، أنا to me it is a combination. خلاص بليت وأجريسيف. يعني أنا my observation
أنا حاسة جاياكي في الكلام يا دكتورة باب إنه we should برضو have immunological search. عيانينكم ديل يعني شفتوا كان الهيرتو فيهم كان studied الهيرتو جين كان studied في البيشنتس حقينكم ديل، ولا كانوا قبل الإيرا بتاعت الناس بتعمل الاميونوهيستوكيمستري؟ ما عارفة، لكن أفتكر there is some immunological point of view، يعني some immunological point. This is regarding the paper of دكتورة رباب. عندي سؤال
عشان ما انسى ارد لك على دي واسال اللي بعديها ارد لك عليه برضه. بالريجارد يلا انا قلت لك لو لاحظتي انه انا عشان اعرف انه البيشنتس انه proven to be cancer، خلاص اللي احنا ما كان ده راديولوجيكال دايجنوزيس. طيب احنا كنت باخد التليفونات بتاعت البيشنت، خلاص، وبتواصل معاهم تليفونيا، بس بعرف من المريضة يعني جزء بسيط أنا وصلني الهيستوباس نفسه، خلاص، بالتلفون، لكن الماجوريتي عرفت منها إنها والله أيوة هي بدت الكيماوي أو هي عملت ماستكتومي أو هي خلاص proven to be breast cancer. خلاص، لكن أنا يعني ما يعني لكن ده في 2022 كان في بيعملوا الإيميونولوجي. يعني بعض البيشنت بيجوا بعرف انه اساسا هم يعني حتى واحده من البيشنت اللي انا بريزنتد كانت لومينال بي كيس، خلاص. دي واحده من البريزنتد كيسز تقريبا ولا اللي ذكرناها ولا حاجه زي دي. فشنو في بعض منهم بيرسلوا لي الهيستوباس، طيب، في التلفون في الواتساب، لكن الأغلبية ما برسلوا لي، بس بتقول لي والله أيوة بدأت علاج في الذرة وادوني الكيماوي، أو والله مشيت لدكتورة عايدة عملت لي شالت لي الثدي. خلاص أنا عرفت إنه مشيت لدكتورة عايدة وشالت لها الثدي، معناه proven to be breast cancer. خلاص، فيلا أنا ما عندي
I think إنه يعني في recommendations حقتكم تكون في إنه further study إنه to include الهيستوباثولوجي.
ما سمعت الريكومنديشن بتاعتنا، نرجعها تاني ما مشكلة.
لا سمعتها لكن I mean إنه يعني يكون في recommendation لstudy إنه يكون فيها الاميونوهيستوكيمستري ويكون فيها الهيستوباثولوجي ويكون فيها الجيناتيك، study. إن شاء الله البلد ترجع يا رباب ويكون عندنا مقدرة إنه نعمل ريسيرش
بإذن الله.
إن شاء الله.
مساعدة إن شاء الله. مساعدة كان قبل عندك سؤال لدكتورة نادية، صح؟ معلش أنا ما شفته إلا بعد ما طلعنا البريك.
أنا في الحقيقة الصباحية كان بس عندي شغلة كده. I joined من الصباح، حضرت معاكم من قبل مريت من دكتورة
فعلا
أمل.
كنت قاعدة من البداية.
أيوة. هو شيرد هنا شيرد ولا انشيرد البرزنتيشن؟
الريكومنديشن شيرد شايفينها.
بس نخلي الريكومنديشن دي كده عشان إذا في إضافة بعد ذاك، إذا في حاجة هنا ما مكتوبة نسجلها ماله. يعني إذا في واحدة من الريكومنديشن
قصدي لك في الاستاديز الفاتت الناس لقيت انه في جيناتيك predisposition، وسنس انك انت اشتغلتي في حتت كثيره برا السودان we don't recognize this, so we should put a part of the genetic studies ولا genetic mutation in our recommendation، على اساس انه نعرف انه في genetic predisposition، في genetic mutation، what's going on. يعني
you are right yes. أنا طبعا يمكن ما كتبت specifically للجيناتيك، يس نكتبها ماله، لكن أنا قلت إنه الفينومينا دي it is related to the Sudanese ladies، يعني حاجة related للسودانيز ladies. طيب فيها جانب الأجريشن of the cancer itself، خلاص، ده one issue، والبريزنس البريزنس بتاعت الليمفاتيك الموجوده في الليمفاتيك بلاكسس القاعده ميديالي دي the other point. فهي ثيوري it is a phenomena يعني محتاجه انه الناس تشوف الكونتريبيوتنج فاكتورز بتاعتها شنو، سواء كانت جيناتيكس وكانت يعني whatever the cause and to see and to look for this اسمها شنو اعملوا lymphocytography mapping حتى انه هل اذا في فاريانت، اذا فعلا في lymphatic variants موجوده حتكون موجوده، اذا ما في معناها this is just lymphogenesis. But why lymphogenesis يعني selectively taking certain place for all Sudanese ladies؟ يعني كل البوزيتيف cases عندهم at the same location. This is the question.
ايوه طبعا حكايه انه البريست كانسر اجريسيف في البلاك ويمن دي طبعا حاجه يعني نون في كل الاستاديز. فزي ما قلت لك افتكر we need الجينيتيك. دكتورة نادية, we enjoyed very much your lecture. You spent a long time in preparation and very good presentation. Excellent. I put a question in the Dropbox, but I don't know if you see it. If you saw it, it is about the number of the study of lymph nodes. Usually we have some conflict with the histopathologist about the number of lymph nodes. We feel that we took lymph nodes which has been mislooked. So is there any effect of the type of the solution you use to dissolve the fats around the lymph nodes?
I don't use it.
I heard at your presentation you said that you palpate the lymph nodes before you examine it. So sometimes it's not palpable. The lymph nodes were not palpable. So my question around this.
It's not like your palpation, ya Aida. I have the specimen in front of me. And the first thing that when the specimen comes to the lab, you do sectioning so that you get good fixation. Like مثلا المركز القومي للأورام في القاهرة, they cut fresh. We first put, as it comes from the lab, from the theater, it is put into formalin, and then when it comes to us in the lab, we open it, slice it, so that we get good fixation, and then next day or day after, then we start grossing. So you see there are different methods of doing it. Like المركز القومي لأنه هو بيشتغل 3 shifts during the 24 hours. They do grossing on fresh specimens. And because they are in the same center, the theaters are there, their lab is there, and they work 24 hours. So I have seen fresh specimen. مثلا التكنيك هنا, when the fat is fresh, you can spread it out on your cutting board, which is usually wood. And when there is a technique where you just spread, because you have slices now, like more than, it should be less than 1 centimeter, and a half centimeter slices. And then when you are in the axillary fat, for example, you spread the slide and it is soft fat still. So because it's fresh, and you can just pass the butt of your
الصوت بعيد يا دكتورة نادية. I'm very interesting to hear.
You spread, you use the butt of your knife or the scalpel that you are working with. You spread the fat, actually like moves out of the tissue, and then you get on part of the lymph nodes, and you can put them up. I have seen this, it's wonderful. But the system in Sudan is different because of our heat, and because the patient has to pay all the other things. The patient actually is moving around the specimen. So we all put our specimens in formalin. Now, once the specimen is in formalin and it comes to us, we make sure we open it and we have it in formalin. So actually, we are palpating our slices. Did you get this, Aida?
لا والله ما سمعتك، قلت شنو؟
قلت لك الحاجة اللي بنعمل لها palpation هي is a slice which is half a centimeter
يعني اوكي
because I have a specimen that was open and the specimen has been in formalin. Now being in formalin,
and so you go directly and cut it. Okay.
We don't directly cut it. We cut it once it comes to the lab. We open it and then we cut it 24 to 48 hours later when it is fixed. Once it is fixed, the fat is firm, not as soft as you know it when it is inserted. And then we palpate the sections that's why it is grossing is a very meticulous thing and it should be done without interruptions in a cool room. أنا دايما بقول للregistrars, you must have had your food, you must stop to drink the hot climate in Sudan because you must be
able to concentrate.
Slices
okay.
and for the lymph nodes. مع الضغط الحاصلة عندنا في السودان, I'm sure they are missing it. And that is why it depends on the experience and the surroundings when you are crossing.
Okay.
نورس زميلاتنا الإيجيبشن أنا شفت منهم جبال طلعوا ولا
أيوة
والله كانوا موجودين وحسي في بروف أم الحجازي موجودة
أم الحجازي موجودة. أيوة أنا هسه كنت عايزة
وكانوا قاعدين لغاية نهاية البرزنتيشن.
نسمع منهم كنا محتاجين نسمع منهم بالنسبة الكومنت على الكيسز لأنه هم طبعا بيشوفوا حالات كتيرة وكده.
أيوة بروف أم الحجازي قاعدة بس let me check.
بروف أمل
حسي قبل دقيقتين كانت موجودة. I can't see her now.
مالك
literally قبل دقيقتين كانت موجودة.
ايوه انا ذاتي كنت بعاين في البارتيسيبانت كنت شايفاها موجودة وعايزة اقول لك افتحي لها المايك.
بس هم كلهم بروفيسور رشا كانت حاضرة, دكتورة ميريت كانت حاضرة, دكتورة أمل حجازي برضو كانت حاضرة لغاية النهاية.
كنا محتاجين نسمع منهم their comment يعني
فعلا
الكومنت بتاعهم هنا مهم شديد. عندنا زمن
أيوة.
ولا خلص؟
احنا والله خلصنا.
احنا اتجاوزنا الزمن اصلا.
كنت عايزه اشوف انه مريت اذا كان نقاشنا اخرها يعني اتكلمنا كثير في حاجات بتخص السودان. دايره اشوف
هي كانت والله كانت قاعده
اي لانه نحن دخلنا
لغايه
في
نهايه لا كانت قاعده لغايه ما انت قربت تخلصي البرزنتيشن حقي. كانت موجوده كلهم كانوا موجودين حتى بروف رشا. لكن لأن الوقت غالبا يتاخر في مصر يمكن يكونوا طالعين من الشغل وكده لانهم ليله شغالين.
يلا اوكي. هم كان طبعا كراديولوجيست بالنسبه لهم مهم انه نسمع منه اذا مريت قالت لي انا وريت الكيس قبل كده, وريت الكيسز دي قبل كده, واسا لما رسلت المسجه رسلتها في الجروبات دي برضه رسلتها ليها. فقالت لي بعد ما زمان وريتيني لي انا عملت سيرش, واسا لما رسلتيها لي ورسلتها للشباب في الجمعيه برضه عملت سيرش ف I didn't find the similar case يعني ما قلت لي ما لقيت حالة شبيهة. وما هي ما
شافت اليونيكنس حقت الفينومينا دي.
وهي ما هي لنفسها ما حصل قابلتها
فعلا كبير قالت كده.
اي وثانيا قالت لي عملت سيرش ما لقيت. فكنت حابة اسمع من دكتورة امل ودكتورة رشا بالذات, انه دكتورة امل دكتورة امل في الاسكندرية ودكتورة رشا في القاهرة اذا مرت عليهم. هي الفكرة إنه الناس to be aware about it والمسج برضو بالنسبة للناس اللي بتشتغل بريست. أهم حاجة في التكنيك while you are scanning a Sudanese lady don't raise the probe between the two sides. وانت scanning طوالي continuous ما ترفع البروب زي ما زمان بقول لكم في الأكزيلا برضو وانت ماشي على الأكزيلا خلاص. الاكزيلاري تيل ما ترفع البروب لانه كثير بيحصل ميسنج ان بتوين, يعني واحد ما يكمل الاكزيلاري تيل وجامب يشيل البروب ويمشي على الاكزيلا. هي ما يتمس هنا ليجنز تمشي كونتينيوسلي بنفس الصوره في الميد لاين تمشي كونتينيوسلي للكونترالاترال بريس at all levels يعني ما في النص في حته واحده، لانه ممكن تلقاه على higher level وممكن تلقاه على lower level وممكن تلقاه
or in the middle, yeah,
at the
in between.
يعني exactly at the middle. Okay. between الchest anterior to the sternum the subcutaneous تبدا السترنم من فوق لين تحت وتمشي من one breast to the other breast searching for any edema, skin thickening, abnormal vascularity, lesions, whatever we have seen. يعني دي الحاجات اللي احنا كلها شفناها يعني. فإذا ما في تاني سؤال is okay. قولوا الدكتورة وشاح.
رسلت لدكتورة ميريت فممكن نستنى شوية.
طيب كويس، ما في مشكلة، ما في مشكلة.
هتدخل قالت يعني هاد
أيوة بس waiting for her response.
يعني ما شافت الرسالة لسه.
اعملي لها
دخلت.
You are welcome.
أنا بالنسبة لي يا رباب ما شفتها هنا خالص، مما وريتيني لها قاعدة أشوف في الام ارز ما لقيتها.
هاي قلت لي جبال، قلت لي انا ببحث بقيت من عرفت الصايم بقيت كله MRI بفتش عليها انه اشوفها ما لقيت زيها، وقبل كده ما لقيتي يعني هسه بعد شوف
لا ما لقيت.
انا وريتك
لا ما لقيتها. لا ما لقيتها.
لكن الان شفت الكيسز كلها.
ايوه يا
في الالتراساوند في الماموجرافي في اي حاجه شفتي كيسز زي دي في MRI؟
لا ما لاحظت، لكن نحن بنعمل الميد لاين دائما يعني ما في بروتوكول انه we do between the breast في screening ultrasound.
لا لكن اذا هي في MRI كان حتبين دكتوره
مريم. ايوه غير كده ممكن في الميديال بريست برضه حتبين كانت.
صح. you are right you are right دكتوره مريت. we are waiting for your comment.
انا اسفه ان انا الساعه الاخيره ما قدرتش ان انا اكمل، عشان كده انا داخله دلوقتي فجأة، فانا مش عارفه احنا في نص النقاش.
لا ولا يهمك ولا يهمك، ما في مشكله اكيد.
لا
ما
ولا يهمك عادي،
شغاله اليوم كله كده.
كان يوم الصراحه طويل، ربنا يقويكم يعني ويقدركم دايما كده، كان يوم فعلا فول داي
يتقبل
يعني.
من الجميع
يا رب. معلش انا كان يعني بتابع وانا في الشغل
لا ما في مشكله. فانت الجزء الاخير ده بتاع الاستدي خلاص، دي الستاتستيكال داتا، لكن انا في الاول اي بريزنت الكيسز.
انا شفت الكيسز. ايوه انا شفت الكيسز.
يلا ها ادينا يور كومنت على الكيسز ووجهة نظرك.
هي فعلا يونيك. انا حقيقي ما يعني I didn't encounter او اشوف في الليتريتشر حاجه مشابهه يعني، فكنت بقترح ان احنا فعلا نفتحها للنقاش عندنا برضه في EGSBI، ونحاول ان احنا يعني نعمل انفيتيشن لكذا سبيشاليتي يكونوا من كذا حته يعني في over the world يعني.
An oncologist, I think, is very important to be involved in this discussion.
مش عارفه اذا كانت السمر اللي معانا، انتي السمر اللي معانا ولا دكتوره امل؟
منو؟
لا سمر. بس مجهود يعني كبير جدا ومجهود رائع والله، ويعني سيمبوزيوم يعني very precious بجد يعني. انتوا في تسجيل صح؟
ايوه في تسجيل، ما مشكله.
والله
يا
يا
ريت
دكتور
والله.
ما كانش هيكون كده لولا وجودكم معانا.
لا ازاي، لا والله احنا يعني
حليتوه طبعا ديفينتلي، خطيت يعني زدتوه سكر زي ما قالوا.
حبيبتي ميرسي.
دكتور
معلش انا عشان بس انا يعني كان الساعه الاخيره كده ما كانش نافع اركز خالص، فانا معلش هشوف الريكورد الاخير واقول لك برضو رايي يعني.
تمام ما في مشكله، لكن قال لها انك انت يو اجري انها هي زي يونيك فينومينا.
طبعا.
ما هو طبعا نحن بدينا سيرش، لكن انتوا طبعا برضه يو ار براكتسينج.
لا انا عشان انا كمان يعني بالذات يعني مثلا كندا عشان فيها دايفرستي كتيره من كل الريسز، فكان حتى هشوف حاجه مشابهه او كده انا مش I don't recall خالص أو أشوف حاجة زي كده أو متكررة كده. need to be يعني
نعرفك بدكتورة هبة أنا الآن في كندا بالمناسبة، دي برضه
مين
شغالة في
بقى
كندا
مين
وبقبلك على
اللي في كندا؟
هبة
أهلا دكتورة
دكتورة
مينات، أنا في كالجاري.
أهلا هبة
وسهلا.
حبيبي. فين
قدمت بعدك
في أي ولاية في أي
أنا
province؟
أنا في ألبرتا في
ألبرتا.
University of Calgary.
ممتاز
بس
لكن
عملت
ما هي
الفيلوشيب
مكان.
في ماكماستر.
ممتاز. ربنا يوفقك يا رب.
تسلمي، شكرا، وشكرا على البرزنتيشن الجميل. تسلمي.
لا أنا اللي ميرسي على إن أنتوا اديتونا الفرصة، والبريست ايمجينج بالذات من أكتر السبيشاليتيز اللي يعني كل ما بتشوفي experience مختلفة من بلاد مختلفة بريسز مختلفة بيديكي أكتر depth في النولج والمعلومات.
أيوه
فإن شاء الله تجمعي لنا برضو حالات من عندك كده ونناقش.
دكتورة
أيوة إن شاء الله.
دكتورة هبة قدمت بعدك، يمكن ما تكوني اسم شنو ده.
أنا والله السبت ده بيبقى يوم صعب جدا.
أيوة لا ما في مشكلة، قدمت حالات جميلة برضو، لكن ما مشكلة.
لا هشوف إن شاء الله في التسجيل.
برسل لك الرابط في التسجيل إن شاء الله.
وتنورونا بقى كلكم في يعني الويبينارز بتاعت EGSBI
إن شاء الله
نرتبها إن شاء الله. نرتب مع دكتورة رباب
بإذن الله. شكرا على الدعوة.
دكتورة مريت، ومعليش يعني تعبناكم وانتوا اصلا
لا خالص والله. انا يعني لو كان بس يعني حتى اليوم نقدر ان احنا نكمل والله كنا كملنا، بس
لا
كان كل حد مرتبط بحاجة.
دكتورة أمل ودكتورة رشا كنا
دكتورة
حابين.
أمل في البرايفت بتاعها في الكلينيك، ودكتورة رشا عندها البورد بتاع بهية وانا كنت في الشغل. فلا والله لو يعني احنا كنا مستمتعين جدا، وكان نفسنا ان احنا نكمل اليوم كله معاكم.
برضو ما قصرتوا يعني، قدمتوا ما في وسعكم، وكان شيء جميل وأدى طعم يعني مميز للسيمبوزيوم. وإن شاء الله نلتقي في أوقات إن شاء الله طيبة.
إن شاء الله يعني كل الشكر لكل اللي موجودين بجد. يعني ميرسي كتير على المجهود ده، وميرسي على استضافتكم لينا.
الله يكرمك، الله يديك العافية.
شرفتونا يا دكتورة.
شرفتونا. تفضلي خدي راحتك. الله يكرمك يا رب. شكرا لك حبيبة. الله
شكرا
يكرمك
يا جماعة، شكرا لكم يا رباب. أنا ذاتي أستأذن المغرب راح علي كلكم.
تفضلي. أنا شايفة هنا غسان الأمين. غسان يا منى.
أيوة
مستر غسان، اسمه مستر غسان الأمين.
أيوة غسان الأمين.
مستر غسان اتفضل.
والله ازيكم؟ سامعني؟
صوتك بعيد شوية يا مستر، لكن سامعينه بس هو بعيد شوية.
هو أنا من قبالي أنا معاكم، لكن لأنه أنا في الشارع ما مسافر وضايع في شوارع نيويورك كده، فما كنت ما أخش أعمل إزعاج. It was really nice presentation. يعني I think we had discussion before, Dr. Rabal, about the cases. It's amazing, and it's pointing to new findings. عادة يعني لأنه so far إحنا all the treatments are guided by guidelines based on studies done on completely different populations. I don't know if this is proven in some population in Sudan. Maybe it can change the management. If you have inflammatory breast cancer, you need to treat both breasts as one organ. I think this is very important. And as everybody said, more studies are needed to prove this finding and to find out which population, like the demographics, the genetics, as Aida said. And after that, it can change the management in this population. So thanks a lot for the observation and the idea and the study, the respective study. And let's think forward what to do next. Thank you all for the nice symposium or the webinar. ان شاء الله تكون سامعيني، بس لانه انا الجوطه شديده هنا.
سامعينك
وكتر
سامعينك
خيركم
مستر. يديك العافية و thank you so much
ومشكورين
for
جدا
attending.
على الحاجات دي.
السلام عليكم
Thank you,
مستر
thank
غسان،
you.
سامعينك.
مستر شكرا لك انت يا مستر، شكرا كتر خيرك.
لا شكرا لكم، تسلموا تسلموا.
الله يسلمك يا رب.
طيب إذا ما في إضافة تانية ممكن نختم، ولا في زول عنده كلام؟
إذا في الحضور في أي حد عنده سؤال you are welcome. ما في بعد ذاك ممكن نختم. في حد عنده أي استفسار، عنده سؤال بخصوص الأشياء دي؟ ما في. ما في حد
Okay.
سأل. It's okay.
Okay. Now we come to the close of this enriching conference. I would like to express my heartfelt gratitude to all our esteemed speakers, moderators, and attendees. Your dedication and insightful contribution have made this event a great success. We began our day, in summary, we began our day with warm welcoming speech from Prof. Abdullah Jabir, and I was honored by welcoming our colleagues from Egyptian Society of Breast Imaging. Then we got engaged in our scientific program. Professor Kamal, as the first speaker, provided us with a valuable discussion on DCIS and the radiologist role in breast cancer tumor board, followed by Prof. Amal Hijazi, who offered a detailed multimodality imaging review of HER2-positive breast cancer undergoing neoadjuvant chemotherapy. After a short break, Dr. Merit enlightened us with her insights and experience on fat necrosis with an interesting collection of cases. Dr. Nadia Dawi then addressed an important and interesting topic about the pathological response and the dilemma of lymph nodes after neoadjuvant treatment. This was followed by Dr. Hiba Mohamed Osman's compelling and interesting case presentation series, which added a practical perspective to our scientific exchange. And later in the evening, Dr. Rabab presented her findings about the features of unexpected midline lymphatic spread of breast cancer in Sudanese women, expanding our understanding of this unique imaging challenges in our country. Throughout the day, we benefit from lively discussions led by our dedicated moderators, Dr. Nouras and Dr. Ilaf, who ensured the seamless interactions and engagement. A special thanks to everyone involved, our distinguished speakers, panelists, and audience for your active participation. Your contributions have made this conference a truly valuable learning experience. We thank also all those who shared in the discussion, Dr. Muna, Dr. Aida, Dr. Nadia, and Mr. Ghassan, Dr. Marid, and all who has an input in this day. Now,
Dr. Hiba, yes.
And Dr. Hiba, yes, Dr. Hiba.
Yes.
We look forward to future collaborations and continued advancement in breast imaging. Thank you all, and we hope to see you again in our upcoming events. Thank you very much and goodbye. السلام عليكم ورحمة الله.
عليكم السلام يا وشاح، دعناكم الله.
الله يبارك فيك دكتورة عايدة، الله يسلمك.
الله يسلمك. السلام عليكم جميعا.
الله يبارك فيك.
عليكم السلام.
الله يديك العافية. في أمان الله. عليكم السلام.